Sri Shakti is the embodiment of 5 elements: the sky, the earth, and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air, and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of
Venkatesh,
Video back, please.
video has stopped.
1 second, ma'am.
And this has to be made two times, right? Video?
Just play it.
Leela,
Yes, sir. Good morning, sir.
good morning. Is it okay if I join again at 11?
Yes, sir. 11:30 is the inauguration function.
so I'll
we
join
would be
around
happy if you can be with us.
No, I am with you.
Okay, sir.
But I'll be live. You will see me only when I am supposed to be there. Okay?
Bapu, good morning.
Sure, sir. Sure, sir.
Bapu, good morning.
Dear friends, Foxians and women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of FOGSI, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Sri Shakti as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization.
Sri Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth, and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air, and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond FOGSI's commitment towards women's healthcare. FOGSI for all, always.
FOGSI for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dhira to stop violence against women. FOGSI for all, always will strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman.
Dr. Shanta Kumari with the theme FOGSI for all always and Dhira Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman, Swasth Mahila.
Violence against women. I think it's a silent pandemic, and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dhira, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women.
I completely support her vision and mission as President FOGSI and also especially support her campaign, Dhira Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the President of FOGSI, declare my commitment towards women's health and safety.
A very good morning to all of you. On behalf of our President, Dr. S. Shanta Kumari, our Secretary General, Dr. Madhuri Patel, and the Vice Presidents in charge, Dr. Bipin Pandit and Dr. Fessy Lewis, it is my privilege to welcome one and all of you to this FOGSI Fetus Day celebration today on 31st October 2021. On behalf of 3 committees who've come together and put their efforts of getting this information regarding the fetus across all the esteemed audience here. Dr. Bela Bhatt from the Imaging Science Committee, Dr. Mandakini Pradhan from the Fetal Medicine and Genetics Committee, and myself from the Perinatology Committee of FOGSI, welcome one and all of you into the FOGSI Fetus Day with the theme, The Fetus Says, Do You Know Me Well Enough? So we just learned how all the 5 elements in nature come together and make life possible. The fetus is that first form of life which we acknowledge in our clinical medicine. And today is the day to look at all the aspects of fetal medicine and get everybody clear their doubts regarding this very enigmatic topic. To start the proceedings, I would welcome on stage Dr. Gurpreet Sandhu. She will be the Master of Ceremony for the first session. Dr. Gurpreet Sandhu is currently the Secretary of the Aurangabad Obs and Gynae Society and has a very, very busy schedule with her clinical practice at the MSS Multispeciality Hospital. Extremely academic, having presented several papers at national and international forums, published articles in the FOGSI platforms and elsewhere. She's an executive committee member of the Imaging Science Committee and a joint organizing secretary of the Sonocon 2019 at Aurangabad. Dr. Gurpreet Sandhu, the stage is all yours.
Am I audible, madam?
Yes.
Yes, thank you so much. Thank you so much for that elaborate reading of my CV. Without wasting much time, I would like to introduce the chairperson for the next session. I'm privileged to introduce Dr. Mumtaz, who's the first chairperson here. She's Professor, Department of Obstetrics and Gynecology, MES.
Can
Medical
we have
College.
slide of Dr. Mumtaz?
Yes. MES Medical College, Periyanthal, Kerala. She has been awarded many awards. Dr. Kalyani Kutty Amma Memorial Gold Medal, All Kerala Conference of Obs and Gynae. Dr. Thampan Memorial Gold Medal, All Kerala Conference of Obs and Gynae. Dr. Amarendra Nath Dan Prize for Best MCH Paper, All India Conference of Obs and Gynae, Bangalore. Kerala Federation of Obs and Gynae President's Gold Medal for the Best Paper, All Kerala Conference of Obs and Gynae 2019, and Wonder Foxine Award, Mumbai 2019. Next, we have with us Dr. Neelam Chajed, Madam. She's trained in Obs and Gynae from SAIT GS Medical College, Mumbai, member of Royal College of Obstetrician and Gynecologists. master's degree in maternal and fetal medicine from University of Barcelona, fellowship in fetal medicine from Mediscan Systems, Chennai, for the advanced training, North Cumbria University Hospital, NHS, UK, RCOG international faculty for teaching on the MRCOG Enhanced Revision Program, RCOG authorized examiner for MRCOG Part 3 practical exam, accredited by Fetal Medicine Foundation, FMF UK, for performing NT and Dopplers, invited as speakers in many regional and national conferences. With a long list of their achievements, I would like to welcome the chairpersons for the first session. Welcome. Over to you, madam.
Thank you, Dr. Gurpreet, for those kind words. And thank you, Chinmay ma'am, for this wonderful opportunity. And today we are celebrating the FOGSI Fetus Day under the three chairpersons and also the FOGSI chairperson's guidance. So now it is my privilege to introduce to you Dr. Atul Ganatra. Sir is the Vice President of FOGSI. We all know that 2021 Sir is Vice President. Can I have the slide, please? Sir is also the Joint Secretary of IAG and the Chairperson of MTP Committee, MOGS, and also the Managing Committee member of MOGS. Sir is the Director of R.J. Ganatra Nursing Home and the Progeny IVF Center, and also the endoscopist at Fortis Hospital and Jupiter Hospitals. Over to you, sir, for your talk on preconceptional health.
Thank you, Dr. Mumtaz, Dr. Neelam, Bela, Chinmay, for inviting me here as an opening batsman here. The Indian World Cup team doesn't do very well in the opening. I think we lost 2 wickets in the first 15 deliveries, but I'll try and do as much justice as I can. I have to universally apologize for being a very lazy WhatsApp person, so I hope I will be excused. Is my slideshow seen?
Yes, sir. Please enlarge it. Put it in the slideshow.
So thank you very much to the entire team of Dr. Shanta Kumari, Madhuri Patel, Bipin, Pesi, Dr. Mandakini, Bela, Chinmay, and the two doyens of FOGSI, Dr. P.K. Shah, and it was great seeing him early in the morning, and Dr. Alka Kaplani. Our food should be our medicine, and our medicine should be our food. And this is what Hippocrates said a few hundred years ago, and I think we've forgotten that very, very fast. Medical causes of maternal deaths in India, as you can see here, there are many, many conditions which cause medical maternal mortality. And I think these are some points that we need to keep in mind when we're talking about preconceptional care. Diarrhea even today causes neonatal deaths in India, preterm deliveries, congenital infection, tetanus. These are treatable and preventable causes of death. If you look at these newspaper clippings, it says for every woman who dies in pregnancy, 9 escape death. Jaundice and typhoid still cause maternal deaths in India. Hepatitis is a silent killer. And when I was a resident, at least 9 patients died in a week with hepatitis E when we had no treatment. We even today do not have any treatment. I think the largest amount of blood transfusion I've given is to a patient who had hepatitis E, about 130 bags of blood and blood products. So it's not 9 months, it's actually 12 months that we need to look into preconception and pregnancy care, of course, nutrition in pregnancy. And we need to optimize health. And this is no rocket science. WHO mentioned it many years ago. You're eating with your unborn child and they feel that energy. I think this is what Lindsay Matthews said. And this is so important. And I keep telling my patients, when you sit with your plate to have lunch, dinner, or breakfast, imagine, what am I eating? Is it good for my child? I think that's the kind of mental policy that we must follow. WHO has come out with a beautiful manual which talks about preconception care, maternal mortality, and childhood and perinatal mortality. Let us see some facts now. 4 out of 10 women report that their pregnancies were unplanned. 50% of perinatal deaths are higher among babies and adolescent mothers. Up to 10% of pregnancies among women with untreated gonococcal infection result in perinatal death. Maternal undernutrition and iron deficiency and anemia cause about 20% of maternal mortality. Fetal genital mutilation, again, a very, very underreported and under-discussed topic, increases neonatal death by about 15 to 55%. In the absence of interventions, rates of HIV transmission from mother to child are between 15 to 45%. So I think this is extremely important that we pick up these patients who are HIV positive before they develop full-blown AIDS. So what is our aim in preconceptional care? Our aim is the provision of biomedical, behavioral, and social health interventions to women couples before conception occurs. Mind you, I repeat, before conception occurs, and to improve the health status and reducing behaviors and individual environmental factors that could contribute to poor maternal and child outcomes. So it's not only a short-term gain, it's basically a long-term gain. These are some aspects that we need to discuss: child maternal mortality, birth defects, preterm birth, neonatal hypoglycemia, goiter, hypothyroidism, and I can go on and on. Diabetes, vertical transmission of HIV, underweight and stunting, reduced breastfeeding, diarrhea. And we need to address the whole issue as a package: nutritional conditions, vaccines, genetic condition, environmental health, fetal genital mutilation, fertility, too early unwanted successful pregnancies, interpersonal violence, psychoactive substance use, tobacco use, mental health. Is the woman really prepared for a pregnancy? I think in India, most patients get pregnant before they realize that they're ready for it. And what do we need to do? We need to screen for anemia. We need to supplement iron and folic acid. And government is doing a wonderful job by fortifying multivitamins with our food items, information, education, counseling, monitoring nutritional status. I'm not sure how many people spend time about nutrition with our patients. We just prescribe medication, folic acid, ultrasounds, double markers, NIPT, etc., etc. Screening for diabetes, management of diabetes. And management of diabetes is not about taking OHA or insulin. It's about the kind of diet plan. When I ask a patient who is a diabetic who comes to me for the first time, what do you have for breakfast? She says, I have idli, dosa, upma, poha. And these are things she's not supposed to have because they are predominantly carbs. And the CDC has come up with a fantastic chart, and I think Bela should get this out for FOGSI so that each of our gynecologist colleagues kind of starts ticking. They don't have to think, what am I going to talk to my patient? Tick these points as to have I discussed these with my patient when she comes to us with pre-pregnancy or preconceptional counseling. What are the benefits? We'll reduce an unintended pregnancy, prevent birth defects, prevent low birth weight, poor pregnancy outcome, prepare the woman, and promote family planning, of course. And who should go for it? I think everybody, especially those who've had a bad experience in the past pregnancy. So the target is from healthy mothers to healthy babies, but I think there is a time for a paradigm shift, a healthy woman to a healthy mother, and then we will have a healthy baby. So the woman has to be healthy before she becomes the mother. And this Barker's hypothesis proposed that adverse nutrition in early life, including prenatal as measured by body weight, increases susceptibility to a metabolic syndrome, which could be hypertension, dyslipidemia, coronary heart disease, obesity, and many others. So let's come to the first point, weight gain in pregnancy. I think the BMI, if the woman's BMI is less than 18.5, she must put on about 12 to 18 kg weight. And simultaneously, at the end of the spectrum, if she's more than 30, she should not put on more than 5 to 9 kg of weight, approximately 2 kg per month from the second trimester, or 1 kg in 15 days. Because obesity can cause birth defects, it can cause macrosomia, preterm birth, stillbirth, and I can go on and give a lecture on obesity. This is a very, very important slide, I think, which every gynecologist should discuss with the patient in the pre-pregnancy or in the first visit. Total caloric intake, 350 to 400, 45 to 60% carbs, protein intake, 60 grams per day. And I think all of you watching me today, look at your diet on a daily basis. I don't think we Indians consume more than 15 to 20 grams of protein. The bone, brain, and muscle of the baby requires protein, total fat intake. These are our low-carb vegetables, and I think charts like this should be given to our patients. We must get at least 3 servings of protein, 8 to 9 servings of whole grains, 7 servings of fruits and vegetables, 4 or 5 servings of dietary products, dairy products. Eat essential fats and limit high fat, high sugar, high sodium food. The lockdown has really come up very, very hard. Most women working from home, they keep munching Lays and whatnot, which is actually so high in sodium. And 9 out of 10, this is an article in Mumbai, 9 out of 10 patients have very, very low protein, though Mumbai can do a little better. And most of our patients are vegetarians. And I think this is a chart that we give all our patients as to what are your 10 best sources of protein. I don't think we consume even 2 of these if we don't really make an attempt. So I tell my patients, look at the next slide. Dal, curd, paneer, sprouts, mozzarella, cheese. These are our vegetarian proteins. So you must have either a paneer burji, or an anda burji, egg burji, sprouts, and the Gujarati khakra, a cheese paratha, or maybe a chicken curry. And a kind of one of these 5 items should be a part of every meal, because a bad diet can cause these following problems like premature birth, low birth weight, feeble and weak child, deformed babies, depression. Depression in the woman because she doesn't get enough protein. She gets tired. There is a lot of fatigue involved. And the ACOG and the app considers that these are some risks that we need to pick up also. Reproductive awareness, environmental toxins, nutrition, genetic causes, vaccination, very, very important. What do we need to do? We need to give them preconceptional folic acid and B12, test for rubella, seronegativity, diabetes, hypothyroidism, anemia, thalassemia. We need to find out if they are on any of these drugs, alcohol. We need to stop alcohol. We need to find out if their hepatitis B vaccinated, because organogenesis finishes by about 9 or 10 weeks, maybe max 12 weeks. So if we don't take care of this diet and their vaccination and the folic acid in the first preconceptional period to immediate post-conception, I think we'll have a higher incidence of a perinatal problem. Investigations, I don't think I need to go into the detail, but please see to it that the thalassemia profile, the thyroid function, rubella IgG, and the blood sugar is done. Vegetarians, we must see that their B12 levels are optimum. Rubella vaccination can be given 30 days prior to she attempting if she's Rh negative. And now the COVID vaccination, we must see to it that she finishes her vaccination. Even today, I have 5 patients who are there in the COVID ward, out of which 2 are on the ECMO ventilator. So COVID is not gone. And if a woman comes, I said, I would give her, at least a Covaxin so that she finishes in 28 days and then she gets pregnant, because once she's pregnant, we may not give it to her for the first 12 weeks. Vaccinations are recommended. We have the influenza vaccine. We could give them the Tdap at about 32 weeks. The thyroid, of course, we must remember that the thyroid range should not be more than 3.2 in either of the trimesters, though this study recommends in the American Thyroid Association a 2.5 in the first trimester. Anti-epileptic drugs can cause many defects, including the cleft lip and cleft palate, and that's not something that we need to be careful about. Multivitamins are a waste of time. So many patients come and ask us, can I take Herbalife? Can I take this particular medicine? These vitamins are absolutely of no use to us because they are a part of our diet. And I said, yes, you can take the Nutri-Life. It will benefit the company at least. Folic acid, 400 micrograms, extremely important. With the women with a previous history of a neural tube defect, of course, 5 milligrams folic acid is important. B12 intake, I think B12 and D3 are very, very underrated products, but B12 is extremely important. We know B12 deficiency can cause infertility, can cause recurrent pregnancy loss. Because of low B12 will cause a high homocysteine, and a high homocysteine will lead to thrombosis and fetal defects. Vitamin D, all adults, including pregnant and breastfeeding women, need 10 micrograms of vitamin. And I think instead of getting tests costing 3,000 rupees, B12 and D3, we must just supplement them with once a week D3 when they come to us in pregnancy. And I tell them take it every Sunday on an empty stomach so that we remember how to take it. We cannot stress enough about diabetes. And I said, it's not about taking medication. It's about the diet plan that is very, very important. Your diet has to be low in carbs. Anemia, the most important killer in our country, I think, low dietary intake of iron. menorrhagia, hookworm infestation, other nutrition deficiencies cause anemia. And we have to give them these charts as to which is your source of iron. Unfortunately, plant source of iron is poor, so we must give them these pictorial graphs about what iron supplements are all about. I think thalassemia, this is the moral responsibility of every gynecologist that we pick up thalassemia in our patients. And you can pick it up just by doing a CBC report. Remember, if the HB is low, the MCHC is normal, if the RBC count is normal, we are looking at thalassemia. You don't have to do that HbA2 levels, just you can do it if you want to confirm. I repeat, low HB, normal RBC or high RBC count, and a normal MCHC. This is what Dr. Agrawal has taught me 9 or 10 times. This is thalassemia. Smoking, very, very important that they stop smoking at least a couple of weeks before or months before pregnancy. Not allowed in pregnancy for sure. Alcohol is dangerous, and I think we must see to it that our patients, of course, they come and tell us now, can I have a little wine? Can I have a little vodka? Have a weekend party? It can cause a small size head, shorter average height, low birth weight, poor coordination, hyperactive behavior, poor memory, and I can go on and on. Others could be sexual counseling, personal hygiene. So many patients who come to us with fungal infection. Contraception has to start from preconception and has to go on to the post-delivery or postnatal period. Lactation, look at the nipple of the patient in the second trimester of patient so that you can treat the patient for flat nipples, vaccinations, thyroid function, drugs that they take, I repeat. So finally, friends, eat better, not less. That's very, very important. So I think this is the moral of the entire preconceptional planning. And never stop doing your best just because someone doesn't give you credit. You don't get paid to spend time with your patient. We are not lawyers. However, we need to see to it that we spend that extra 15, 20 minutes or employ a dietitian who will talk to them about it. And I think if you maintain a chart of the CDC, we will probably go through all the points when a patient comes to us at the first. Thank you very much for a patient hearing.
Thank you, Atul sir, for that wonderful talk. I must say you are a gentle and you gave a gentle and complete lecture on preconception care, that in a very good voice. Thank you for sharing the chart for preconception care so that we know whether we have missed out any points. We all know preconception health plays a very great role in achieving safe pregnancy and a healthy baby. And for many of us, it is just giving folic acid. Now, as sir told, we realize that it is not just that. It is that we should have a role in deciding when the woman should become pregnant. As sir rightly said, many become pregnant before they are mentally ready for it. So choosing the right time is important, especially when a woman has a medical disorder like an epilepsy or diabetes, hypertension, or some connective tissue disorders. But most of us get the only chance we get to see a patient before she becomes pregnant is in the postpartum period. That too, the further checkups in the postpartum period may not be that complete also. Like many a time we lose a track of the GDM and preeclampsia patients we have. So why don't they come for this checkup is one question we should ask ourselves, because many of them are unaware of the need. The parents do not know, and they are very hesitant to bring an unmarried girl to a gynae. So that problem is also there. So I think we should start with educating the parents. And I know sex education is coming up. It's going to be there in all the schools soon. Maybe a big way to go, but we should take the initiation or initiative step to achieve that. So a healthy girl should grow into a healthy woman, and that healthy woman should become a healthy pregnant mother. And what about the preconception health for men? Is it required? Sir, do you have anything to say about that preconception health in men?
Absolutely. I think B12, B3, sugar, thyroid, smoking, because a woman can become a passive smoker. Bila did not give me enough time, otherwise I would have narrated. I thought she was, kind of granting men कि आप लोगों को छोड़ दो. We will, just concentrate on the woman. But I think the man is equally responsible. And I keep joking with my patients, and I said, he should be on paternity leave, and whatever you eat, let him eat as well, so that he understands what the woman is going through. And I refuse to see a patient who comes to me for preconceptional counseling without the husband. If she comes with the mother-in-law stands outside. She doesn't come in unless I have to tell her that these are positive points and these are things that your daughter-in-law needs to eat. Because otherwise they will say have ghee, have butter, have laddus, but the nutritional value of these things is questionable. I think we in COVID times used to restrict our relatives, but if I don't have the husband with me, I do a video call with the husband while I'm talking to the wife, so he listens to what I'm trying to say. WhatsApp, COVID has taught us that much, that you can do a video call with the husband or the mother-in-law, because there are so many things. I mean, exercise is something which is so important. So many things that we need to discuss. The first consultation with a pre-conceptional counseling or the first antenatal visit has to be at least 40 minutes. We have to spend, it's not about doing a PV, it's not about checking just weight and blood pressure. Diet, I think, is the most important aspect that we need to discuss, because we are predominantly vegetarians in India, and I think our diet is very low in protein and B12. And I think if we look after these two aspects, I think we'll take care of a lot.
Thank you, sir. Thanks once again. We move on to the next session. Dr. Gupta.
Dr. Neelam will introduce the next.
Good morning, everyone. It gives me a great pleasure to introduce Professor Kushagrati Ghosh. He is a fellow of Royal College and has a RCOG diploma in advanced fetal ultrasound. He's also a professor in Obs and Gynae at the Kolkata Medical College, RKMPS. He's a director at the Institute of Fetal Medicine, Alipur, Kolkata, consultant in Obs and Gynae at Bhagirathi Neotia Hospitals. He is a clinical examiner for various undergraduate, postgraduate exams, MRCOG Part 3 examinations. He is also the past president of Bengal OBGYN Society and has been a chair for the AICC RCOG India East Zone. So I welcome Dr. Kushagrati Ghosh for his next talk. The stage is all yours.
Yeah. Can you see my screen?
Yes, sir.
Can see my screen. Okay.
I would request all the speakers to stick to the timings. Each speaker is given 15 minutes.
Sure.
Thank you.
Sure. Thank you very much, Chinmay, Bella, and Mandakini, for inviting me for such a prestigious FOGSI Fetus Day. I can see all the luminaries there in the faculty Zoom. The topic that I'm going to talk on is what has changed in screening for aneuploidies. When we talk about aneuploidies, we essentially talk about Down syndrome screening. That is because that is the commonest chromosomal abnormality at birth, which causes mental retardation. The life expectancy of the babies after birth is quite long, and it's quite challenging to bring up such babies. And there is a medical legal twist as well of missing such Down syndrome babies at birth. That's why this is what we basically talk about. But we all know that we have to confirm, and we have to confirm, then Down syndrome can only confirm by getting a fetal sampling, either by amniocentesis or by chorionodular sampling, but we don't do that for obvious reasons. So it started as a screening for high-risk population, which started in 1970s based on maternal age. At that point of time, all women above the age of 35 years were considered high risk because of the inflection of curve. And then all of them were subjected to amniocentesis. But quickly it was realized that that method only detected about 30% of Down syndrome with a 5% amniocentesis rate, which was not quite acceptable. So the search was on for the methods to screen all women. And this is the major change which occurred in the Down syndrome screening, from high-risk screening to universal screening. And there was intense research regarding biochemical and USG markers for Down syndrome that could be used in addition to maternal age along with it. And therefore, that what followed was a period of discovery of various biochemical and biophysical markers. Now, screening for aneuploidies in the early 1980s and 90s came out with the biophysical screening, known as the genetic sonogram for soft markers, biochemical screening, which we call serum screening, combining both the two. And then recently, from 1997 or so, the genetic screening of the NIPS came up. Now, when we talk of biochemical screening protocols, there was a plethora of names like integrated test, serum integrated test, combined test, quadruple test, triple test, double test, sequential test, and so on and so forth. And debates followed, which one is better, and everyone claimed that their new markers were superior to the others. Now, therefore, the Surus trial was conducted, and then they compared one test against the other as regarding the suitability, the detection rate, and the false positive rate. And there are a few things which came up from the Surus trial, which we still follow today, which is age alone as a method of Down syndrome screening should not be used. LMP alone should not be used because it is inaccurate in about 15% of cases. Triple test should not be used because of low sensitivity. NT alone should not be used. Double marker alone should not be used. Integrated screen is good for pickup, but it is cumbersome. And sequential screening has a lot of dropouts. And regarding contingent screening, there are more number of protocols than there are markers probably. So the Surus recommended that at the moment, we should stick to only two types of biochemical screening. One is a combined test, which we call FTS in our country, mostly between 11 to 14 weeks. And if somebody misses that window, we go for the quadruple test later on in the second trimester. Now, whatever method we use, accurate estimation of gestational age is extremely important by CRL because the software calculations that we do are done with gestation-specific mom values rather than the absolute values of the markers in nanogram per DL. Now, when we talk of first trimester screening, we are screening between 11 to 14 weeks with a CRL between 45 to 84 millimeter. So we have a 3 weeks window. And we follow the NT criteria as devised by Kypros Nicolaides with the Fetal Medicine Foundation. Now, first trimester screening, any first trimester screening has to start with the first trimester scan. This is absolutely important, as has been stressed over and over again by ISWAG and other authorities. All women should be offered first trimester USG regardless of their intention to undergo down screening because it goes beyond down screening regarding viability, dating, multiple pregnancy, chorionicity, major anomalies, and lastly, Down syndrome. The first trimester screening of the combined tests that Surus trial has recommended and the NICE guideline and everybody recommends is estimation of CRL, NT value, nuclear translucency, and two hormones, BAP-A and free beta HCG. Along with that, in the test acquisition form of the TRF, we have to mention the date of birth because all of these are minor modification odds ratios on top of the other three parameters which I discussed: maternal weight, history of Down syndrome in the past, exogenous HCG injection, twin and their chorionicity, and a history of bleeding PV, race, and history of diabetes. Practically what is done is USG is done, CRL and NT values are measured, blood is drawn in gel tubes or dry bead spots or TPS papers. The requisition form is filled up with clinical information like date of birth, weight, etc. And then the risk categorization is done at 1:50, where 250, where more risk than 1:250 is considered high risk. And usually I go for diagnostic procedures, amniocentesis and CBS, depending on the period of gestation. And if it is low risk, then we usually counsel the patients and continue pregnancy. But it has to be remembered that this is a screening test. A high-risk fetus does not mean that the baby is Downs and we should not terminate the fetus. And if it is a low risk, also it does not mean that it is zero risk. And so everything is hunky-dory. There is always a possibility of having a Down syndrome very rarely. And therefore, it is very, very important that whatever we do it correctly. The method is correct so that we are not blamed later on. Now, in 2018, the NICE guideline revised the cutoff value in UK from 1:250 to 1:150. That is because of their audit. They have a stringent criteria for doing NT, and they have observed that there's no point in doing invasive tests below a risk of 1:150. But in our country, in the absence of enforcement of strict NT criteria in India and the absence of audit of NT in India, elevating the cutoff from 1:250 to 1:150 might make us miss more Down syndrome babies, and we should be very careful in introducing that NICE guideline in India routinely. But having said that, we do not stay as we are. We we keep on searching for better avenues. So increased search was on to increase sensitivity, which means the pickup rate of downs, and to reduce the false positivity, which means the amnio rate. And therefore, two protocols came up, which is called the first trimester quadruple test, where we add the AFP along with the other parameters. And then we have, if we add another parameter, which is the inhibin, then it is called the first trimester penta test. There is definitely an incremental increase in the pickup rate, no doubt about that, and reducing false positivity. But does it justify the cost? Probably in India, it may not justify the cost, and that's why none have gained much ground in aneuploidy screening in India, apart from the fact that these are slightly costlier than the FTS. A new group has come up, which is the intermediate risk, which has thrown all of us into utter confusion. I don't know whether it's a new trend or not. And it all started in 2005, very slowly, with a very benign study by Professor Kypros Nicolaides, consisting of 75,000 women as a risk-oriented two-stage first trimester screening. And what it did was divided the so-called low-risk population further into two groups. The high risk remained the same, into two groups, the low group and the intermediate group. Now, statistics show that if we go by these classification, then 5% by default would be high risk. Of the rest of the 95% population, 70% would be recategorized as low risk, and 25% population, which is quite high, would be considered as intermediate risk. Now, there are pros and cons, proponents and opponents of intermediate risk concept. The logic behind the people who say that, yes, we should carry on with the intermediate risk is that there can be downs maybe in this intermediate group, however low it may be, and we should not miss them. But the problem is how to investigate these intermediate risk groups. Do we do further triaging by nasal bone, tricuspid regurgitation, and ductus venosus? Do we do invasive for these group, or do we do NIPS? Or some people would say just counsel and follow up to an anomaly scan, genetic scan, and fetal echo. So there is no standard. People who are against intermediate risk say that there is no standard cutoff or guideline. There are various papers which show that the upper guideline could be 1 in 100, 1 in 150, 1 in 250. The lower guideline could be 1 in 500, 1 in 1000. So between that group would be intermediate risk. There is no consensus. If around 20 to 25% population, it causes huge anxiety in the patients, counseling time of healthcare professionals, and the cost effectiveness of this has not been studied, and there is no standardization regarding what to do with this intermediate risk group. A fact to ponder is that none of the national guidelines of any country, UK, USA, Australia, New Zealand, European countries, recommend intermediate risk in their national aneuploidy screening protocols. So the question is, should we be reporting such intermediate risk category in aneuploidy screening in India at all? There's no consensus, so it's better avoided. Now, ACOG and Society of Maternal Fetal Medicine Practice Bulletin, as recent in 2020, has gone on to say that NIPS as a primary screening for Down syndrome can be instituted in places where it is possible. And it is far better as a pickup rate and false positivity regarding compared to biochemical screening. However, an early anatomy scan is a must. This is the crux of the bulletin of 2020. Now that brings us to the non-invasive prenatal screening, or NIPS, or the genetic screening that we call. Non-invasive prenatal screening is a highly effective screening method for Down syndrome, but it is not diagnostic. And if we compare the pickup rates and the amnio rate, sensitivity and the false positivity of the three categories of tests, which the SURUS recommends and the ACOG and the SFMG recommends, 90% sensitivity with a 0.2% false positive rate, which is great. And the pioneer was in 1997. It came into clinical force in early 2000. And the cells that come into maternal circulation comes from the strophoblast of the fetus. And so it may come, it may not come. And therefore, there are possible sources of error, like low fetal fraction, early gestational age less than 10 weeks, maternal obesity, multiple pregnancy, especially when they're discordant for trisomy in dichorionic diamniotic pregnancies, vanishing twins, confined placental mosaicism when we are doing CVS, and maternal copy number variations, polymorphisms. And whenever there is a third cell line like donor egg, surrogacy, or organ transplants. ISPD has gone on to say that there was a trend of using this NIPS beyond Down syndrome to look for microdeletion and duplications. And the ISPD says in 2015 that this test, NIPS, should be limited only for microdeletion and microduplication only when there are significant disorders with a well-defined severe phenotype in the family or on ultrasonography probably. International policy statement guidelines, there are lots of guidelines and policies since 2012 on NIPS, and the recent one was on the ACOG SMFM guideline, which I mentioned. And the crux of the guideline says that it is a screening test, NIPS, and it is better called NIPS other than NIPT. It is not a confirmatory test. It can be done 10 weeks onwards. However, it is costlier than the biochemical screening. There is a problem of low fetal fraction of approximately 3%, sometimes up to 5%. It is not a good idea to do NIPS in FTS screen positive patients already. If so, then they should be counseled very, very carefully. It's like doing a second screening test in an already screen positive population. So the take-home message, ladies and gentlemen, would be counseling before any form of screening that we do is a must. We do 11 to 14 week scan anyway, whatever method we use, because it has a lot other benefits apart from Down syndrome screening. Down syndrome is only about 1 in 800, but all the other problems are much more than that. We keep on doing the standard FTS combined screening where we do the FMF criteria screening and the PAPI and beta ECG. High risk and low risk are categorized on 1 in 250 and avoid the intermediate risk group. If required, then you have to counsel the patient very carefully before going for the intermediate risk category. Amniocentesis and CVS is done in high risk group. We avoid NIPS in screen positive population. If we are really worried about Down syndrome screening, then we may do the NIPS instead of FTS as a primary screening in affordable patients, which is now coming up in a big way, but cost is a factor. But whatever method we use, again, ladies and gentlemen, we should reiterate that we should not forget the scan and the counseling at every step. Thank you, ladies and gentlemen. We have come a long way in the screening for Down syndrome screening, but we still have a way to go. Thank you.
Thank you very much, sir, for the entire enlightening lecture. And as you have said, I think we have come a long way and we still have a long way to go. And from moving from triple marker to NT to now NIPS, I think we have really come a long way, but this new epidemic, not pandemic, I would say, but epidemic of intermediate risk is really causing a lot of confusion. So just for the benefit of audience, sir, and myself also, how do you incorporate the evidence base and your clinical practice in this intermediate risk category? Because I think all labs have now started giving that, and we are facing a lot of problem where it is clear there is no problem. So for all structural anomalies, in increased NTs, or otherwise problematic reports, there is no problem. But for in the intermediate risk where everything is okay, how do you clinically sort of take the scenario forward in your own practice?
That's a very important and very pertinent question. Now, the thing is that there is a catch in the sentence which you said, that all the labs are now reporting intermediate risk. Actually, if you go into what they write, you see either it's an opt-in or an opt-out. So if you don't respond anything, they would opt you in, which means they will enter you into their database and send you intermediate risk reports. But you have the option of opting out, like it used to happen in HIV counseling earlier on, a decade ago. So if you opt out, like we have opted out, most of the centers in Kolkata have opted out. We have talked to all the vendors. And since we have opted out from my center, always we have a high risk or a low risk report. Now, having said that, if you want to opt in into the intermediate risk categorization, I think all patients should be counseled beforehand that there is a possibility of having an intermediate risk up to 20-25%. We always tell them about high risk and low risk, never tell them about intermediate risk. And the intermediate risk comes as a world from the blue, and they come with the intermediate risk, and they are referred, and then they don't know what to do. The patients don't know, the referral doctors don't know, and the person who is doing fetal medicine specialist also don't know, because you see the jury is out. Nobody knows what to do with the intermediate risk. Nobody wants to do amniocentesis because of the risk of miscarriage. Nobody wants to counsel just like that, don't do anything and carry on, because just in case if there is a Down syndrome in
the
that
problem
group,
is who will bail the cat.
Therefore, people have gone to the very easy route of doing an NIPS and reassuring them that everything is fine, which is again wrong. So the question is whether to go for intermediate risk is really concerning. If we want to go for intermediate risk, I think you counsel the patient beforehand, and they're willing, go for it, no problem with it. But if without counseling, to go for a protocol which has an intermediate risk, I think is not fair.
Yes, totally agreed, sir. But the problem here is the people who opt out are the people who are taking risk, and opt in is like,
I think let me intervene. That's a very interesting discussion, and it has the capacity of going on for a very long time.
Sorry, very sorry.
I think we have to
go to the next
test counseling and move on. So can we? Thank you so much.
Yeah. So I invite Dr. Gurpreet to introduce our next speaker.
Yes.
The next speaker is
sorry, Dr. Mumtaz.
Yeah, Dr. Bela Bhatt. It's my privilege to introduce Dr. Bela Bhatt. She is the chairperson of Imaging Science Committee, a consultant at Rainbow Hospital, Mumbai. She's a real fetal person with the FMF certification for nuchal scans for fetal anomalies. She's also a life member of Society of Fetal Medicine, Scientific Secretary of AFG Mumbai, and a winner of many awards, the CS Dawn Awards, the winner of FOGSI Has Talent, and we know really she's talented both in academics and other on stage also. And she's the national convener of FOGSI Superstar Competition 2019-20.
That's okay, ma'am.
Yes, yeah. Now we go on to the talk by Bela ma'am. Over to you, ma'am.
Thank you so much, Dr. Mumtaz, for those kind words of introduction. And so I'm very happy that Dr. Kusha has beautifully covered the aneuploidy screening and what's new in it. So when I'm talking about inverting the pyramid of antenatal care, I'll not have to touch upon those points. Well, we all know that traditionally, what we learned even as residents and just almost a decade back was this kind of a pyramid of antenatal care where least importance was given to first half of pregnancy and maximum importance was given to the latter half or the second half of the pregnancy. And it was Nicholas in 2011 who proposed to invert this pyramid of antenatal care and give maximum weightage to the first trimester and then invert the pyramid of antenatal care. Now, why this basic concept has changed? Because initially what we used to do is to react to complications after they have developed in the second half of pregnancy. Whereas what Nicholas proposed was that right at 11 to 13 weeks, 6-day scan, that is anti-scan, you analyze early based on the sonography markers, based on the biophysical markers, biochemical markers, predict and try and prevent or delay those complications. And therefore, maximum weightage was given to this 11 to 13 weeks, 6 days time period, or what we call as first trimester screening. Again, another thing is traditionally we have been taught that the first trimester is from beginning of pregnancy till 12 weeks, but the functional first trimester is till 14 weeks. As we all know, the anti-scan we do between 11 to 13 weeks, 6 days, right? So the anti-scan which initially started for aneuploidy screening tells us much more. What all? Well, first of all, most important, accurate dating. We know our growth monitoring throughout the pregnancy is going to be based on accurate dating, which is done based on the CRL, which is very appropriately measured at 11 to 13 weeks 6 days scan. Timing of delivery, again, for that we need accurate dating. Aneuploidy screening, Dr. Kusha has beautifully mentioned about it. We can pick up 50 to 60% of structural anomaly, and that's very good right at 12 weeks of pregnancy. Prediction of preeclampsia and fetal growth restriction. So these first three things is something I'm going to go into details of it, but still we get much more information right at your first trimester. In Rh negative mothers, we can work up to decide who will need intensive monitoring based on Rh entity titer. Preterm labor, cervical assessment will help us find out high-risk group that may benefit from close follow-up and possible treatment. Multiple gestation, we all know how much important it is to find out the chorionicity, because once we find out whether it's a dichorionic or monochorionic pregnancy, the monitoring, the management, the complication is way different. In monochorionic, we need to frequently monitor based on the complications, vascular complications. Gestational diabetes mellitus, a good control of gestational diabetes mellitus right from first trimester is going to prevent your macrosomia and related complication and some of the stillbirths, late stillbirths in the third trimester, if the importance has been given on good glycemic control right in the first trimester. Thyroid disorders, we know we all do TSH now. And when we do TSH in the first trimester and we try and keep it below 2.5, we know that we are going to control it throughout the pregnancy and we can reduce the neurological deficit. So basically, based on all this information, we can tailor individual prenatal care as per patient and not a blanket ANC care that is once a month till, 28 weeks and then every 15 days and then weekly in the last month. No, we can tailor the individual prenatal care. Those who are high risk will require more intense monitoring. Low risk will not require intensive monitoring. So aneuploidy screening, we know that FTS, the detection rate with the combined test, that is nuchal scan and double marker with all the markers, fetal heart rate, nipple translucency, nasal bone, ductus venosus, tricuspid flow, based on which factors you use, the detection rate ranges from 90 to 95%, but this is the best screening test available and right at 11 to 13 weeks, 6 days. So this is what we use. We know the importance of heart rate at 11 to 13 weeks or anti-scan. Well, there'll be in trisomy 21, 13 and Turner's, there'll be tachycardia, and trisomy 18 and triploidy, there'll be bradycardia. Now, mainly it will help us in differentiating between trisomy 13 and 18, because in both in trisomy 13 and 18, there'll be decreased beta HCG Pape. So if there is tachycardia, it goes more in favor of trisomy 13. If there is bradycardia, it goes more in favor of trisomy 18. We all know we have to take correct CRL at this anti-scan, and because it is the nuchal translucency is a function of proper CRL, and mind well, when there is high nuchal translucency at your anti-scan, it doesn't just tell you about the high risk for aneuploidy, but it also gives information about possibilities of many other problems like cardiac anomaly, pulmonary or mediastinal mass, genetic syndromes, skeletal dysplasia, arthrogryposis, torch infection, fetal anemia. So you have to one by one rule out each of them. So right at your first trimester, you get possibilities of diagnosing so many or suspecting so many conditions, which one by one you can rule out. Ductus venosus as a marker is a marker of chromosomal anomalies, but reversal of A wave, as you can see here, is also a marker of some of the cardiac defects and also fetal death. So we need to screen the heart properly even at anti-scan. Tricuspid flow, again, tricuspid regurgitation is a marker of chromosomal abnormalities as well as cardiac defect. So we need to look at the basic heart at anti-scan when we find these abnormalities. Second important aspect is anomaly detection of anti-scan. We know that the incidence of Down syndrome is in general population is 1 in 800, whereas that of structural anomaly is 3%, which is way higher. And with the better machines and skills, now almost 50 to 60% anomalies can be picked up at nuchal scan. We know this FMF always detected 9 acrania, lobar holoprosencephaly, encephalocele, anencephaly, body struck anomaly, limb reduction anomaly, exomphalos, gastroschisis, and megacystis. These can never be missed. They can always be detected at your NT scan or your 11 to 13 week scan. So these are some of the anomalies which were picked up at our Center of Rainbow Women's Hospital. And these are some of the cases that I've put here. This at 11 weeks, there was arrhynia with cyclopia, absence of nose, holoprosencephaly, and being a little anomaly, it was terminated. The genetic test showed trisomy 13, so it can be picked up right at 12 weeks. Occipital encephalocele, again at 11 weeks. Here it was, you can see some subtle changes. It's not very, very obvious here, but there was a enlarged fourth ventricle and a developing encephalocele. Now, I have put this case specifically here because in this particular patient, right at when patient came at between 8 and 9 weeks of pregnancy, I had suspected there's something wrong because of this enlarged cystic appearance in the brain. And so it was followed up at 11 weeks and again followed up at 12 weeks. And here you can very clearly see in this video also that there is an encephalocele which has developed, and the patient opted for termination of pregnancy. See, outside it doesn't look great, but it is a major, major anomaly. There was no other associated anomaly. The tissues were sent for genetic sampling and it ruled out common aneuploidies, but the DNA has been stored for further genetic evaluation. As we know, there can be some of the genetic causes in such cases. Another case of acrania with exencephaly. You can see the overhanging brain here. Well, nowadays we don't need to wait till your 18 to 20 weeks scan to diagnose acrania or your anencephaly. We can diagnose acrania right at NT scan. Right, another case of acrania with holoprosencephaly, a case of meningocele with CTV, again picked up at 12 weeks of pregnancy, as you can see here in these images as well as video. This was a case of body stock anomaly, which was picked up at nuchal scan, and grossly anomalous fetus, and obviously it was a lethal anomaly. It was terminated. So all anomalies that I have shown before were lethal anomalies. So parents wish to terminate, but then again remember that even if they terminate the pregnancy, always counsel them for genetic testing, or if they are not ready or not in a mental condition to test for genetic testing at that point in time, always counsel to store the DNA, which just costs 2,000 rupees. And at later date, after 6 months, 1 year, when they plan next pregnancy, before that, we can test them and find out whether there is any chance of any genetic anomalies there, whether there is chance, what is the chance of recurrence, etc., etc., and a genetic counseling can be done. This was another case of exomphalos. You can see very well in the sagittal and axial section. And this is one anomaly which is not lethal, but you need to rule out the chromosomal anomaly and rule out that common aneuploidies are not there, and then the patient can be counseled based on that. This is another case of arthrogryposis with generalized edema, very high chances of genetic association, patient terminated, and the genetic testing, the DNA has been stored. This case, the patient, there was a generalized edema, cystic hygroma, and the testing was done and it showed trisomy 21, and patient opted for a termination. So benefit of early detection right at your 11 to 13 weeks scan is that if it is a lethal anomaly, it allows for earlier and safer termination with less risk to mother, favorable cost-benefit ratio, and the couple can protect their privacy, which is very, very important for the couple. We have to think from the patient's point of view also, so they can protect their privacy. Nobody comes to know that there was a pregnancy which has been terminated. In case if they decide to continue, in some of the cases where there's no chromosomal anomaly and there are treatable anomalies, it gives them time to prepare for postnatal treatment and plan to manage delivery in specialist center. Well, remember, we are always not there to pick up any anomaly. Those cases in which patient had previous congenital anomaly in the previous pregnancy, or it's a gestational diabetic patient or patient on some of the drugs, anti-epileptic drugs, if you can do anti-scan and rule out 50 to 60% major anomalies also at 11 to 13 weeks, it reassures the normality in early pregnancy. And that's a very, very big thing for our patients. In some certain conditions like obese women with abdominal scars and all, we know even the anomaly scan is going to be difficult. So transvaginal scan at nuchal scan is going to depict a better anatomy. So there it is an advantage. Well, remember, you can pick up 50 to 60% anomalies at 11 to 13 weeks scan, but then it does not replace your 18 to 20 weeks anomaly scan, because your 90% of anomalies are going to be ruled out at your second trimester scan, and therefore it substitutes and not replaces, but it is very important. Another very, very important thing is risk calculation for early preeclampsia at anti-scan. Well, we know that the incidence of preeclampsia is 2 to 8%, even more than structural anomaly. So this aspect is very, very important. Now we know that the placental architecture is established by the end of first trimester, and that makes the physiological basis of prediction at the end of first trimester with the help of biophysical and biochemical markers. So which are the biophysical markers? The maternal and demographic factors, mean arterial pressure, uterine artery PI. For the want of time, I can't go into details of this. Along with this, we do a mean uterine artery PI MOM. Friends, here I want to stress upon this thing, that this is very easy to learn. It's not a rocket science. All of us must learn to do sonography on our own, anti-scan on our own, and add this uterine artery PI Doppler at anti-scan, so that we are able to assess the risk of preeclampsia and fetal growth and placental insufficiency right at 3 months of pregnancy. So this is a normal flow of uterine artery at the anti-scan, whereas this is showing high uterine artery PI beyond more than 95th centile. So little addition of information in the form of uterine artery PI at anti-scan is going to have a great benefit for patient. So if you are doing it, do it yourself. If you are sending it to a sonologist, please ask for uterine artery PI so that you can calculate risk based on FMF calculators which are available online. We always add these biophysical markers with biochemical markers. So FMF recommends PAPE with PLGF, but we know for financial constraints, we may not have PLGF, but at least add PAPE, which is a part of double marker. We know that biophysical markers, that is mean arterial pressure and uterine artery PI, increases more than 95th centile, whereas biochemical markers like PAPE and PLGF would reduce less than 0.5 mm. And what does this signify? This signifies higher risk for preeclampsia, fetal growth restriction, and FMS, the SPREE study has shown that combination of these two biophysical and biochemical markers is going to have the detection rate of almost 80 to 90% as far as early onset preeclampsia, which is a severe form of preeclampsia, is concerned. So what I feel is do at least what is least possible. If you have PLGF, fine, because the detection rate would increase to 90%. If it is not there, don't worry. With your double marker and anti-scan and uterine artery PI, the detection rate would be 80% for early onset severe form of preeclampsia. And even if the patient is not ready for double marker, at least add uterine artery PI, you'll have 75% of detection rate, and that's how we can help our patients. These low biochemical markers, that is PAPE and PLGF less than 0.5, are the markers of placental dysfunction. So it gives us information not just about the risk of early preeclampsia, but also fetal growth restriction, abruptio placentis, stillbirth, preterm delivery. So you need to monitor these patients closely. And what is the role of prediction if we are not able to prevent? These are two sides of a coin. So once we find out that this patient is at high risk for early preeclampsia or fetal growth restriction, this SPREE study of Fetal Medicine Foundation showed that when the low dose aspirin started before 16 weeks, it does help. And the FIGO has also considered this SPREE study of Fetal Medicine Foundation and came out with the recommendation that if based on your biophysical and biochemical marker, the patient is at higher risk of more than 1 in 100, start aspirin in the dose of 150 milligram. I repeat, 150 milligram and not 75 milligram at 12 weeks of pregnancy. Continue till 36 weeks of pregnancy. And mind well, you are going to prevent almost 80% of early onset severe form of preeclampsia and 40 to 50% of fetal growth restriction. Again, this is just a graphical this thing, that the incidence of trisomy 21 is low, but structural anomaly and preeclampsia is high. So these two things are very, very important at your first trimester screening to predict and prevent this severe form of complications of pregnancy. As far as Rh negative pregnancy is concerned, well, we do a workup to decide who will need intensive monitoring based on Rh antibody titer. If the antibody titer is below the critical titer, we repeat titer every 4 weekly. But if it is above the critical titer, then we manage this, monitor these patients with MCA PSV, and then take a call whether IUT is required or not. And well, we talked about inverting the pyramid as Dr. Professor Nicolette has suggested. I remember very well Dr. Prashant Acharya, who is another stalwart, has suggested tube for ANZ care, antenatal care. So what I feel is that it's a combination of this inverted pyramid and the tube, and it makes a funnel shape for the antenatal care, where the first trimester, the 11 to 13 weeks, makes very important, because with the help of nuchal scan, biophysical, biochemical markers, you get lots of information to categorize patients into high risk and low risk, and decide who needs more monitoring. But at 28, 32, and 35 to 36 weeks, also we need scans. Why? Because at 28-week growth plus Doppler will help us detect early onset fetal growth restriction, and we can monitor them and give better perinatal outcome. It will also pick up late evolving anomalies as well as placenta previa, and we can plan the delivery accordingly. Well, 35 to 36 weeks scan is also equally important with growth and Doppler, because these days we know that late onset FGR can be picked up based on these scans, and because they form 70% of fetal growth restriction, we will be able to prevent 40% of late stillbirth if we add this one scan in our routine scans, apart from late evolving anomaly as well as placental location. So robust screening program and early prophylaxis at first trimester results in positive impact in terms of reducing maternal as well as fetal complication. So, well, Nicolette was the one who tried to invert this pyramid in 2011. And then many joined hands in last decades to help him invert this pyramid of antenatal care. And I think we all are, now numbers are increasing. We are all trying to increase this first trimester screening and trying to stratify the patient and into high risk and low risk, and help our patient reduce the complications which are going to occur in the second half of the pregnancy. So with this, I would like to conclude my talk. And as chairperson of the Imaging Science Committee, it has been my dream to see that every obstetrician becomes a sono-obstetrician or gynecologist, because we know that for every obstetric or gynec patient, we need to do a scan. And if we are able to do a good scanning, then we are definitely going to improve the maternal as well as parental outcome. So thank you very much for patient hearing. Thank you.
Thank you so much, Bella ma'am, for that wonderful deliberation. It was a very fluid presentation. And I must say, you have skillfully inverted the triangle like a dance mudra. And very good videos also. Just to say, I remember a story by one of my professors. Like when he was a student, the uterus was larger than gestational age, and they didn't have ultrasound. They had to do a scan, X-ray. And they thought it is a vesicular mole, and they terminated the pregnancy. It turned out to be triplets. So definitely gone are those days. Gone are the days when suddenly the woman comes at 20 weeks and we realize it is an encephaly. And I think gone should be the days where we diagnose Downs after delivery, after the baby is born. Though we can terminate till 24 weeks legally, the complications associated are more. So it is definitely better to diagnose it early. Ma'am, I have just 2 queries. You mentioned cervical length in first trimester. Is the same cutoff used, 2.5 centimeters there also?
So basically the thing is, the most sensitive assessment of risk for preterm is in the second trimester, of course, between 18 to 22, where we have a cutoff of 2.5 millimeters. But our FMF software does give us risk assessment based on the cervical length, and I think less than 3 centimeters is something which we'll keep a watch on these patients. It's that, so that, you know, we are more careful at 16 weeks, 18 weeks, 22 weeks, and then definitely progesterone support may help this patient.
You can sort of triage those women who have a higher chance. Okay. And preeclampsia screening, are you doing routinely in your practice, and what is the cost like?
Yes. See, basically, PLGF is something not every patient is affording. So I mentioned in my talk also, but at least double markers is what we are doing. So your nucleus scan, uterine artery, PI, maternal demographic factors, MAP, and double marker, at least you will get 80-85% sensitivity to predict the severe form of early preeclampsia. And we would start if the patient is more than 1 in 100 high risk with the 150 milligram of aspirin. And I have myself seen improvement in the PI and good outcome in so many patients, because since 2017, when the FMF study came out, I have started using this, and I do see benefit in so many patients in the last 4 years.
Thank you so much, ma'am. Thanks again for those wonderful videos. Thank you.
Over to you, Neera, madam, with the next talk. Yes, unmute yourself, madam. Neelam, madam, you need to unmute yourself.
Yes, sorry for that. So, it gives me an immense pleasure to introduce Dr. Malti Prasad to you all. She is a member of the Royal College. She's a director at the Trichy Fetal Medicine Center. She has several awards and publications to her credit, like the best paper at FOGSI 2015 for alpha thalassemia and non-immune eye drops. She has authored chapter on FOGSI platform, presented papers in FIGO, and she's been a secretary at the Trichy Obs and Gynae Society, executive member of the Imaging and Fetal Medicine Committee FOGSI, vice president at the Trichy Obs and Gynae Society, and she's been the past secretary for IMA Trichy Society. Over to you, Dr. Malti.
1 minute. Good morning, all. It's a pleasure. Can you see me now? Are you able to see me?
We can see you, but you need to share your screen.
That's what I'm doing. Can you see the screen?
Not as yet.
1 minute.
Yeah.
Okay. Yes.
Yes.
Yes. Good morning, everyone. It's a pleasure to be seeing all of you. Special thanks to Dr. Chinmayi ma'am, Dr. Mandakini, and Dr. Mandakini Pradhan for the invitation. Are you able to see me?
Yes, your full screen has gone back to.
Can you make it slideshow, please?
Yes, 1 minute.
It was on slideshow. It went back.
1 minute. 1 minute.
Yeah.
1 minute.
Perfect. Okay.
Yes. So I'll be talking about how not to miss anomalies during a routine anomaly scan, as already enumerated by the previous speaker. It's important to understand that all anomalies cannot be picked up in the first or second trimester. There's a few anomalies which still has a long way to go, and we are unable to pick up these anomalies. So a systematic approach in the first and second trimester would go a long way in picking up these anomalies. It's important. The purpose of the anomaly scan in the first and second trimester is to provide accurate diagnostic information and optimal antenatal care, and to perform a biometry to look for growth abnormalities. And ultrasound, as it says, can identify the majority of major malformations, but it cannot pick up 100%. It's important to understand, counsel the patient that all anomalies cannot be picked up by routine ultrasound. But if you use a systematic approach, some of the anomalies can be picked up. And it's important to assess the multiple pregnancies, best done between 18 to 20 weeks of gestation. And an anomaly scan would give us an opportunity to assess the need for fetal interventions, both diagnostic and therapeutic, and the option of termination of pregnancy can be discussed. So what is the advantage of early anomalies in the first trimester of pregnancy? Advantage is that you can exclude many anomalies, early reassurance to at-risk mothers, earlier genetic diagnosis, and easier pregnancy termination if appropriate. Suppose if you find a lethal anomaly in the first trimester of pregnancy, it becomes easy for you to terminate, and it becomes easy for the consultant also. But some of the limitations are that you need trained and experienced personnel, and uncertain cost by benefit ratio is very important. And some of the anomalies can appear very late in pregnancy. For example, agenus of corpus callosum, hypoplastic left heart, and hydrocephalus can be seen even in the third trimester of pregnancy. A skeletal dysplasia can be seen in the third trimester of pregnancy. So it's important to reassure that if you do an anomaly scan, just because everything is perfect, it doesn't mean the baby is unlikely to show up many surprises even in the third trimester. So in the first trimester, first and foremost, how do you pick up anomalies in the first trimester? It's important to make a measurement of the bilateral diameter and the head circumference. In the head circumference, in the bipedal diameter, you have to look at the cerebral hemispheres, which should be symmetrical. You must see a very nice, clean interhemispheric fissure here. If you do not find the interhemispheric fissure at that point in the first trimester, think of a holoprosencephaly. If you do not find these two choroid plexus on either side giving a butterfly sign, once again think of a holoprosencephaly, and the BPD measurement should be outer to inner or inner to inner. So cranial bone ossification once again should be seen at 11 weeks of gestation. If you do not see the cranial vault in the first trimester, always do a transvaginal ultrasound, because many of the abnormalities can be missed out by a transabdominal ultrasound. We've started doing only TVS for first trimester ultrasound. If you do not find the cranial vault, think of an anencephaly, and there should be no bony defects or distortion. And you have to understand that the lateral ventricles should be filled up by the echogenic choroid plexus, which should extend to the lateral borders. If you find a small choroid plexus occupying only 1/3 of the sides of the ventricles, think of a ventricular megaly in the first trimester also. And butterfly sign is very important. You have to document it in your report and into images, because later on if the patient presents with some other problem, you can always have a documented butterfly sign. If you do not find the butterfly sign, as you can see in the picture here, think of a holoprosencephaly. And you need to understand that corpus callosum and cerebellum may not be assessed in the first trimester. So you have to wait for the 16 or 20 weeks ultrasound to look at the corpus callosum and the cerebellum. But now lot of papers are coming in where you can look at the pericallosal flow in the first trimester too. So this is a picture of the thalamus and the third ventricle, which you once again have to document in the first trimester. And this is a typical case of ecrania anencephaly sequence. You typically will find an hyperechogenic amniotic fluid in an anencephaly when the vault is absent. This is an encephalocele which was picked up in the first trimester by a transvaginal ultrasound. So this is a normal appearance butterfly sign, which you can see this appearance is lost in the second picture, which is a holoprosencephaly. So when you find a BPD, suppose you measure the BPD, it's important to always measure the diameter and its circumference. When you find a BPD which is less than the 5th centile, always think of either a holoprosencephaly or a spina bifida, open neural tube defects. When you find a fused thalamus, as you can see here, it's a holoprosencephaly, and there's a complete loss of butterfly sign in a holoprosencephaly. So I'm not getting into the details of intracranial translucency. It's important when you do a nuclear translucency, always look at the intracranial translucency. If it is absent, you think of open neural tube defect. So I'm not getting the details of that. And this, you have to measure the BS, the brainstem by intracranial OB diameter, to look at whether it's increased or decreased. And next, coming on to the face, a sagittal view of the face is very, very important. As you can see, the nasal bone, which is the equal sign, and you can measure the NT in this profile, and you can always have to look at the maxilla. If you find a maxillary gap, you have to think of cleft palate. It's important to look for the superimposed line sign, which is commonly seen. If you do not find the superimposed line sign, think of a palatal abnormalities. And the mandible should be nicely seen, which should be parallel to the maxilla and should extend to almost the anterior aspect of the maxilla. This is a case of micrognathia, which was picked in the first time. So you hardly find any mandible there, and large clefts may be visible as early as the first trimester, and teratomas or lymphangiomas of the neck can also be picked up in the first trimester. So this, always have a look after you finish a sagittal, do a coronal view of the orbits. You can see the eyes with their lenses. Measure the interorbital distance and the binocular distance both in the first and second trimester. When you have a hypertelorism, which is more than 9th centile, think of trisomy 13, 18, 21 and Carpenter syndromes. When you find centile less than 5th centile, it is suggestive of hypotelorism. So following a coronal imaging, always have a look at the retronasal triangle. It should be intact. It should be a triangle. If you find any deficiencies, you think of a cleft palate, and cleft lip can be picked up as early as in the first trimester by doing a transvaginal ultrasound. And teratomas or lymphangiomas also may be visible by coronal imaging. So this was once you come to finish off the face, you have a look at the neck, where you can pick up cystic hygromas, jugular lymphatic sacs, and assess the proper alignment of the neck with the trunk. When you find a stargazing appearance, you think of an anencephaly. And lungs should be homogeneous, should have an homogeneous echogenicity. You should not find any pleural effusions or solid cystic masses. And you can pick up diaphragmatic hernia in the first trimester pregnancy as early as 12 weeks. When you find the diaphragm is not intact and the stomach bubble is very often seen in the chest, based on that, you can diagnose in the first trimester also and assess the stomach position and the liver to assess the normal situs. A 4-chambered view, you don't have to get into the details of a heart. You have to assess the 4-chambered view of the heart by color Doppler. Look at the 3-vessel view. And normal position of heart and chest situs evaluation, very important, which can be done in the first trimester. Take a dual picture of the stomach and the heart, so you know you're on the right track. And look for the 4-chambered view and the 3-vessel view. And coming to the spine, a longitudinal axis of the spine can be done. This was a meningomyelocele which was picked up in the first trimester. And look for the intact skin when you do a sagittal and the coronal view. And some of the markers of spina bifida, which you usually see in the second trimester, may not be seen in the first trimester. But one clue which you can get to exclude spina bifida is to see a BPD, which is less than the 5th centile. If it is less than the 5th centile, always have a thorough look of the spine. And one more marker of spina open neural tube defect will be a crash sign where you see a dried up brain, which is typical of an open neural tube defect. So these are the small markers by which you can do a complete evaluation and not to miss anomalies in the first trimester. And always have a look at the stomach and the bladder. And stomach is always should be seen on the left side of the abdomen. Always assess the position of the stomach. And normal situs, look for, this was a case of megacystis bladder, and the bladder imaging also should be done the first trimester. She had a megacystis bladder and a hydronephrosis. And most importantly, as already shown by Dr. Bela, have a look at the ventral wall, look at the umbilical cord, document a picture of the umbilical cord insertion to look for omphalocele and gastroschisis. And extremities, bony segment, you have to assess all the 4 bony segments of the upper and the lower limbs and assess the normal orientation of 2 hands and feet, exclude clubfoot, even the first trimester of pregnancy. But sometimes there could be a positional vertical talus deformity, so reassess the patient once again at 16 weeks. It's not necessary to always count the fingers, but I feel that in the first trimester, when you do transvaginal ultrasound, becomes easy to actually count the fingers. So when the patient comes in for an anomaly scan, things become easy when you start assessing in the first trimester. So something you will miss in the first trimester will be agenus of corpus callosum, ventriculomegaly, hypotaylorism, unilateral clefts, bowel atresia, renal abnormalities, more spina bifida, hemivertebra sometimes, and mild skeletal dysplasia can be missed in the first trimester of pregnancy. So coming to the second trimester, so you have to do a systematic evaluation in the first trimester, and the patient comes back to in the second trimester. Always do a systematic evaluation so that you will not miss out anomalies. So have a complete look of the head for the size, the shape, integrity, and density. This was a case, this was an oval shape. This was a lemon-shaped skull, which was seen in the second trimester of pregnancy, and she had a meningocele. This was a typical strawberry skull with bilateral choroid plexus cyst, and she had AVSD. Amniocentesis showed trisomy 18. So assessing the shape of the head is very, very important in the second trimester of pregnancy. And always do a 3 planes in axially, which are the transventricular, transthalamic, and transcerebellar, or document all these images. In the transthalamic, you should be able to see the central forks with the 2 thalami. If you find a picture like this, it is obviously holoprosencephaly. Make sure you go one by one so that you do not miss out anomalies at that point. Next, in the transcerebellar diameter, do a cerebellar assessment. The TCD should be measured. If the cisterna magna is more than 10, always there could be a Dandy-Walker malformation like this, or a mega cisterna magna, and assess the nuchal pad. When you find a cisterna magna less than 2, when you find a complete obliteration cisterna magna with banana shape, then you always have to extensively look for the spine for a meningomyelocele. Next, coming to the transventricular pain, where you have a look at the ventricles should be measured at the atrium, the lateral ventricles, and always look for the anterior and the posterior dilatation. And look for abnormal ventricular morphology and periventricular echogenicity by a complete neurosonogram. When you find a ventricular megaly, think of it could be an isolated finding, or it could be a part of single gene disorders or aneuploidy. So this was a case of Dandy-Walker malformation and Arnold-Chiari malformation. This was an isolated ventricular megaly tested positive for trisomy 21, and they went in for a termination of pregnancy. So coming to the face, a sagittal view of the face is very, very important to look at the nasal bone, measure the nasal bone less than the 5th centile, you call it as unossified. And this is a superimposed line sign to look for palatal abnormalities. Always have 3D, when you have a suspicion of an oropharyngeal mass, this was an oropharyngeal mass, and 3D also showed an oropharyngeal mass, which was tested and showed benign mucinesis. The patient went in for termination of pregnancy. And this coronal view of the face is very, very important. Very often when you do the ultrasound, the patient's delivered and the consultant calls and tells you the eyes were very small. So in spite of doing interorbital and intraorbital distance, we had 1 or 2 cases of microophthalmia, which was picked up, which was not picked up the anomaly scan. And never ever forget to look at the lip to look for cleft lip and cleft palate. And coming to the neck, it's important to look for the cervical meningocele. You can find a cervical meningocele here. This is a cystic hygroma in the neck. And this was a case of a cervical teratoma seen in the base of the, just below the mandible. This was again a second picture of cervical teratoma. All these patients opted for termination of pregnancies. When you do a systematic evaluation, most of the anomalies can be picked up. So this was a case of bilateral jugular lymphatic sacs on either side of the neck, and this patient tested again positive for trisomy 21. And coming to the chest, important always is a typical case of congenital diaphragmatic hernia. We can see the stomach bubble here. You have to measure the LHR ratio. This was a cystic CCAN, which presented to us in 20 weeks of pregnancy, and 34 weeks, the entire lung was filled with the mass, and we had to do a aspiration of the cyst, and the patient delivered without any morbidities, and the patient babies around 2 or 3 months old of age and were doing absolutely fine. This was a solid CCAN, which was picked up in the chest. Coming to the heart, a normal 4-chambered view of the heart is very, very important. Normal regular rate by M mode is very important to pick up premature atrial contractions. It should be 120 to 160 beats per minute, and the heart should be occupying only 1/3 of the chest. When you find more than that, you have to measure the perimeter and the diameter. If it's more than 50 or 60%, think of a cardiomegaly. And always important to measure the left axis deviation, because there could be a left axis deviation either because of some outlet abnormalities. And always take a dual picture so that you know you're on the right track regarding the situs. So this is a 4-chambered view of the heart, and the LVOT and RVOT and the 3-vessel view should be documented in your images so that when you have a doubt, you can always look back at the images. So coming to the abdomen, so some of the common abnormalities which can be seen as a normal stomach, which is with the portal sinus. Here you can see an omphalocele. This was a duodenal stenosis where you find a dilated stomach followed by a narrowed first part of the duodenum. This patient tested again for trisomy 21. This was a small bowel dilatation which was picked up at around 30 or 32 weeks of gestation. She had to undergo surgery after birth. And this was a simple gonadal cyst which was found, and this resolved immediately after delivery. So a systematic evaluation starting from the stomach, entire abdomen would help us to pick up many, many anomalies. And coming to the kidneys, a kidney Doppler is important to the document. If you see the kidneys properly, always put a kidney Doppler so that you don't miss out any pelvic kidneys. When you find a pelvic kidney, you find that there is a vessel coming in from the ipsilateral iliac vessel. And this was a clear-cut case of hydronephrosis. This was a pelvic axial separation. This again was a megacystis bladder due to a bladder outlet obstruction. The like was absolutely fine. And a multicystic dysplastic kidney, when you find many, many cysts of varying sizes not communicating with each other. The difference between a multicystic dysplastic and a hydronephrosis, that in a hydronephrotic kidney, you find this is communicating with each other, whereas in multicystic, it is not. And this was a typical horseshoe-shaped kidney with hydronephrosis, and the patient opted for termination. Am I going out of time? Okay, so coming to the spine, a complete evaluation of the spine in the transverse, coronal, and sagittal view is very, very important to pick up. This is a normal looking spine, which looks absolutely normal. This is the meningomyelocele, and few hemivertebra also can be picked up by a sagittal and the coronal view. And meningocele should be picked up in an anomaly scan, preferably in the first trimester, if not at least at 20 weeks of gestation. And most of the meningomyelocele will have cranial markers like lemon-shaped skull, so and a banana-shaped cerebellum will be seen. And coming to the extremities, a measurement of femur humerus is very important. And absence of presence of radius and ulna is very important, because very often find the radius in the radial deformities, ulna is very short. And it's important to prognosticate pregnancy. The presence of tibia and fibula on both arms and hands should be documented. And look for the alignment of the foot, which is a club foot. And here you can find the polydactyly. Counting of fingers or toes is not mandatory, but if you find a polydactyly, it's always better to document it in your report. And bowing, if you find a femur bowing, it's important to look for that. This patient had a absent radius and very short ulna, and she had a claw hand, and she went for termination of pregnancy. And we had the fetal DNA storage done for this patient. And opening and closing of at least one outstretched hand is very important as per the anomaly scan guidelines. So something which can be missed in the second trimester, the anomaly scan, is a lissencephaly, white matter abnormalities, isolated cleft lip and palate, abnormalities of the thyroid. Diaphragmatic eventration can be missed. See, diaphragmatic hernia can be easily picked up, whereas eventration can be missed in the anomaly scan. Small ASDs and VSDs can still be missed in a routine anomaly scan. Intestinal atresia, hypospadias. This is one area which I felt that it can be missed in an anomaly scan. Tethered cord and mild skeletal dysplasia, which usually presents in the third trimester, can be missed out in a routine anomaly scan. So to conclude, fetal anomalies can be diagnosed as early as first trimester. Gone is an era where we picked up most of the anomalies in the second trimester. Now it can be picked up as early as first trimester, about 50 to 60% as said. But just because she has a complete first trimester ultrasound doesn't mean she does not require an anomaly scan. The patient needs to have a second trimester anomaly scan, because some things like corpus callosum can be CSPs can be seen only in the second trimester of pregnancy. And some anomalies can also be seen third trimester of pregnancy. For example, evolving skeletal dysplasias, hydrocephalus, we still see it in the third trimester of pregnancy. Thank you. Thank you very much for your patient hearing.
Thank you, ma'am, for the clear and crisp presentation. I think the key message from the lecture today is a systematic checklist which we all should follow for the anomaly scan, which has been also advocated by the ISWAG in the form of the 20 planes 2-sweep approach, and it is easily available on the ISWAG website. And that will also help us in uniformly reporting anomaly scans and picking up as much as possible, I think.
Thank you very much, madam.
Thank you. Thank you.
I thank the chairpersons and the speakers for the session. Now we move on to our next part. For the next session, I would like to invite Dr. Prachi Singh, madam. She has done MBBS, DNB, Diploma in IVF, consultant at Ashirwad IVF Center, Muzaffarpur, Ayushman Hospital Endoscopy Center, Muzaffarpur, Bihar. He's on Coordinator Imaging Science Committee, FOGSI 2018, Founder Secretary, ASAPAB, Muzaffarpur. Joint Secretary MOGS, Secretary IMA Muzaffarpur 2019, started first IVF Center of North Bihar in 2013 and have had innumerable successful pregnancies. Recipient of Young Gynecologist Award at first conference of AOGSBJ, presented numerous papers in national conferences, publications in FOGSI Manual of Imaging and in Obstetrics and Gynecology. Welcome, madam. Over to you.
Thank you, Dr. Gurpreet, for the kind introduction. A very good morning to all, and I welcome you all to this very important session of today's scientific program, in which we have 3 keynote addresses by esteemed speakers. To chair this session, I have the privilege to invite stalwarts of obstetrics and gynecology, Dr. Bipin Pandit sir, Dr. FOGSI Lewis sir. Dr. Bipin Pandit sir is the former Executive Council member of Maharashtra Medical Council. Sir is the Vice President FOGSI 2021. He has been the President of Mumbai Obs and Gynec Society 2018-19, the Joint Secretary of FOGSI in 2015. Sir was the Treasurer of AICOG 2013 held in Mumbai, Chairman Violence Against Doctors Cell FOGSI, past President of Medical Consultants AMC Mumbai, former Managing Trustee of Association of Medical Consultants Mumbai, received Lifetime Achievement Award from AMC in 2019, Trustee and past President Fellow Gynecologist. Sir has special interest in laparoscopic surgery, high-risk pregnancy, many publications and presentations to his credit, and Sir has published a book, DocuSmart, on ideal documentation. You're very warmly welcome, Sir, Dr. Bipin Pandit, sir. Our next chairperson is Dr. FOGSI Lewis. Sir is a senior consultant and associate professor in charge MCH course, Department of Reproductive Medicine and Surgery in AIMS, Cochin, Kerala. Sir is the Vice President FOGSI 2021, ISAR National Executive Member, ICOG Governing Council Member 2021-22, Vice Chairperson Kerala Chapter IAGE, Secretary Kerala Chapter of ISAR, Executive Member of Kerala Chapter IFS, All India FOGSI International Committee Chairperson 2013-15.
We are running late. We will go ahead, I think.
Yes, you're most warmly welcome, sir. I request our esteemed chairpersons to take over the proceedings and introduce our eminent speakers. Dr. Bipin Pandit, sir, can you please introduce Dr. Prashant Acharya, sir?
Yes, thank you very much. Good morning to you all, and happy Diwali and prosperous New Year in advance. It's a great pleasure to introduce a great speaker, Dr. Prashant Acharya. I'm sure you must have heard him before, and he's a ISOC board member from 2015 to 2019, ISOC ambassador from 2014 to 20, South Asia and India, and is vice president FOGSI 2012. And he has got very many achievements and awards and publications. And today he's going to speak on invasive testing, prenatally invasive testing. Dr. Prashant Acharya.
Thank you, Dr. Vipin, for your kind introduction. Can I share my screen? Is it visible now?
Yes.
All right.
No. Screen is not visible.
Screen is not visible.
Screen is not visible. I think I'll share my screen first. Hope it is visible now.
Yes.
Not fully. Yes. Make it. Yes.
Yeah, thank you. So today what I'm going to discuss is about invasive prenatal techniques. Now, honestly speaking, these invasive prenatal technique itself is such a long topic. It's almost 2 days workshop, which I'll try and put it across in 20 minutes by showing you some uncommon procedures which you may not have seen. I will try and avoid the CVS and amnios and those kind of routine because there are some talks for that also. Now, the prenatal diagnostic procedures, usually they are, which are usually done is CVS, amniocentesis, photosynthesis, fetal tissue biopsy, which was done previously. Now, an era of genetic testing that tissue sampling has gone. Now, therapeutic procedures are, of course, blood transfusion, fetal reductions, shunt procedures, tracheal balloon obstruction for diaphragmatic hernia, laser surgery for twin-to-twin transfusion, all sorts of monochorionic complication. There are few open fetal surgeries and open neural tube defect repairs which are there. Now, which are the patients which are supposed to be selected? There are a few things. The condition should be associated with long or short-term morbidity if left untreated in utero, and the benefit should be much more than the risk to the mother or risk to the fetus. There are some ethical dilemmas. I won't go into that kind of ethical dilemmas because otherwise it will take much longer time. Now, which are the conditions where we can offer them prenatal diagnosis and procedures? First, I think there is some noise going on. Somebody is. Can you switch off that mic, please? Yeah, thank you. First is anemic fetus. That is one of deep procedure or condition where the outcome is really fantastic. Multifetal pregnancy, especially when there is overcrowding of 3 or more pregnancy because of the ART techniques. Monochorionic twins and an acardiac twin. These are the day-to-day conditions which are supposed to be treated. Now, when there is a fetal environment failure, that is, I would call environment because of if there's a severe oligoamnios or severe polyhydramnios when mother is symptomatic, you can do something to them. Obstruction leading to organ failure, especially with a severe pleural effusion, so that it will lead to a lung hypoplasia, and you relieve that effusion by doing procedure is going to be very effective. And a post-urethral valve, which is going to affect the kidneys and the renal function, there you can do something to these fetuses. Of course, cardiac failure you can always do because of the supraventricular tachycardias. Fetal goiter can be treated easily by giving them the thyroxine to the fetus. Amniotic band syndrome, which ends in a necrosis of that particular fetal organs, can be resected out and the obstruction can be relieved. Sequestration of the lung or thoracic lesion leading to the CCF in the fetus, where baby becomes hydropic because of the AV shunting or arteriovenous shunting. You can always plug in that vessel and you can get relief from the sequestration of the lung. Congenital diaphragmatic hernia, of course, you can create a balloon put inside the balloon inside the trachea and allow the lungs to get expanded by collection of the mucus inside the bronchial tree, which will prevent the lung hypoplasia. That's what the whole concept is. Fetal thrombocytopenia, just like anemia, you can always inject the platelets, not the RBC. Here you are injecting pure platelets to the fetus so that it will not have intrauterine bleeding in the brain or anywhere leading to the organ malfunction. Placental chorioangiomas, and of course that they will also work as an AV shunt and can lead to the problem. And you can always treat them by plugging it by injecting the thrombotic agents or by putting the laser inside. Critical aortic stenosis. Aortic valve, when it is stenosed, you can, just like the balloon valvotomy, just put in a balloon there, pull it out, you just create an artificial rupture of that stricture. You can relieve that critical aortic stenosis so that you prevent the left heart failure, and by treating them, you can have a good, reasonable outcome inside utero. Once baby comes out, then you can treat perfectly. Of course, acardiac twin by using laser or radiofrequency ablations. Some open fetal surgeries for open neural tube defects, or even fetoscopic surgeries for the open neural tube defect has been done across the globe, but there are a few issues with India. Yet we have not started those doing, and we are already equipped to start. In near future, we are going to start these fetal surgery along with the spine surgeons. So that is where we can offer
a powerful communication medium.
So that there are few things which you are supposed to do is always take a consent, F form, PCP, NDT, antibiotic prophylaxis, and tocolytics. That's different thing. But complications has to be explained in detail, and success has to be done in detail, and be very honest on explaining all these complications.
Presentations
I'm sorry. I think there is something which is going on. A minimal standards and protocols which we have published for FOGSI. This is a FOGSI publication. In 2012, they are all updated, and that's all. Always we can take it forward. Now I have divided to show you those video into two segments. Early interventions that is done before 16 week, and after 16 week they are done in later than 16 week. Possible procedures for chorion villus sampling, fetal reduction for triamniotic, trichorionic, simple fetal reductions. But when it is associated with one of the monochorionic pair, the entire system becomes different. That is where the things are going to be. Fetal reduction in one of the monochorionic twin by choice is also a different ball game. How to do it? What are the choices? An acardiac twin. These are the ones. These are the indications where you can possibly approach them earlier. When monochorionic pregnancy is involved, you cannot inject the pharmacological agents like potassium chloride or xylocaine, because it will go through the vascular communication to other fetus, and other fetus will also die. There you have to apply the mechanical energy, and that is either by radiofrequency ablation, laser coagulation, or by bipolar cord coagulation. These are the things you can do it, and we will see some of the procedure. The baseline principle of doing any procedure is simple. Your needle has to be in line of the probe. When your probe is like this and your needle is like this, or when your probe is like this and your needle is oblique, you will not see the needle inside, and there you are going to fail miserably. So that is the baseline, basic principle of fetal intervention. So make sure that whenever you intervene a fetus, or whenever you do any procedure, you have a precise needle position. So CVS, of course, I am not going to show, neither I am going to show you the simple potassium chloride kind of fetal reduction, but let me show you how you can do laser. By using the laser, how you can reduce one of the fetus whenever you are the involvement of monochorionic twin is there. This is where this is if you really look at this is the laser fiber which is going on through the needle. This is the laser fiber. When I apply the energy, just look at this, and I will also show you the procedure right on both the side also. Just have a look at this. This is where I'm just putting my energy here, and the entire fetus, the region. There are 2 points where I can intervene. This is one at the insertion. This is where I'm going to coagulate both umbilical artery as well as the umbilical vein here at this point, and here I'm going to coagulate the ductus venosus. So that's how I can put in my laser fiber when I want to introduce. I want to intervene early in pregnancy. Let us again. I'll show this is an acardiac fetus, acardiac twin. One from the monochorionic. This is normal fetus. This is acardiac, and this is the same way I'm going to intervene, just like same with an acardiac twin. This is radiofrequency ablation. What in radiofrequency ablation? It is we have to put a small nick, just a small nick, because the needle is 17 gauge. This is the needle which we just put inside. You can see the needle, my needle is parallel. Look at this region. My needle is coming. This is my needle. It has gone to the base near the fetus, and yes, just I have entered the heart, near the heart, and I will pull out the prongs from the radiofrequency ablation. 3 prongs will come out, and this is going to coagulate almost 1.5 centimeter square area, and which will stop the circulation mechanically. This is especially used. This is one of the procedure. This is useful. This is really very good instrument, and a package. And once it will take 1 minute, this is electric energy, which will convert it to the heat. This is where the things are attached to the machine, and this noise will throw the energy. It will make the element heated up, and it will eventually heated up in mechanical heating of the core tissue. That's how it is going to be done. Now the fetal intervention procedure later in the gestation after 16 weeks, again amniocentesis, I'm not going to show. Let me show you the fetal anemia or the fetal transfusion. Of course, you know the important causes for fetal anemia. I'm not going into the detail, but one of the important point is the measurement of PSV when there is zero isolation angle. What we do use is the EcoTip amniocentesis needle. I've just injected a local. Just see at this region. I have given the local anesthesia. This is my target. Here is, if you can see, this is needle. My needle is just pushing at the base of the cord. And once the base of the cord is pierced, yes, that's where the base of the cord is pierced. And let me show it to you again. That is the base of the cord which is pierced. Once it is there, what you are supposed to collect the blood for CBC, for fetal blood group, and direct Coombs test. Once it is there, you attach a three-way, and once the three-way is attached, the blood has to be pushed with the syringe. If you can see here, the blood is being pushed with the syringe inside. And now whatever quantity you have calculated before starting transfusion, you will be injecting the same quantity of blood by rotating, by getting blood from the bag, rotating the stopcock and pushing it inside these fetuses. Let me show you some of the procedure. This is just I did day before yesterday. Here you can see I've just put in my needle here, just here. Now that needle is placed inside. Now look at this video. Once you inject, that is how the turbulent flow which is going to be visible, and you can carry on the procedure. It was a twin pregnancy, so we had to transfuse both the fetuses simultaneously, one after another. So that's how the fetal transfusion is being performed. Of course, the fetal transfusion, we have now more than 704 transfusions with really almost 80% of success. But still, people are referring with the stage of hydrops. We have almost 30% referrals only after the hydrops has developed. That's where we as an obstetrician needs to redefine ourselves and diagnose anemia before it develops hydrops to have better outcome, because there is going to be a little difference in the outcome. Now coming to multifetal pregnancy, more is not always merrier. And whenever you are dealing with dichorionic pregnancy, I'm not worried. But when I'm dealing with monochorionic pregnancy, I'm really worried, because these monochorionic pregnancy will have its own different complications, different set of complications, and that needs to be addressed. And all complications in monochorionic are because of the discordance. Whether discordance in amniotic fluid, one is more, one is less, we call it the TTDS. When the Dopplers are altered, we call twin anemia polycythemia sequence, because one fetus is anemic, it will show different Doppler, and one is polycythemic, it is going to show you different Doppler. Difference in the size, we call it a selective fetal growth restriction, and one fetus having malformation, one doesn't have malformation, like an acardiac twin, we call it the trap sequence. So in all monochorionic twin, remember one thing, evaluate them every 2 weeks for biometry, amniotic fluid, deepest pool, uterine umbilical artery Doppler, MCA, PSV, ductus venosus, and a complete brain examination. 2 weeks, every 2 weeks, all monochorionic pregnancies are to be evaluated to watch for all the typical classical 4 complications like TTDS, selective growth restriction, TAPS, and trap sequence. So let us see what is the basic pathology for that. If I show you, let me show you. This is, I will freeze this. Look at this. This is the membrane, as you can see. This is the vessel which goes here. It goes inside the substance and it crosses the membrane and it goes to the other side. Look at the same here. It is coming from this side. It goes in the substance and these vessels are coming out. Okay, these vessels comes in, goes in the substance here, and it goes to the fetus. There are all arteriovenous malformations which are happening. Look at these are the points. And these vessels are creating problems. Look at this. This crater is red dye, green dye, no vascular communication. But look at the surface of the placenta. You can see many communications which are there, and these are the ones which is going to lead to all sorts of complications because of that. To treat twin-to-twin transfusion, again there are simple phenomena. Just on putting the fetoscope inside, what I will see is of course this is the fetal face which I see easily. But look at the one of the most important point is the membrane of the other fetus is going to be just like adherent on the surface, body surface of the fetus. And these are the vascular architecture on the surface. Look at this. Look at the. I think it must have gone to that membrane is very sticky. Once the membrane, you can see those kind of picture. The best option is you can put in your laser there and try and identify those vascular anastomosis which I show you there, and put the laser energy and try and coagulate those. Now let us see how we can do that. This is a video on your right side of the screen. Look at this. You have got, these are the vessels which are on the surface of the placenta. My laser fiber has come out from the scope, and I have applied the energy, and this has coagulated the surface, those vessels. Look at this. This is one going in and out. Just I apply the laser fiber right there, point it out there, and start applying the energy, and it is going to completely coagulate the entire system, and this is going to stop the circulation. So that's how we identify all communications and go on coagulating all those vessels and try and prevent the blood or RBCs and also going from one to another. So that is how one of the important point is. Another situation is if patient can afford laser, because which is really one of the costly thing, around costing 70 to 80,000 rupees. But important point is the outcome is 55% for both fetus, with a 9% of cerebral palsy after the laser. If we counsel like that, or if patient, those who cannot afford one, if the patient wants only one but good child, this is one of the option we always say. A bipolar cord coagulation. This is 2.9 millimeter bipolar probe. You need no specific instrument. It's a trocar bipolar forceps. Just put your bipolar that trocar inside the pregnant uterus. You can see here it has right gone inside, and just you withdraw your trocar, cannula is inside. Put your bipolar forceps inside, catch hold of the system, and catch the cord. This is my forceps is here. I will try and catch the free loop of the cord. At least it has to be coagulated at 3 places. Just see here. I have just catch that umbilical cord, applied the energy. Because it is heat, it will create the fumes like on my screen. And that is how I will do my bipolar cord coagulation. And one of the fetus, I will make sure that one of the fetus is going to be completely stopping the blood flow, and this is going to be completely stopped. And that's how it will going to eventually stop the entire situation. in TAPS, anemia polycythemia, we try and inject the fetal transfusion to one of the fetus, or we can offer them the cord coagulation. That is what we can always offer them. Intrafetal laser, if you found the acardiac twin which grows bigger than the normal fetus, or it is causing CCF, you just go in to the feeder vessel, apply the laser, coagulate completely, and that is how you do it. Now, some of the pleural effusions you can put in. I have got still 2 minutes, so I'll show you that shunt, and then I will stop. There are two different kind of shunts which are available. One is Harrison shunt, and there is another shunt which has come up, is Somatec shunt. And just looking at the let us look at the Harrison shunt first, and also we can offer them the intrafacial interstitial, in utero fetoscopic fulguration of the posterior valve. This is the bladder in the bladder, if you inject the somatic shunt, eventually what will happen? This is going to drain. And can somebody stop? Mute the Soumya. Soumya needs to be muted. Admin, can you please mute?
Yes, it's done, sir.
Okay, all right. Still it is there. Fine. So once the shunt is being placed at appropriate point, one end is going to be inside and one end, this is shunt is going in. This is the shunt which is placed inside, and you withdraw the stellate, and you can see the urine is being drained out. That is one of the thing in a post-urethral valve. Another situation is we have started doing this in first time in India or first time in Asia by fulguration of direct post-urethral valve. This is in utero complete therapy. This is where we have put a fetoscope right inside the fetal bladder. And fetal bladder, you can see the keyhole appearance, keyhole of the neck, bladder neck obstruction. And once you can see the membrane, which is which is obstructed. Just go put in laser there, laser fiber, cut it appropriately so that the urine which is collected inside the bladder, this is going to be it will create a natural passage and that will end up in a complete correction of the post-urethral valve inside in utero only, rather than placing a Harrison shunt, because there are a lot many issues about putting a Harrison shunt. So I will skip some of those things. Again, this is one where you can always put a shunt. I'll show you. It is just like a copper T. As you load the copper T, the shunt has to be loaded, and also it has to be kept inside. This was the case of pleural effusion. This is the Harrison shunt, and these coiled structure are to be kept like a long, and it has to be loaded on loader, just like a copper T. You just load them, then put the trocar inside the obstructed organ like pleural effusion, or inside the bladder, and insert your this by push and pull technique at appropriate level, and that is how the shunt procedures is supposed to be done in utero. That's a shunt. That's a trocar. Just put in trocar and cannula. It's a special trocar. It will you go right inside the obstruction side. That's where you are gone to a pleural cavity, because the pressure is too high. Even with the larger diameter of the trocar, you can see the fluid which is gushing out. So that much pressure is there. The baseline idea is to relieve that pressure. So you just introduce that shunt inside the pleural cavity. Here we are doing it in pleural cavity. So by push and pull technique. So there are markings. So you push and pull those certain things inside, and that is how everything, all the entire procedure is supposed to be done. So the baseline concept is what? You may have a fetal goiter. Again, you can treat the moment you see the fetal goiter, because now there is a fashion of doing TSH. Only TSH is useless investigation. When you investigate a mother, it has to be TSH and free T4, because till 26 weeks, it is a free T4 which will go across the placenta and will be supplied to the fetus. Only TSH is indicated once a lady is on thyroxine. Whether the dose is appropriate or not, that is where you can only monitor by TSH. If you are interested in looking at whether baby will develop a goiter, which is eventually lead to whatever you say, that the baby's IQ is going to be low or blah, 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 which may not be a very, very, very correct kind of decision, there you should be doing TSH as well as free T4. A lady who has got low T4 and high TSH, they are the ones, they have got chances of developing fetal goiter. A mother who is hyperthyroid on drugs, they are the one who will develop these goiters. A hypothyroid lady with TPO antibodies positive, they are the ones who will develop fetal goiter. That they are the ones who need real careful monitoring, looking for the fetal goiter. Go and ask for the fetal goiter. The moment you can see the fetal goiter, put the levothyroxine by injecting through the needle near the fetal mouth, and baby is going to engulf, the baby is going to drink that levothyroxine, and will have a complete kind of management. Carry-home message is simple. You can do lot many procedures in India. You can save lot many lives, and with the real good perinatal outcome. Thank you. Thank you very much for patient hearing.
Thank you, Dr. Prashant Acharya, for an excellent lecture. And I'm sure the delegates and the audience must be thrilled to see your fantastic videos and the invasive procedures which you have shown. I'm sure this is the future of fetal medicine, and more patients will get benefited because of your procedures.
Thank you.
Thank you very much. And I would request FOGSI to introduce the next speaker. And admin, please mute all others except the speaker and the chairpersons.
Can you stop sharing the slide?
Yeah, I will just.
Okay, it is my proud privilege to introduce my good friend who I know for last 25 years, a true clinician and a dedicated teacher, and who was always into the work. Can you stop sharing? Okay.
Yeah, I think I have stopped sharing.
Yes. So can you put the CV of Dr. Balu? Okay, Dr. Balu Vaidyanathan is a clinical professor and pediatric cardiologist head of the fetal cardiac division at Amrita Institute of Medical Science, Kochi, Kerala. And his major career achievements are he is official training coordinator for the government of Kerala and NHM Mission Kerala in the fetal heart training program for gynecologists and radiologists, national coordinator of fetal cardiology working group of Society of Fetal Medicine and Pediatric Cardiology Society of India, and trainer in fetal heart education program of the ISUOG, and member of the Global Fetal Heart Focus Group of Volusan, Austria, and global trainer for the Volusan G in 3D, 4D fetal echocardiography in the Asian and South Asian region. And he will be talking today about the counseling and impact of prenatal diagnosis of fetal cardiac defects. Over to you, Dr. Balu.
Thank you, Dr. FOGSI. May I share the screen now? Okay, just give me a second.
Yes.
I hope my screen is.
Yes.
There's a lot of background noise, so I think maybe the organizers can do something about that.
Please mute all except Balu.
Okay, thank you so much to the FOGSI team and for inviting me for this lecture. And today I'm going to talk to you about what we should do once we diagnose prenatal heart defects during the prenatal life. The three important aspects which I want to discuss with obstetricians today is, number one is prenatal screening of the fetal heart. What should the obstetrician know? The second key aspect is counseling and pregnancy management. What you should know to make the right decisions. And finally, you should also know what teamwork and a dedicated system can achieve as far as the impact factor is concerned. And I will leave you with some messages which you can hopefully follow. The Indian scenario is that it's a very large country. We have about 25 million births every year. Congenital heart defects occur at a frequency of 6 to 8 per 1,000 live births, which is a constant feature all over the world. And in India, when we extrapolate these numbers, this comes to about 250,000 babies born with heart defects every year. So this is perhaps the single largest number of birth malformations when you take as a group. Of this, about 1 lakh children are expected to need surgery in the first year of life, and about 37,000 will require surgery in the first 1 month of life. Now, in states with low infant mortality, like Kerala, where I practice, congenital heart defects is an important contributor of infant mortality. Now, when you talk about antenatal screening for CHD in India, it's like looking for a needle within a haystack. And this is a great paradox. We have these meetings and we have great talks But the problem is most of us practice in ivory towers. The expertise is available in a very few centers in the country. Most patients with fetal heart defects occur in low-risk pregnancies. There are no clear protocols for screening being practiced in vast parts of the country. There is limited infrastructure and personnel, and hence I have to say that the overall prenatal pickup rates of even major heart defects is very, very low in the country. Now, when we talk about prenatal screening for heart defects, there are two kinds of approaches. Most of the obstetricians tend to focus on the high-risk group, while what we need to remember is that most of the defects in numbers, they occur in the standard run-of-the-mill low-risk pregnancies. So these are some of the high-risk pregnancies where heart defects can be more often found. And these include the fetal indications, include an abnormal heart as seen in the screening, presence of extracardiac or chromosomal abnormalities, presence of non-immune high drops, high-risk pregnancies like IVF or FOGSI, then increased first trimester NT. Maternal indications include a mother with a heart defect, maternal autoimmune disease, which can cause fetal heart block, exposure to teratogens or metabolic disorders, or intrauterine infections. In the familial indications for fetal echo, the important conditions would be a previous child with heart defect or presence of Mendelian syndromes. Now, the ideal time for fetal heart evaluation would be somewhere in the mid-trimester anomaly scan. That's the time when most of the anomalies are picked up. There are many people in this country who are very good in first trimester fetal echo as well. So that's also a possible window. And that should be a part of the early screening along with the NT and other things. Even sometimes in the late pregnancy, many heart defects can be picked up, and this can have a significant impact on the way we counsel and manage, particularly the correctable problems. Now, there are several protocols which are laid down for fetal heart screening. The more popular ones would be the ICE-WORK protocol, which involves serial images in the transverse view of the fetal heart, starting from the abdominal situs to the four-chamber view, to the outflow tracts and the three-vessel view. So this is a very standard protocol. Many of you practice this. But in my opinion, even if you see three views, the four-chamber view, the outflow tract, and the three-vessel view, and apply this correctly, most of the abnormalities can be, in fact, at least suspected, and then can be referred to a more better expert for a more detailed evaluation. Now, we did this process in Kerala, and this is one of the most important things which we did in the last few years. So during this period of 2017 to 18, we did a number of workshops initiated by the government of Kerala and the National Health Mission of Kerala. We trained more than 500 doctors, almost 600 doctors, mostly from the specialties of obstetrics and radiology. And we actually created this flashcard, mostly adapted from the ICE-WORK protocol for the fetal heart evaluation. Also came up with a small 35-page booklet, which contained what we should do, when should you refer, what's the standard protocol, indications, and the downstream pathway. And this in a recent paper by Srihari Nair, he's a part of the NHM in Kerala, which is published in Global Heart. The data came on the impact of this training. A lot of doctors who attended this program reported that their skills actually got enhanced. And most of these doctors felt that they are now comfortable examining the three-vessel view and the outflow tracts. And the direct evidence for this impact of the training came from this registry of newborn with heart defects in Kerala called a chronic registry. The pickup rates for major and critical CHDs now in Kerala is about 21%. Mind you, this is a population registry and not just restricted to few highly specialized centers. So this is a population pickup, it's about 20% in Kerala. So that's the first part. So that's about what the obstetrician should know about the screening of the fetal heart. So do the basic three views in all cases, even in low-risk pregnancies. Now we come to the counseling and decision-making, and that's where teamwork is very important. Now, some questions are important when you talk about counseling fetal heart defects. We should know about the diagnosis, the natural history of the heart defect, the presence of other factors like extracardiac or genetic defects. And then we need to put in a number of factors like gestational age, what are the treatment options, what are the outcomes after treatment, are there any long-term issues, what are the costs, initial or recurring, and is there any funding support available? And so all these factors will impact the decision-making. And we have different options, and this needs to be exercised based on the laws and regulations. We can terminate a pregnancy if that's a very complex problem. We can refer for planned delivery and postnatal care. Few conditions we can manage in utero, like arrhythmias. And the last is a planned comfort care, which is when there is a late diagnosis of a complex heart problem, where the family does not want to go for a tertiary pediatric cardiac care. The family knows that there is a heart problem, and hence their consent for not to go for intensive care may be taken. That's what's called a comfort care. So all these options may be discussed. Now, what is really interesting is that the whole scenario has changed now. There is this amendment of the MTP Act now, and which has changed some of these standard practices. But the question is the diagnosis of any congenital heart defect an indication for termination? It's an absolutely no, because it's not at all a correct practice as per science. So for this, the obstetrician need to understand that all congenital heart defects are not the same. So we have minor defects like small VSD and echogenic focus, which is completely non-cardiac. It's actually not even an indication for fetal echo. Then mild tricuspid regurgitations. These are really non-entities. Then you have more major lesions like tetralogy, transposition, coarctation, VSD. And then we have complex lesions like hyperplastic left heart syndrome, heterotaxy heart, severe Epstein's anomaly. Now, if you want to compare these with each other, it's like comparing apples with oranges. They are not the same. And hence, we cannot have one single formula for counseling every heart defect. You need to know what each of this means. Now, in my opinion, there are some conditions which are truly difficult to salvage. One is this complex heart defects which have poor long-term outcomes. This includes conditions like hyperplastic left heart syndrome, heterotaxy, very complex pulmonary atheresias. Second is heart defect, which is associated with major extracardiac anomalies. Heart defects which are associated with major genetic anomalies. And then when there are major comorbidities like extreme prematurity or low birth weight. Apart from these, pretty much everything else we can actually offer good treatment. Now, which is the most critical view? The four-chamber view. The four-chamber view actually separates the heart defects, which can be corrected completely. They have two good-sized ventricles. Versus when you don't have two good-sized ventricles, when you have a univentricular heart, then the outcomes are not so great. So these are some of the very complex heart defects. On the top, we see hyperplastic left heart syndrome with a small left ventricle. Here you see Epstein's with severe TR, gross cardiomegaly, even high drops can develop. And this is an example of a heterotaxy heart or right isomerism, where again, you can see that there is only one ventricle. And when these are associated with extracardiac anomalies, which can occur in about 30% of all heart defects, or genetic abnormalities, again, can be seen in only 30%, not all. Like this is AV septal defect, which is associated with trisomy. And this is an example of a truncus, which can be associated with 22q deletion. Now, many conditions like transposition of great arteries, typically, very rarely are they associated with extracardiac or genetic abnormalities. Now, when you see these complex heart defects, typically characterized by a univentricular heart, and when you take them long-term after surgeries, and the typical surgery is usually not one operation, multiple operations, they tend to have problems. And this is the long-term follow-up data from Australia and New Zealand after the Fontan procedure for single ventricle. And when we see about 20 years down the line, a number of patients actually develop heart failure and problems related to that, and particularly hyperplastic left heart syndrome. So this is what we actually observed in our own data. So we published the outcomes after the prenatal diagnosis of univentricular heart from our center. We had 500 plus cases, only 215 were born alive, of which of the ones who are born, about half of them only went for cardiac surgery. Now, the important thing about this data is that when there was an intention to treat, 119, they did well. Most of them survived. But when there was no intention to treat, either in utero or after birth, it was a poor outcome. So overall, it has a significant impact on the outcome. So what I'm trying to say is that just by doing the four-chamber view, you can actually pick up these complex defects, and then appropriate counseling can be taken during the pregnancy. On the other hand, when you take the outflow tract lesions, you have conditions like tetralogy of Fallot, transposition of great arteries, coarctation of aorta. And when you actually go for surgery for this patient, this is not one surgery or an anecdote. This is our entire 10-year data, more than 5,000 operations done. And our center now performs all heart surgeries for children with heart defects with a mortality of 2% or less, including a large number of newborns. And when you take adult survival, when the four-chamber view is actually normal, which is the spectrum which I've shown in this red box, the adult survival is more than 95% in most of these lesions. So what we are trying to say is that every heart defect does not perform the same after surgical correction. There's a good number of them actually do very well. And these are some of the pictures. So this is a newborn after the TAPVC repair. I'm holding a transposition baby 6 months after surgery. Many of them go to schools, and actually a couple of my patients have actually become medical students as well. These were tetralogy and this is a TGA. So obviously, if somebody tells me that all heart defects, treating them is futile, I will probably stop this lecture straight away and go for something else. So it's not the same. It's actually, a lot of them do very, very well with treatment, and many of them are normal people. So the prognostic heart defects has to be based on the individual lesion. Many of them, like AVSD, if it's not associated with Downs, TOF, TGA, coarctation, they have excellent long-term outcomes. Even some of the single ventricles like tricuspid atresia, double inlet LV, etc., they have a fair prognosis. Only complex lesions like hyperplastic left heart, heterotaxy, complex pulmonary atresia, severe forms of Epstein's, they have a poor or guarded prognosis. So fortunately, 80% of the heart defects which we diagnose in the fetus, they have very good outcomes with treatment. So that is what the obstetrician should know. So when you counsel, be very careful. Don't just go on a very loose manner and counsel that heart defect terminate. No, that it doesn't work like that. You need to actually either know the prognosis or you need to inform somebody who knows the prognosis, like a cardiologist. So the information has to be according to what you practice. A cardiologist should be the one who should primarily prognosticate about the heart defect and the treatment options. The fetal medicine, genetics, and radiology people should actually prognosticate on the other factors like presence of extracardiac or genetic evaluation. And the role of the obstetrician truly is to consider the information provided by all the other specialists and then take a decision. Then only the decision making will be correct and scientifically accurate. Now, let us see the third and the final part of this lecture, which is what is the impact of prenatal diagnosis of critical CHD. And I do hope that this segment will encourage some of you to maybe consider, referring to pediatric cardiologists, because this is really stunning. Now, when you have a prenatal diagnosis of a critical heart defect, it really offers a lot of advantages. Number one is the families can be counseled and can be prepared and motivated. So you are actually going in for a major something after birth with a lot of preparation. It's like going for a major tournament, like, with the preparation. So you are mentally, physically, and financially prepared. The very important advantage is that it can avoid newborn transport because delivery can happen in the same center and the cardiac care can be provided in an expedited manner. And we have shown, and others also have shown, that when you have a prenatally diagnosed case delivering in the cardiac center, the preoperative condition of the baby is better. The baby stays in the ICU for a shorter period. The outcomes are better and the costs are also lower. And these are some papers which came from Western countries. And a lot of people will say, oh, we can't replicate that here. Ours is different. This is India. But now I will show you the Indian data. So what we have done is over a period of last 10 decades, we have developed a comprehensive program. In fact, most of the centers do have. And all we have done is basically gel the people together. So we have the prenatal services, including fetal cardiology and fetal medicine with obstetrics, genetics, and counselors. So we diagnose, do a multi-system evaluation, and then counsel. Then we have the high-risk obstetrics team, which looks after the delivery with immediate care by neonatology. And once that is done, we go for the postnatal care, which includes pediatric cardiology, surgery, the intensive care, and so on. And this is done in a very seamless manner. Every aspect of the program is knit with each other. And I am just a member. My main job is to talk to some of my colleagues. So we have Dr. Radhamani, the head of the Department of Obstetrics here. Then Dr. Krishna Kumar, who is an absolute light of the program, initiated the program of pediatric cardiology in Amrita, one of the stalwarts in the field. Dr. Brajesh is my lead pediatric cardiac surgeon, young man, but he has operated a 1.5 kilo TGA and has brought the baby out with flying colors. We have another legend, Dr. Sheila Nambudiri in genetics, Dr. Jayasri in neonatology, and of course, our own Dr. Vivek Krishnan in fetal medicine. So this is a team and our colleagues, we work together towards the outcomes. And what have we done? The impact. The real impact of the work cannot be done in an anecdote, one case or two cases. What actually has done is that in Kerala, together in partnership with the government of Kerala, we have actually developed a system for universal healthcare for children in Kerala. This is called the Hridyam program. And between 2016 and 2021, Kerala reported lowering of its infant mortality rate from 12 to 6 per live birth, 1,000 live births. And this is the statistic. The overall all-cause deaths in infants decreased by 21%. And look at the reduction in deaths due to congenital heart disease, 41% reduction in deaths because of the initiation of this Hridayam program. And this has been a very, very dynamic program which involved a lot of educational activities on prenatal screening, newborn physical examination, postnatal screening, and postnatal follow-up. So it is not just something which was done in an ivory tower. We all went to the field and met the doctors working in the field, periphery, trained them, and actually developed this whole network of services, which is now functioning in an absolutely brilliant manner. And in our own center, this resulted in a significantly increase in the referral patterns. The number of planned deliveries after prenatal diagnosis of heart defects increased. And now about 40% of our newborn cardiac admissions actually have a prenatal diagnosis. And I do have data that after the initiation of the Hridayam program for treatment of congenital heart defects, the termination rates after prenatal diagnosis became half, from 39% to just 21%. And most of the terminations happen in very complex heart defects. We also showed that with the prenatal diagnosis, the preoperative condition of the baby is actually better. The newborn can go for heart surgery at least 5 days earlier compared to when diagnosis is made after birth. And we also showed that the in-hospital mortality after newborn heart surgery came down from 9% to 2.9%. So this is only newborn heart surgery over a 10-year period. In a very critical but correctable heart defect called transposition of great arteries, in a recent paper published in Ultrasound and Obstetrics and Gynecology, we showed the impact of prenatal diagnosis and planned delivery. Of the 64 babies who were born, 54 were delivered in a cardiac center versus 10 in a maternity hospital. And those who were born in the cardiac center had a significantly lower mortality compared to those who were born in maternity hospitals and then transported. So this shows the impact of planned delivery in a cardiac center. And finally, we also showed that following the prenatal diagnosis, the cost of newborn heart surgery also was lower. In fact, the prenatal diagnosis and planned delivery offered a 20% reduction in the overall cost. Because transportation could be avoided, the number of centers, the stabilization was less required, and the preoperative ICU stay could be reduced as well in the prenatal group. So how do we move forward? So I'll just take a couple of minutes to complete the story. So I believe that this model, which we have developed in Kerala, can be scaled up to many parts of India, particularly those areas with infant mortality of less than 25. So what you need is antenatal services for prenatal diagnosis, the tertiary pediatric cardiac care, and this is available. What is critical is to develop the in utero referral network and the funding support through preferably the government support. The network has to be interconnected with primary screening at the level of obstetrics, a detailed diagnosis at the level of fetal medicine radiology, and then the tertiary pediatric cardiac team. And we need this crosstalk between each other. And as Dr. Bela discussed in her lecture, the screening has to begin early at the first trimester itself, because many of the complex multi-system anomalies can be picked up there itself. The mid-trimester anomaly scan should be used for comprehensive diagnosis, counseling, and decision-making. And in the final second half of pregnancy should be mainly used for following up and planning the peripartum care. And when it comes to counseling fetal heart defects, the obstetrician has to be counseling in a very judicious manner. You need to distinguish between those who have poor risk, which is very complex CHDs, or CHDs with multi-system anomalies. So these are the cases where early diagnosis and termination is justifiable. For benign lesions like echogenic focus, small VSD, all that is required is reassurance. While for critical correctable problems, you should always try to refer to in utero to a pediatric cardiologist for a planned delivery in a cardiac center and postnatal care. So the final message, the projected scenario for India is that we should move towards a universal screening of fetal heart in all pregnancies. Two options we have: complex defects, go for early diagnosis, counseling, and perhaps termination if the family cannot afford care, while critical correctable CHD should be going towards a referral to a pediatric cardiologist for planned delivery and care. And this way we can optimally utilize the resources and we can reduce the long-term morbidity and healthcare costs. So this is a baby recovering after arterial switch in our ICU. The eyes of the baby tell the story. It's twinkling and sparkling. So thank you so much for listening to this lecture.
Thank you, Dr. Balu, for that excellent talk on antenatal cardiac screening and the clear-cut message to the gynecologist and how we can move forward from here also. And I think we'll be taking the questions at the end as we are running late. Next, I think.
FOGSI, can I just say something? I have to actually leave because of something which is very important. So if there are any questions for me, if I can take it, otherwise I can sort of answer the questions later. I have to leave now because of an emergency.
You are muted, Dr. Parchi.
We will take the questions later, sir, because we are already late. We are running late.
Okay, in that case, with your permission, can I leave because I have to attend an emergency scenario at home?
Okay, sir.
Thank you, Doctor.
Thank you.
Thank you, Dr.
Thank you. Thank you, sir.
Thank you.
I now request Dr. Bipin Pandit, sir, to please introduce Dr. Deepika Dekha, madam, for his talk.
It's a great pleasure to introduce Dr. Deepika Dekha. She's going to speak on IUGR and what problems in detecting. She's a past president in 2014-16 and founder past president of Society of Fetal Medicines, past chairman of Indian Society of Perinatology and Reproductive Biology, past chairman of Genetic and Fetal Medicine Committee of FOGSI, and she has taken training abroad and done various fellowships and written various articles. Dr. Deepika Dekha, the floor is yours.
Thank you.
Hi, Dr.
Can I
Deepika.
please share my screen?
Good morning, Dr. Deepika.
Good morning. Good morning. That's Shanta?
Yes.
Okay. I too, have some things, so I'll just go straight to the point. So thank you very much for the invitation. I'm trying to get full screen. Okay. My topic is not, as exciting as the previous two talks, but I think it's very, very important for the general obstetricians and also the fetal medicine specialists who, in and out, we see these cases of IUGR. And it was very, very interesting, the topic, whether our knowledge itself is restricted. I think it is, because there are so many things that we still do not know, like even the definition, what is an IUGR, whether it's a symmetrical IUGR, asymmetrical IUGR, how to classify them, whether to classify according to the period of gestation or how. And then, of course, the causes, the monitoring, how to monitor, most importantly, when to time the delivery, depending upon the different case, and so on. So it's very, very important in the beginning that we should evaluate these cases, whether they are symmetric, asymmetric. The slide is not very clear, but okay. So early insult, or was it a late IUGR? So that needs to be done. Now, is it very difficult? I mean, is it very different? The small baby because of prematurity and the small baby because of IUGR? Sometimes yes, and most of the times no. Because, these babies with IUGR have separate complications, as you can see. Stillbirths, hypoxia, malformations can be there. In neonatal period, both the types of babies do almost the same, but the long-term health issues can be there, especially for the IUGR babies. So there's a lot of research which needs to be done. Very, very important is for the accurate diagnosis of IUGR. We should not overdiagnose and we should not underdiagnose. We all know that, examination alone is not very accurate. Even with a single, ultrasound, it's not, and we may need to do ultrasounds very accurately to see the estimated fetal weight and all the various levels of measurements to come to the accurate diagnosis. There are very different types of IUGRs, as you can see in this chart. So newborn may be small for gestational age, but may not be having IUGR. Another one may be having, you can see the curves here, this SGA and IUGR. Here there is IUGR, but there is no SGA. And this is SGA, but not IUGR. So it seems to be very, very confusing. And our knowledge certainly needs a lot of improvement. We must not overdiagnose. Unnecessarily, there's a lot of hospital cost and higher demand of specialists. Neither should we underdiagnose. Classification is a major problem. What is moderate IUGR? Between the 3rd to the 10th percentile, severe IUGR, because the prognosis is totally different and the management would be totally different. So there are different hypotheses which says that the causes for IUGR being different, the management also should be different. Again, there are the types: very early IUGR before 28 weeks, early IUGR between 29 to 34 weeks, and then the late insult IUGR after 34 weeks. And the morbidity, mortality, management, everything, investigations differ. So here we really need to do. Also, we do not have, as I said, a proper classification or a proper staging of the IUGRs. We know that now most centers, we depend upon ultrasound. Ultrasound of not only just the size of the baby, the various measurements, but the Doppler. And it is the Doppler which has really changed the management of this IUGR baby. The umbilical, the middle cerebral artery, the amniotic fluid volume, all these things have come a long way, but there is still a lot that we need to know. Our knowledge is still restricted. There was another classification which I found in the literature based on the staging, which again depends upon whether the percentile is below the 10th percentile or low, or whether the Doppler of the middle cerebral artery or the umbilical artery is abnormal or normal. So these various classifications are there. Also, we have to give a lot of importance to the amniotic fluid volume, and that plays a very major role. If the AFI is less than 5, then the prognosis becomes bad. So management, also we still have no consensus. There is a lot to be managed, known. If it is stage 0, then you can even deliver a term. Stage 1, we can go on till about 37 weeks. But beyond that, we may have to deliver at 34 weeks, especially if there are twins. We may even have to deliver at 32 weeks. So it all depends upon the type of the IUGR, the cause of the IUGR. And the biggest problem is we don't have any treatment. We can only monitor. There are lots of things like bed rest and albumin infusions. I know that in private, a lot of people give the mother IV amnio infusions, albumin infusions. They put them on various sorts of vitamins, aspirin, even heparin. But do they really have any effect on the IUGR? Not much good literature is available. Maternal oxygen therapy, really, they don't actually work. Again, one of the biggest things, the first thing doctors do is put the patient on bed rest. There's lots of literature now to say, even from the Society of Maternal and Fetal Medicine and many other studies, the Cochrane database of 2000, that there is not enough evidence to evaluate the use of bed rest as a treatment for IUGR. So in fact, they may be giving rise to more complications. So bed rest is really, really controversial, and our knowledge on that is restricted again. Then comes the timing of delivery. The timing of delivery, it all depends upon the monitoring. And when do we think that the baby is critical, needs to be delivered, otherwise the baby will die. Now, that is not the only thing. What about the IQ? What about the mental condition of the baby after birth? So all these things have been studied. The growth restriction interventional trial, the GRIT study, compared the immediate versus delayed delivery when clinical uncertainty prevails. Another very important trial, the disproportionate intrauterine growth interventional trial at term, that also went on to see that there was actually no significant difference on maternal and neonatal outcomes between induction of labor and expectant monitoring. Now, that really is confusing, isn't it? So there really are not many IUGRs, especially when you talk about late preterm or early term IUGRs. When to deliver the babies with abnormal Dopplers, there are no really good RCTs. But available data says that we can go even up to 37 to 38 weeks. But beyond that, there is no need. Twin pregnancies with a co-twin IUGR, of course, the chronicity is very, very important. But we should not go beyond 34 to 36. Certainly, if they are monochorionic, we don't go beyond 32 weeks. Also, there's a lot of studies now which show that the optimal gestational age for any IUGR baby, especially with abnormal Dopplers, please no need to go beyond 35 weeks. You're not going to gain anything extra, just by increasing the period of gestation. Now, another very important group is the very early IUGRs. They are the ones where we are so scared of. The ones between 25 weeks and 30 weeks. And they're the most problematic. Actually, below 26 weeks, below 25 weeks, we shouldn't even try to make them, survive, because the parental morbidity is so high. So whenever, even in AIMS, when I was there, like, they want to do a cesarean for a baby which is 25 weeks, I really have my doubts. There is really no need to make these babies, deliver. Let them have an IUD and you can probably try in the next pregnancy. But if you can get even 1 week or 2 weeks more, give them corticosteroids, do the monitoring, do NSTs every 8 hours. Sometimes you may even do continuous monitoring, fetal heart rate monitoring. If you can gain 48 hours, the prognosis is much better than if you want to deliver them before 25, 26 weeks, when there is an abnormal Doppler. And then the most important problem is how to deliver. You wonder, will this baby survive? And should we give a vaginal delivery? But then if you don't do a cesarean, this baby, especially the ones with the abnormal Doppler, will not be able to go through the stress of labor. So then you need to do a cesarean section. And so it becomes a big dilemma. Again, the prognosis, it's related to how you're going to deliver, whether you're going to give the woman a scar or you're going to give a baby by cesarean section, which may or may not survive. That is a big dilemma. And again, our restricted knowledge. Ultimately, what we want is we want a child with no intellectual, neurodevelopment, or learning disabilities. So, of course, these are, very much dependent upon upon the underlying cause. But our management has to be also at par or going along with it. Again, they would be also premature. So added to the IGR is the prematurity. So it's very, very important to know about an estimate of the prognosis, how they're going to catch up after birth. So that's very, very important to have an expert neonatologist in the group. And because the catch-up growth is unpredictable, and most IGR babies, of course, they can catch up growth by 2 years of age, and which rapidly occurs in the 3 to 6 months. So the 3 to 6 months and up to 2 years is a very, very critical age. And you need to see these babies along with the pediatric endocrinologists, because there could be a lot of endocrinological problems also, and especially regarding the height and all. And for an obstetrician, what is most important is, can IUGR be prevented? There are many studies, risk assessment studies have been done. Of course, things like cessation of smoking, no alcohol. If a very underweight woman, she has nutritional interventions, she gets rest, it may help. We have had a lot of research done on bed rest, hydration, progesterone supplementation, even antibiotic treatment without much use. Also, there is very less evidence to support use of maternal hyperoxygenation, plasma volume expanders, and all. So ultimately, what we are left with is just intensive maternal and fetal monitoring. And therefore, I would conclude by saying that, yes, our knowledge of the growth-restricted fetus is also very, very restricted. There are so much fields of research. I still remember at one time when I was a young faculty, I wanted to give, directly, because I was also doing a lot of interventional fetal work, I still do. And I wanted to give intravenous direct fetal albumin infusions to see whether that would improve the growth of the baby. And then there were a lot of animal experiments and all. But somehow I couldn't get this project through. But there is a lot of scope for research in all these fields of IUGR. The management, the diagnosis, not one single monitoring technique, whether it is Doppler, whether it is NST, whether it is just a biophysical profile, is alone adequate. You have to manage with a combination of biophysical profiles, Doppler, and the maternal fetal count, and of course, keeping in mind the neonatologist, the prognosis of the baby, how it's going to be, how the baby is going to behave in the ICU, and after, in the next 2 years. All these things are very, very critical in having a good, favorable outcome. It is not the pregnancy alone. It is the delivery, the postnatal, and the up to 2 years age, which is very, very critical and need to be managed as a team. So to conclude, IUGR knowledge is still very restricted and we still have a long, long way to go. Thank you very much for giving me this opportunity.
Thank you, Dr. Deepika Dekha, for an excellent lecture. And I totally agree. IUGR is still a tricky situation where it's very difficult to decide whether the baby is safer inside or safer outside. And the timing of delivery will decide the fate of the pregnancy and the delivery and the baby. So it's extremely important to manage IUGR very diligently. And thank you very much again. Due to paucity of time, I think we will, Chinmay will go to the inauguration immediately. Yes.
Yes,
Madam, waiting.
You.
Madam has got another commitment. So.
Thank you, chairpersons, for chairing the excellent session. Now welcome and invite Dr. Madhuri Mehendale to take over the proceedings of the inaugural program. Can I have the CV of Dr. Madhuri?
Just give two lines, that's all.
Dr. Prachi, you have to unmute yourself.
I'm sorry. Dr. Madhuri, you're welcome. You've done your endoscopy from Germany diploma, and please go on with the proceedings of the inauguration function. Most welcome.
Thank you. Thank you, ma'am, for those kind words. Good afternoon to one and all. It's an honor itself to honor this beautiful audience who have gathered here. I welcome you all on behalf of FOGSI on the FOGSI Fetus Day. Welcome to the webinar, Fetus, Do You Know About Me Enough? Thank you all for giving us your prized time. Before the invocation, let me first acknowledge the presence of some of our eminent dignitaries today. We welcome our President, Dr. Shanta Kumari ma'am. We welcome our President-elect, Dr. Rishikesh Pai sir. I think he's not been able to join. He had some other commitments. We welcome Dr. Madhuri Patel, our Secretary General, our Vice President, Dr. Bipin Pandit sir, our Vice President, Dr. Fessy Lewis, Dr. Niranjan Chauhan, Joint Treasurer. We welcome our three chairpersons who have put in a lot of hard work for today. Dr. Mandakini Pradhan ma'am, Fetal Medicine and Genetic Committee, Dr. Bela Bhatt, Imaging Science Committee, Dr. Chinmay Ratha, Perinatology Committee. I feel extremely privileged and honored to be given this opportunity to welcome our chief guests for today, Dr. P.K. Shah sir, who's a past president FOGSI, and Dr. Alka Kriplani, who's also a past president FOGSI. Welcome. We will now have our traditional auspicious lamp lighting ceremony as a tribute to our Mother Saraswati, the goddess of knowledge. Please may I have the video?
Shubham Kurutvam Kalyanam Arogyam
Thank you. And now, feeling truly blessed this morning, I welcome everyone once again, requesting for our President theme video now. Please, may I have our next video?
Dear friends, Foxians and women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of FOGSI, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Stree Shakti as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond FOGSI's commitment towards women's healthcare. FOGSI for all, always.
FOGSI for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dheera to stop violence against women. FOGSI for all, always will strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman.
Dr. Shanta Kumari with the theme FOGSI for all, always and Dheera Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman, Swasth Mahila.
Violence against women, I think it's a silent pandemic and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dheera, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women.
I completely support her vision and mission as President FOGSI and also especially support her campaign, Dheera Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the President of FOGSI, declare my commitment towards women's health and safety.
That was truly inspiring. Your passion is unending for the women care. I request our President, Dr. Shanta Kumari ma'am, to address the audience with a few words. I request Dr. Bipin Pandit sir, our Vice President, to introduce Madam.
It's a great pleasure to introduce Madam Dr. Shanta Kumari, our present president of FOGSI. She has got many accolades, and at present, she has been elected as a FIGO treasurer, which is a very, very great thing. Everybody knows Shanta Kumari, Madam, so I don't want to waste time just introducing her. May I request Dr. Shanta Kumari to please give her address.
Thank you, Dr. Bipin, sir. Good afternoon, everyone. It's indeed a pleasure to have Dr. P.K. Shah and Dr. Alka Kriplani, Madam, as our guests of honor. It's very nice to have you all here, and congratulations to our whole team for this lovely update on the Fetal Day. I'm sure that all the delegates are enjoying this lovely workshop, which is the amalgamation of the three committees. So very well done. Dr. Bela, the ultrasound committee, Dr. Chinmay, the perinatology committee, and Dr. Mandakini Pradhan, the genetics and committee. Yes, times have changed from a few decades to the present age. Now we know that obstetrics doesn't mean only taking care of the mother. Obstetric means taking care of the fetus in utero. So what we are taking care is much more important than what the neonatologist or the pediatricians are going to take over. So I think the onus is on all of us obstetricians to see that we deliver a healthy baby. And that is the core of today's meeting, that is a Fetus Day. So the fetus has every right, the fetus has a choice. And remember, fetus has a life. And the most important aspect is we as obstetrician gynecologists need to take care of the emotional aspects of the parents. Now times are changing. It's very easy for us to diagnose so many disorders, but then we need to have a discussion with the parents, because we need to understand that it's not only our responsibility as OB-GYNs, but we need to consider what the parents, what the mother wants, and then give them the proper idea or counseling about what is happening so that they make a proper choice. I think that is the way forward. And now we have realized that the fetus can be taken care of in so many ways. We have got so many new techniques where we can actually diagnose so many problems without being very aggressive. We have got so many non-invasive techniques, and we have made a lot of advances even in fetal surgery. I think this is a way forward and the future of having a mother and baby who is going to be healthy and happy. So thank you very much. And I think today the program is going on very well. And I congratulate all my vice presidents, Dr. Archana, Dr. Basab, Dr. Bipin, Dr. Fesi, Dr. Kavita, Dr. Madhuri Patel, our Secretary General, and Suvarna, Niranjan, and Parikshit Tank, and of course the Aruna Suman. You all are doing a great job. I'm happy that together we can deliver. And friends, I take this opportunity to thank all of you for your love and affection and support, which made it possible for me to take over as the treasurer of FIGO. So thank you very much for being with me in my journey to be the treasurer of FIGO. And I take the opportunity to invite all of you to Hyderabad the next Sunday. We have the cervical cancer update because we as gynecologists, we believe that we need to work with the government towards the Cancer Mukt Bharat. So FOGSI towards having a Cancer Mukt Bharat is the commitment which we as gynecologists need to give to our women. So friends, please join us. We have a wonderful cancer update program. It is going to be a hybrid event. It's there happening in Hyderabad. We have the physical hub at the AIG hospitals in Hyderabad. All the faculty are going to be here. All the delegates are going to be here. Those of you who can join us even from outside Hyderabad, you're most welcome. Please do join us. And those who cannot, who are staying in other places, can definitely join on the link. But I look forward to having all my delegates in person at Hyderabad at AIG next week. And I'm sure that you will also join hands with FOGSI and FIGO. And I'm very happy to announce that our FIGO president, the newly elected president, Dr. Jean Connery, is going to be the chief guest at the Cancer Update. She'll be joining us virtually from Paris. And we have Professor Nagesh Reddy sir from the AIG and Dr. G.V. Rao, who will be joining us that day. And we look forward to have all of you at that event. So thank you very much and all the best for the rest of the session. And thank you to all the faculty for actually being with us today and sharing your thoughts and ideas, because fetal medicine is something which is very difficult for a normal gynecologist to understand. For a person like me, a simple brain, we don't understand the super intelligent things which are happening. So thanks for trying to making it easy and simple to all our FOGSians. Thank you, friends.
Thank you, ma'am. Your words are always inspiring and full of passion. We as FOGSians are very proud to have you as our representative for FIGO. Congratulations once again, ma'am. Moving on to our next session of feeling really lucky to have our chief guest today, I request Dr. Mandakini Pradhan, ma'am, Chairperson Fetal Medicine and Genetic Committee, to welcome our chief guest, Dr. P.K. Shah, sir.
Yeah, good afternoon, everyone. And thank you, Madhuri, for giving this. I'm fortunate enough to introduce one of the person who saw fetal medicine from embryonic stage, conception stage to this level, what is today. He is none other than Dr. P.K. Shah. He had changed his mustaches, but his brain has grown bigger and bigger. So he is professor and unit head of KEM Hospital, Mumbai, past dean of Indian College of Medical Ultrasound. He has got, he was our past president FOGSI. And almost everybody, every FOGSian knows him as a good teacher, as a sonologist who started his sonology fetal ultrasounds, and then has got innumerable laurels to his credit. He's a fellow of WellStart International USA, then internationally also he is famous. Not going into detail of it. Dr. P.K. Shah, sir, you are welcome. Thank you for making it to this FOGSI Fetus Day. We are fortunate to have you with us as our chief guest. Over to you, Madhuri.
Sir, we request you to address the audience.
Thank you, Dr. Mandakini. At the outset, let me thank FOGSI, especially Dr. Shanta Kumari, Dr. Madhuri Patel, all the vice presidents, 3 chairpersons of committees related to ultrasound, Dr. Mandakini Pradhan, Dr. Bela Bhatt, and Dr. Chinmay Rath. And it is nice to share this platform with our dear colleague, Dr. Alka Kriplani. It's so nice to see that in last 4 days, I have seen 3 major webinars related to ultrasonography. And that shows the interest that we have as faculty and seniors, and the FOGSI members want to know so much about the ultrasonography. I'm very happy about it. Secondly, the scientific program drawn by the 3 chairpersons is just fantastic. It started with preconceptional health, antenatal care, pyramid of antenatal care reversion, and how not to miss congenital anomalies while doing ultrasound. Also, it included prenatal invasive techniques, counseling. Now, that was something very nice, that we had a talk of counseling, especially for cardiac defects. And Deepika Deka did a fantastic job of exposing all the gray zones related to fetal growth restriction. We are now going to have very important topics like NIPT or NIPS and combined test. There are some snippets or capsules which will cover umbilical artery, renal palliatesis, echogenic barbell fetal therapy, and amniocentesis. And ultimately, Dr. Mandakini Pradhan and Dr. Vandana, they are going to have a panel discussion on healthy fetus. I congratulate all those who have made this scientific program. And thank you very much for making me a part of this webinar. And I wish all the very best. Congratulations, Shanta, for bearing a very important post in FOGSI, FIGO, that is treasurer's post. I think I started my career in FOGSI as treasurer, and I know how difficult it is to convert one organization from red to green. So all the very best. And thank you, organizers, all of you. Madhuri, carry on.
Sure, sir. Thank you for your kind words.
Thank you, sir. I now request Dr. Chinmay Ratha, Chairperson of Perinatology Committee, to introduce our next guest of honor, Dr. Alka Kripalani, for her address.
It's really my privilege to be able to introduce Dr. Alka Kripalani to this audience, whereas she needs no introduction. Some CVs are such that just reading them brings a lot of inspiration. And this is Alka Kripalani, ma'am, our past president of FOGSI, a Padma Shri awardee from the President of India, a president of many eminent organizations, and a teacher par excellence who has received the BC Roy National Award for the Eminent Medical Teacher in 2007. In addition to all her awards, we remember the phenomenal year of 2016 when she was president of FOGSI and gave us the logo of Prevent the Preventable. That remains one of the basic tenets of clinical medicine. It would be really nice to hear a few words from Dr. Alka Kripalani, but I think she'll just join us after some time. So I would request Madhuri to take over and move on to the next session.
Thank you, ma'am. We now request Dr. Madhuri Patel, ma'am, our Secretary General FOGSI, to share a few words with us.
Thank you, Madhuri. Can you hear me?
Yes, ma'am.
Yes. Hello, sir. Respected Dr. Shanta Kumari, our President FOGSI, and now I'm officially declaring Dr. Shanta Kumari for her new post as a Treasurer FOGSI. And Shanta, we are all proud of you. And you are going to get new changes in our FOGSI also along with FIGO. And respected our chief guest, our Dr. P.K. Shah, past president FOGSI. And you know, my dear sir, along with my mentor, Dr. C.N. Purandare, who has taught me all the nitty-gritty of FOGSI. So whatever today I'm doing the administrative work, I owe to Dr. P.K. Shah and Dr. C.N. Purandare. And my dear madam, Professor Alka Kripalani, my inspiration, my sister, and you know, my advisor. So whenever I ask her, she will definitely advise me. And today we are good friends because I worked with her as a joint secretary when she was vice president. And since then we are good friends and she always advises me. So thank you, Dr. P.K. Shah and Dr. Alka Kripalani for guiding me. Then all the VPs, Dr. Bipin, Dr. Tracy, Basab, I can see, Kavita and Archana, and all my administrative officer, Dr. Suvarna, Parikshit, Niranjan, and of course, I cannot forget Dr. Suman. You know, she's, you know, I always, you know, say Suman, but she's Aruna, and I always have her on my, you know, tip of the tongue name of her husband, Suman. I don't know why it is, but Aruna, please excuse me for that same, you know, and all my, you know, great chairperson today's, you know, webinar, Chinmaya, Dr. Mandakini, and Dr. Bela, and all my speakers, chairperson, moderators, and the panelists, and dear delegates who have logged in. Very good afternoon to all of you. I would like to express my heartfelt gratitude to the organizer for giving me this opportunity. I as a Secretary General, I would like to mention something about FOGSI, that we are all, you know, 263 member bodies, with 38,000 plus committed members for the women's health. And we have mission, FOGSI has a mission. I can hear somebody, somebody, can you unmute mute yourself? Yes, madam has joined. Kriptani madam has joined. Good morning, madam.
Good morning.
Good morning. So, as a FOGSI mission, we always protect and support our OBGY practitioner in India. And our primary mission is reduction in maternal mortality and overall health of the woman and the fetus and newborn. So I would like to take the opportunity to say that we have started printing our journal after the COVID pandemic. And you all must have received the journal by this time. And I would like to mention that about 400 copies have come back to FOGSI office. So I request all our members to update their, data on a membership.fogsi.org portal. So it will help us to have effective, communication with all of you. At the same time, it will also help during e-voting. So today's webinar on fetus is an unique webinar and is going to enlighten us on how to have healthy fetus, in turn healthy babies, and in turn healthy future generation. All of us are aware to have healthy fetus. The care starts from the pre-conception period and it continues throughout the pregnancy. Apart from routine tests, we have screening tests, diagnostic tests, and to evaluate the fetus and treat, as one of the speakers said, that treat in utero the treatable condition. So, and now Dr. Deepika Dekpa has rightly said we can find out the growth retarded babies and we can treat accordingly. So we can give healthy babies to the parents. So today we have galaxy of prominent, eminent and experienced speakers, chairperson, moderators and panelists who have been and are going to update on recent advances, which will in turn help us in day-to-day practice and to give best to our pregnant women and the babies. I must appreciate that under the guidance of Dr. Shanta Kumari, Dr. Bipin Pandit, and Dr. Pesi Ruiz, our chairperson, Dr. Mandakini, Dr. Bela, and Dr. Chinmaya are doing excellent academics, and I wish them best. At the end, I would like to mention the quote by Benjamin Franklin: an investment in knowledge pays the best interest. So, dear friends, let us invest in updating our knowledge and give the best to our future generation. Happy learning and thank you very much for giving me the opportunity.
Thank you so much, Madhuri ma'am. And we have just been blessed with the presence of Dr. Alka Kriplani. So ma'am, I had the honor of reading out your CV. And as I said, it's one of the few CVs, the moment you read it, you feel a lot of inspiration yourself. And I still remember your prevent the preventable tag, which is one of the core things in fetal medicine. So madam, please bless us with a few words.
Thank you so much for your kind words. A very good morning and wish you all a very happy Diwali. When I saw my friend Madhuri, with whom I have, a lot of fixation, and she gave such a lovely, address. And I don't think I have to speak much, but I would like to say, Dr. Bela, she's entertaining FOGSI for years by her dancing skills, amazing dancing skills. And you all, we must appreciate FOGSI. Shanta Kumari is the most aggressive and most competent president we have. Unfortunately, still we are not able to meet in person, but you all will agree with me, her charisma is there. And I'm very sorry, I don't know the names of many people whom I should be appreciating now. And the topic is great, fetus as a patient. I always feel obstetric and gynae are two very different branches. Gynae is different, obstetric is different. Somehow they are clubbed together. And we gynecists, basically all over the country, are obstetricians. And when I see everybody, goes for endoscopy and IVF, my heart pains because I think fetus as a patient and obstetrics is the is knowledge, imparting knowledge in this field is demand of the day, because majority of our colleagues are, handling these cases, and whole obstetrics is centered around fetus. So you people have taken a wonderful theme, fetus as a patient, and then it covers all the obstetrics. So it's an absolute pleasure to be with all of you, and I wish you a grand success. As Diwali is very near, I have so many guests in the house, and I'm sure, and I appreciate all the organizers that Diwali, no Diwali, we are continuing with our motto to impart knowledge. Thank you for the invitation and wish you a great day. Thank you.
Thank you, Alka madam. I think you can come down for the physical
Hi,
meeting in Hyderabad.
Shanta, hearty congratulations.
Thank you.
You are, you will be FIGO president one day. I have started announcing, because the infectious charm, the energy, the enthusiasm, and it is your energy, Shanta, which is really amazing. So we are all very, very proud of you. I really want to hug you in person for this FIGO achievement. Love you.
And plus he handled retinal detachment. Thank you, Alka ma'am. He's fine now. I now request, we have been very lucky. We have our three vice presidents, Dr. Basab Mukherjee, Dr. FOGSI Lewis, and Dr. Bipin Pandit sir over here. I request Dr. Bipin Pandit sir to share few words.
Thank you, Madhuri, for giving me this opportunity. Our president, Dr. Shanta Kumari, our secretary, Dr. Madhuri Patel, all the three dynamic chairpersons, all the MOCs, all the faculty delegates, and my fellow vice president, FOGSI, and others. It's a great pleasure to plan this program, such a nice faculty, such nice topics with these three dynamic chairpersons. And they have put in a lot of hard work. So I must thank all these three chairpersons, Dr. Bela, Dr. Chinmay, and Dr. Mandakini, for putting all the efforts to make this program a grand success. And today we have witnessed certain new things, a fetal surgery, so many controversies, and the importance of keeping the fetus safe, and to decide decisively whether the fetus is safer inside or outside in case of IUGR. It's a very tricky decision sometimes. And I'm sure this webinar is going to be very helpful for all the obstetricians and gynecologists, all the FOGSI members in future. And we wish a happy Diwali and a prosperous new year to all, and hope that COVID will go away and we'll all be able to meet physically, which we all are craving for. Thank you. Thank you very much.
Thank you, sir. I now request Dr. FOGSI Lewis to just share a few words.
Good afternoon to all of you, respected FOGSI President and Secretary General, and Chief Guest P.K. Shah sir and Alka Kriblani Madam. First of all, let me take this opportunity to congratulate our President, Dr. Shanta Kumari, for getting officially taking charge as the FIGO's treasurer. And also this wonderful initiative of combining the related specialties, like initially we had all the CMEs were combined, so that all the attending our gynecologists, FOGSI members will get the maximum benefit. So today we have got the Fetal Medicine Committee and Genetics Committee, Imaging Science Committee, and Perinatology Committee. All that related committees had jointly together, and that idea of our president has led to a wonderful academic feast for us. So I'm not wasting any time because we are running late. So with this, I congratulate the FOGSI President, Secretary, and all the committee chairpersons for bringing about this wonderful academic feast for all of us. Thank you.
Thank you, sir. Today is the National Unity Day, birthday of Sardar Vallabhbhai Patel. And it feels me very united here at FOGSI, seeing all our members and all our office bearers here united, putting up a stand and standing for the fetus today. No inauguration or no program would end without thanking the rightful people. I now welcome Dr. Bela Bhatt to offer our vote of thanks.
Thank you so much, Madhuri. It is my pleasant duty to give vote of thanks. Well, first of all, I would like to thank our President, Dr. Shanta Kumari ma'am, who so thoughtfully combined all these three committees so that we could put this program on FOGSI Fetus Day here today for all of you all. I am extremely thankful to both the chief guests, Dr. P.K. Shah sir and Dr. Alka Kriplani, for sharing their valuable time here today and blessing us. Dr. P.K. Shah sir, his name is synonymous with ultrasound in FOGSI. So thank you so much, sir, for being here today. Dr. Alka Kriplani ma'am, the Padma Shri awardee and the past president, has always inspired us all. So thank you so much, both the chief guests, for being here and inspiring us. I thank Dr. Secretary General, Dr. Madhuri Patel ma'am, for being and blessing us. VP in charge, Dr. Vipin Pandit sir and Dr. FOGSI Louis, who has supported, in making this entire webinar of today with the help of all three chairpersons and both the VPs in charge. At every, small thing, we used to inquire them as to what to do and how to go ahead, and they have always supported and guided us. So thank you so much, Dr. Vipin Pandit and Dr. FOGSI Louis, as well as all the VPs, Dr. Basab Mukherjee, Dr. Kavita Bapat, Dr. Archana Verma, for always supporting in our academic activities. I thank past president of FOGSI, Dr. Alpesh Gandhi, president-elect Dr. Rishikesh Pai, Deputy Secretary General Dr. Suvirna Khadilkar, Joint Secretary Dr. Aruna Suman, who has always been there helping, kind of frame this entire program and to put it in practice exactly how to go about it. Treasurer Dr. Parikshit Tang, Joint Treasurer Dr. Niranjan Chauhan, whom I can see who is there with us today. So I thank all the FOGSI office bearers without whom we couldn't have done this program. And of course, my two co-conveners and dear friends, Genetic and Fetal Medicine Committee Chairperson, Dr. Mandakini Pradhan, Perinatology Committee Chair, Dr. Chinmay Ratha. We all three had very good time last 2-3 months, forming the entire program and deciding the faculties and topics and everything. And it was a pleasant experience. And thank you so much. We all three could together only do this, not single-handed, we couldn't have done this. So, and of course, all our wonderful MOCs today, Dr. Gurpreet, Dr. Prachi, Dr. Madhuri Mahendra, Dr. Aarti and Dr. Nisha are going to be MOCs for the next session. So without them, I think the program cannot run smoothly. So thank you so much, all of you all, for being there for us. And academic partners, Mayor Pharma and conference manager Meeti, Venkatesh and Tirupati have been there with us since quite last few days. And we had dry run also yesterday, and we could, kind of make the flow chart of events. And thank you so much for being there and providing the platform. Well, we all know that no academic activity is successful without the audience. So I thank the august audience, all the viewers, the delegates who are sparing their valuable time and being with us today, because without you, the program could never have been successful. Thank you so much, each and everyone, from core of our heart. All three chairpersons are very, very thankful to you all. Thank you.
Thank you, ma'am. Thank you all the dignitaries for being here for our inauguration program. And now, valuing our time, we move ahead. I would now like to hand over to Dr. Nisha Bhatia. Please, may I have her CV? So Dr. Nisha Bhatia is a gold medalist in MS OBGY from the prestigious Usmania Medical College, Hyderabad. It looks like she has several publications and awards to her name. Her special interest is high-risk obstetrics. Welcome, Nisha. Over to you.
Thank you, Dr. Madhuri, for the kind introduction. And welcome back to the academic session after a very enthralling inauguration. Now, we all agree that aneuploidy screening is a vital part of antenatal care, but choosing the most appropriate test can be confusing and also a subject of debate. So without wasting much time, we move on to the next session, which is a debate on NIPT versus combined test. And I take great pleasure in inviting our esteemed chairpersons, Dr. Basab Mukherjee sir and Dr. Kavita Bapat ma'am. Dr. Basab Mukherjee sir is a vice president of FOGSI 21-22. He's been the vice president of Bengal of Society and member of ICOG Governing Council, founder secretary of organizations like ISOPAB and IAGA, Bengal, and he is a great academician, contributed to more than 30 chapters and textbooks. Moving on to the CV of Dr. Kavita Bapatma. She is the Vice President, FOGSI 2122, Organizing Secretary of AICOG 22 Indore, which we are looking forward to, Director of Bapat Hospital Indore. She has held various positions in various organizations, Executive Member of ISAR and IAG. I welcome you, sir and madam, to take over the proceedings and introduce the speakers for the next session.
Thank you, Dr. Nisha. I cannot see Dr. Kavita just now, but I'm sure she'll be joining sometime. She must be busy with her AICOG preparations. Can you please share me the slide of the first speaker, Dr. Prasanna? So Dr. Prasanna is an MS OBGYN in 2011 from Medical College, Kolkata. He's done a fellowship in endoscopic surgeries in 2011 and a PG diploma in ultrasonography in 2012. And for the last few years, he's doing excellent work at Asansol, which is roughly around 200 kilometers from Kolkata in West Bengal. He's a consultant there at the Ultra Clinic Fetal Medicine Center. He's also the Joint Secretary of the Kolkata chapter of the Society of Medicine. He's the East Zone Coordinator of the FOGSI Imaging Science Committee, and and we will be hearing from him first today, and he will be taking on the topic of NIPT, non-invasive prenatal testing, and then combined test we'll be hearing from Dr. Binayak Das. So it's a debate which we have already had some discussion in the morning when we were having the discussion after the lectures, but now we'll be hearing it from our two speakers. To Dr. Prasanna, the floor is yours.
Thank you, sir. Thank you so much, sir. Is my screen visible, sir?
Yes, it is visible. We can see you.
Good afternoon. Good afternoon to all my respected seniors and my dear colleagues. I am going to speak in favor of NIPT today. So the debate is not that which is the best test. We all know that NIPT is the best test when we compare with FTS. The ongoing debate is that how cfDNA screening can best be incorporated into this current prenatal screening algorithms for chromosomal abnormalities. How we are going to do it is the debate here. But we are not debating this. We are not debating that we are not going to do an ultrasound. This is the most basic pillar of aneuploidy screening. No screening method is complete without doing the basic ultrasound properly. So there are 3 points at which we can do an NIPT. So the first is before even doing an ultrasound, that is pre-ultrasound NIPT. Me and my opponents, I'm sure that we both don't favor this. My choice is number 2, that after doing an ultrasound, we do an NIPT directly. And number 3 is my opponent's choice, that after doing an ultrasound and combining it with the biochemistry, that is doing a combined screening, we do an NIPT if the risk comes out in the intermediate zone. So these are the 3 points. My choice is number 2, that after an ultrasound, we go for NIPT directly. So there are 3 options that we can do as a primary screening method, cfDNA. We can go for FTS first and then do intermediate and then do contingent screening in the intermediate risk group, or we can do just by age and ultrasound, and we can or not include biochemistry. So the age and ultrasound, according to me, is the best way in our country to do an universal screening. So the numbers will speak for themselves. You can see here that if it's a combined screening, will give us a detection rate of 90% with a high false positive rate of 5%. And the cell-free DNA, which is a clear winner, you can see here that the detection rate is as high as 99 or maybe more than that, with a very low false positive rate. So we have a clear winner in the form of cell-free DNA when we combine with FTS. But another point which I will take your attention to is that if we combine the FTS along with the additional ultrasound markers like NB, DV, and TR, the detection rate goes as high as up to 95%. and most importantly, the false positive rate comes down. So that is the importance of doing a good skilled ultrasound when we are doing an aneuploidy screening. So my best method or best bet in our country is to do all these markers together. That is NT, NB, DV, and TR. And then we give a risk, we do a triage based on only ultrasound. And in high risk group, we can go for invasive testing. In low risk group, we'll directly go for anomaly scan. In the intermediate group, after doing the NT, we can do for assessment of newer markers. That is the nasal bone, DV, and TR. After that, we will get a calculated newer score. And then according to the risk calculation, we can decide. So by only ultrasound, we can do a triage in our population if we do a good directed ultrasound. We cannot base our aneuploidy screening on these kind of images, which is the commonest images which we see. That is the hardcore truth. We all have to accept this, that you will see more often than not, you will see this kind of CRLs, or more often than not, you will see this kind of NT measurements. So these are basically wrong NT and CRL images. So should we do any testing based on such images? Absolutely no. We cannot base our aneuploidy screening on such quality ultrasound images, which is the commoner scenario. More often than not, we will find these kind of images. So and again, if you put aside the ultrasound, we will get this kind of screening reports that based on PRISCA platforms. How many of us we generally see in our day that Astra reports we are seeing commonly? We will generally see that these kind of PRISCA reports in our clinic. So basically what we are trying to do here, we are trying to risk share between the lab and us. That we are telling the lab that don't care about our ultrasound, how we are doing the ultrasound is not the matter. You give us a biochemistry risk, and then I will counsel the patient that you are in a low risk group based on that biochemistry, which is done on a PISCA platform, and that quality of ultrasound where the FMF criteria are not followed. Why I am telling this? That because when you go to the FMF website, when there is a group of NT specialists who has to take that degree and audit themselves. When we put the cursor on India, you will get only 224 NT specialists. So you can imagine in such a vast and hugely populated country like India, only 224 people are doing it on the Astra and maybe giving perfect images according to the FMF algorithm. So in combined first trimester screening, these are the parameters: age, heart rate, CRL, NT, beta HCG, and PAPE. So it is heavily dependent on ultrasound. We can see here. So if we are doing a poor quality ultrasound, the entire screening is wrong. And we are reassuring the patient that you are in a low risk group for trisomy 21 based on poor ultrasound. So what is the argument given here? The argument given is that the negative predictive value of FTS and NIPT is same in the low risk group. That a low risk, in a low risk group, a low risk FTS and a low risk NIPT has the same negative predictive values. It does not give us any additional information. But when it is true only when it is done properly, and that is a rare scenario in our country. When this paper published in ISWOG, they compared FTS with first trimester risk assessment based on ultrasound and cell-free DNA, and they compared it with the combined screening. So what they tell us that the test performance of cfDNA is much better than that of FTS. And the cost of cfDNA testing is generally deemed too high for it to be adopted as the primary method of screening. The only problem is the cost. When it started in 2012, it was 30,000. Now it is 6,500. Double marker costs rupees 2,000. And there are many government schemes who wants us to do LSCS in 6,000 or 8,000 rupees. So in a country like India, we are not going to spend this additional 2,000 on a biochemistry report, which is giving us only a 2% addition in addition to ultrasound. So what is the way out in India? The way out in India is do universal screening by good skilled ultrasound. There are FMF websites where free software is available. Just put the NT, NB, DVTR values and they will give us a good triage based on only ultrasound. We should offer NIPT to all. Do NIPT for those who opt for it. Do NIPT for those who can afford it. And do NIPT directly in high-risk cases, like in previous trisomy 21 babies. We need not go for invasive testing in this next pregnancy. We can directly go for NIPT. We should not waste time doing FTS or a combined screening in this kind of high-risk cases. And we should offer NIPT to all. So basically, my opponent is going to debate on this factor that we are going to do first of all, we are going to triage by only FTS, and then we are going to do cfDNA only in the intermediate risk group. This contingent screening can be challenged in several ways, this contingent screening model, because firstly, there are still some pregnancies affected by trisomy 21 that are present in the low risk group. So those would remain unidentified. If cfDNA analysis is not performed in this group, then exclusion of the low risk group from cfDNA analysis is based on only economic considerations. So this approach will become difficult to justify as the cost of cfDNA testing decreases further. So the approach in which every woman with a normal ultrasound at 11 to 13 weeks undergoes cfDNA testing for aneuploidy is a reasonable option. Under these circumstances, there is no need for biochemical markers such as beta-HCG and PAPA, and it is questionable. So advantage of this approach lies in the screening performance for T21, which is better than any other method. So cfDNA in the intermediate risk group or to all is usually based on financial rather than clinical considerations, which is a wrong thing to do. So likely to be a temporary limitation as the price of cfDNA has been decreasing since its introduction and is expected to continue to do so. So even though limiting the cfDNA analysis to the intermediate risk group offers a high detection rate by this contingent model, we must remember that approximately 1.5 to 5% of trisomy 21 pregnancies remain in the low risk group. So the only way that a 99% detection rate for trisomy 21, that is the ideal, would be realized, as is possible with a primary cfDNA testing approach, would be not to restrict cfDNA analysis to a small subpopulation. So one could argue, my opponent could argue that there would be abnormalities that we are talking about, rare and which is easily detectable, but followed by cfDNA. Can you hear me, ma'am?
The audio was not clear, sir, but now it's clear, sir.
You can hear now?
Yes, sir, we can hear you. So please go.
So one could argue that if the screening does not involve maternal serum markers, there would be a significant loss in the detection of other chromosomal abnormalities, like rare autosomal trisomies, like RATs. So which are anyway going to spontaneously abort and which are easily detectable by ultrasound. So detailed ultrasound followed by cfDNA leads to a low false positive report and allows for an excellent detection rate of common autosomal trisomies and rare autosomal trisomies together. So this approach obviously obviates the need for maternal serum-free beta-HCG and PAPA measurements. This is a website of the FMF where is a risk calculation software for trisomies. You can see here that I have put a normal biochemistry mom, that is 0.5 for PAPA and 1 for beta-HCG. And NT I have put as 3 mm. It is not even 99 percentile, it is 95th centile, but it is on the higher side. So we will get a risk of 1 in 64. You can see here that even after a normal biochemistry and abnormal ultrasound will alter the risk so much. In the same patient, you can see when I change the mom values of the PAPA and beta-HCG, I made it abnormal, that is less than 0.5. PAPA here is 0.4 and beta-HCG mom is more than 2. But the NT here, you can see it is 1.2. Just see the risk. It decreases to 244 in that same patient. So doing a good skill ultrasound is much more important than rather trusting the biochemistry blindly. So apart from aneuploidy, one can also argue that this first trimester screening for preeclampsia is an essential part of FTS, and therefore serum markers cannot be omitted from any protocol. But O'Gorman demonstrated that at a 10% false positive rate, FTS for early and late PE without PAPA or PLGF results in only a slight lower detection rate than is obtained with inclusion of these markers. So when we are worried about cost in India, we are unnecessarily including PLGFs and PAPAs for doing just a simple preeclampsia screening. So again, this preeclampsia screening software on the FMF website, here you can see that I have put high values for uterine artery PI and mean arterial pressure. And I have put normal values for PAPA. You can see it's a high risk case, that is 1 in 12. In that same category of patient, I have put normal values of mean arterial pressure and uterine artery PI, but I have put a very low PAPA. You can see it's 0.2 moms just. but you can see here that the risk is 1 in 185. So you understand that the variation because of PAPA is very insignificant. We are not going to gain much. So we are not doing a maternal weight, height, ethnicity, past history of preeclampsia, the mean arterial pressure, the uterine artery PI, and we are asking the lab to tell us that whether this woman is going to fall in a high risk or low risk for preeclampsia. There is free website available, free softwares available just by doing a uterine artery PI and mean arterial pressure and past history, weight and height and ethnicity. We can do a very nice triage for preeclampsia in the first trimester without adding any sort of biochemistry. Now we come to the fetal fraction. These are the factors like mosaicism, fetal aneuploidies, triploidies, multiple pregnancies, obese patients, maternal autoimmune disease, where we get a low fetal fraction. And the opponent might argue that we will get a no-call report in these cases. But we have to understand that previously when it was launched, NIPT was done using counting methods like shotgun massive parallel sequencing and targeted massive parallel sequencing. But now most of the NIPTs are based on genotyping methods, not on counting methods. So all are basically SNP based. So in this paper, you will get all the information regarding the advantages of the single nucleotide polymorphism based NIPT. So what are the advantages? It is less dependent on fetal fraction, reduced effect of GC amplification bias, effective differentiation between maternal and fetal DNA, and detects triploidy. What is the problem? We need to be careful in twins and in ovum donation pregnancies. But a new algorithm for handling multiple pregnancies is under development already. So we look at the advantages of SNP-based NIPT, which is done commonly these days, less dependency on fetal fraction. The fetal fraction represents the proportion of cfDNA in the maternal plasma that is of fetal origin. It varies among individuals and factors. In the counting methods of the NIPT, which was done in the past, the test accuracy is highly dependent on fetal fraction. But in contrast, the SNP-based NIPT is less dependent on fetal fraction. We have to understand that approximately 1 out of 3 commercial samples have a fetal fraction less than 8%, where this distinction is very, very important. So in the SNP-based NIPTs, even in less amount of fetal fractions, they will give a very high detection rate for NIPT compared to the counting methods, which was done previously. Now, reduced effect of GC amplification bias, very important point in favor of SNP-based NIPTs. When there are fewer or more guanine cysteine pairs than average, the chromosomes do not amplify in the expected manner during the sequencing process. So it is a problem for which method? It is a problem for the counting method, which relies on comparison to reference chromosomes. And therefore, any variation in amplification reduces the detection rate of that NIPT. But this situation, what it does, it decreases the sensitivity of detection for T13 or monosomy X compared to that for trisomy 21 when we do it with the counting methods. But the SNP-based methods is not affected by this amplification bias since it does not require comparison to a reference chromosome. So the results are not dependent on the amount of DNA in a chromosome, but rather on the specific sequence of the DNA. So basically gone are the days when we used to say that trisomy 18 and 13 is going to give a low fetal fraction and we will get a no-call report. You can see here the detection rates are so similar, 99, trisomy 18, 97 and trisomy 13, 93 with very low false positive rates. So those days are gone when we used to say that because of trisomy 18 and 13, there will be a low fetal fraction and no-call report will need invasive testing. No, it is not true. So effective differentiation between maternal and fetal DNA is another advantage of SNP-based NIPT. What it does, it readily distinguishes between the maternal and the fetal DNA by analyzing the Buffy code that contains purely maternal DNA. What it does, it allows for establishment of a maternal-only SNP profile. So in contrast, the counting method amplifies and sequences both the maternal and fetal DNA. They do not differentiate. The counting methods did not differentiate between maternal and fetal DNA. This distinction, where it is important for conditions such as monosomy X, where it is difficult to determine whether the mother is a mosaic for X. So that is why maybe the NIPT is showing a false positive report. So the sex chromosome anomalies determined with the counting method were because of false positives due to maternal mosaicism in most of the cases. So without analyzing maternal DNA separately, the counting methods may conclude a fetal sex anomaly. The SNP method, what it does, it analyzes the specific maternal DNA contribution, which decreases the rate of false positives related to maternal mosaicism. So where is the impact of this? The impact is in this. This is a 2019 article where they specifically say that in addition to trisomy 21, 18, and 13, the sex classification provided a correct classification in 99.6% of all tested pregnancies. But we need to remember...
You need to conclude this.
Yes, sir. Only last point, sir. It also detects triploidy. So a major disadvantage of the counting method is that it cannot detect triploidy, but SNP method does not require comparison to a reference chromosome. That is why it can easily detect parental triploidy, which was shown in this paper by Nicolaides group. And lastly, sir, in screening for trisomies by cfDNA testing of maternal blood in twin pregnancy, this is an ISWOG update where we say that performance of cfDNA for T21 in twins is similar to that in singletons and is superior to FTS or second trimester biochemical screening. And the detection rate and FPR were 98 and 0.05% in cases of cfDNA. So it is very good for twins also. So final slide concluding, NT-NB-DVTR doing a good ultrasound is the method for which we should follow for universal screening in India. NT plus Dover marker, only 2% addition, and we have doubtful quality, but NIPT does not depend on the quality of the ultrasound. That is the best method of screening. Thank you so much for bearing with me. Thank you, sir.
Thank you, Dr. I think we have the debate is on, and I appreciate you bringing in a lot of other points which your opponent would bring before even he started. I think that's a nice thing of a debate, but I'm not sure you're getting the 1 minute rebuttal which we normally have for a debate. But thank you for your presentation. I think we'll move on. Dr. Vinayak Das is our next debater, and he's taking on combined test. Dr. Vinayak Das is a consultant fetal medicine in the new Ramakrishna Seva Sadan, Siliguri. He is an MBBS MS fellowship in fetal medicine and a FMF UK certified for 11 to 13 week scan. He has several publications to his credit, and his area of interest is fetal medicine, of course, and that's why he's here in this CME. So thank you, Dr. Vinayak Das, for joining us, and it's up to you for the next 12 minutes to debate, 10 to 12 minutes to debate on what Dr. Prasanna has done.
Thank you very much, sir. Can you hear me, sir?
I can hear you, but we have to see you too. You have to put your put your presentation on, please.
Yes, sir. Is my screen visible, sir?
Yes, you are heard loud and clear. Your screen is very clearly visible. Please go ahead.
Good morning, everyone. A very warm welcome to all my seniors and colleagues, and most welcome to Bela ma'am and Mandakini ma'am for giving me this wonderful opportunity, and to my mentor and my guide, Prasanna. So today the topic that we are deciding here is the role of combined FTS in the era of NIPT, and I'll be speaking for the motion. So a little introduction at first. Pregnancy is fraught with complications with potential for significant impact on mother, the child, and family life. One potential complication is that the child may have a chromosomal or genetic abnormality that affects the development. The risk of common chromosomal abnormalities is low, approximately 1 in 250 pregnancies at 12 weeks gestation, compared with other complications of pregnancy. But we have chosen to make this the primary focus of our efforts of prenatal risk assessment. In reality, the preterm birth, preeclampsia, and intrauterine...
Your slides are not moving. Your slides are not moving.
Yes, sir. Are much more prevalent and responsible for far more mortality. So what do we mean by the combined first trimester screening? As Prasanna has already said, it means the detection of nasal bone, nuchal thickness, ductus venosus, and tricuspid regurgitation. And to add with it, we use serum analytes to assess the level of beta HCG, PAP-A, inhibin A, maternal serum fat alpha beta protein, and unconjugated estradiol. So of this, the first three are placental products, and the latter two are the fetal products. And as you can see, in doing serum analysis, we are assessing both the maternal and the fetal well-being with a reasonable certainty, which I will delving deeper during the course of my talk. So what are we fighting for? What is the most common cause of maternal mortality? It's hemorrhage, followed by hypertension, which could be prevented by applying the serum analytes during the first trimester, routine first trimester screening. Also, even in neonatal mortality, preterm birth is not a small byproduct of maternal hypertensive complications. and which far outweighs and far heavier than the congenital abnormalities for neonatal mortality. So in my debate, I will focus on 4 pillars on which I believe the serum analytes or combined FTS should be the backbone of our screening methods. So firstly, coming to the detection of atypical chromosomal abnormalities. So the objectives of this study was to assess that targeted non-invasive prenatal testing for trisomies 21, 18, and 13 and sex chromosome aneuploidies could be an alternative to traditional karyotyping. The aim of this study was to determine the risk of missing other abnormal karyotypes of probable phenotypic significance by NIPT. So the result was that the combined FTS was performed in 193,638 pregnancies, 10,205 were cytogenetic or molecular analysis done. Of this, 9,461 were prenatal and 797 were postnatal and abortion. So on analyzing the result, it was found that out of 10,205, 1,122 or 11% had an abnormal karyotype, of which 262 or 23.4% would have been missed by NIPT, but would have been clinically significant. So the presence of such atypical abnormal karyotypes was increased in women above 45 years of age with increased nuchal translucency and less fetal beta HCG or less PAP-A. So as you can see, in absence of any serum analytes, we are going to miss this important cohort of abnormalities, which is clinically significant. So this is another study to investigate by means of population-based analysis the cohort of women who underwent combined first trimester screening, the changes in uptake of invasive prenatal screening according to risk of trisomy 21 on combined FTS, and the prevalence and methods of ascertainment of atypical chromosomal abnormalities. And as you can see, the prevalence of chromosomal abnormalities were 0.4%, of which 25.1% were atypical chromosomal abnormalities not detected by NIPT. So the same study, we can assess that the atypical chromosomal abnormality, the prevalence decreases with a lower risk in combined FTS, but the proportion of our chromosomal abnormalities will only increase. So in this slide, you can see that lower the PAP-A, the lower the PAP-A and the lower the beta HCG, the chances of the higher atypical karyotype is as much as 46 times and 78 times respectively. So in conclusion, that until recently, combined FTS was recognized as the most effective test for identification of pregnancies at risk of increased chromosomal abnormalities. And although combined FTS is not traditionally designed to detect atypical chromosomal abnormalities, clinical experience have shown that around 30% of this will be detected by using increased invasive testing. And in the era of universal NIPT, we may no longer be able to test this atypical chromosomal abnormalities unless they present with abnormal ultrasound findings, which may or may not be present. So these conditions will have a significant poor outcome than trisomy 21 and should be a real concern when defining prenatal testing. Next, coming to the point of NIPT in twins. So only using maternal age and nuchal thickness, the detection rate is 69.6% with a false positive rate of 7.8%. The addition of serum biochemistry, this jumps to 89.5% and false positive rate of 7.2%. So this study shows the value of combined FTS in twins pregnancy, an area where NIPT doesn't perform very well, or rather should I say, it performs well with relation to trisomy 21, but does not perform well, and or there's a paucity of data concerning trisomy 13 and 18, and it does not give any extra benefit to the other adverse pregnancy outcome related to twin pregnancy. Next, we go to the abnormal biochemistry and abnormal biochemistry and serum anomalies, structural abnormalities. So in this study, we can see with the increase in alpha-fetoprotein, the chances of neural tube defect increases. So addition of serum alpha-fetoprotein will only enhance the sensitivity of detection of neural tube defects in the first trimester itself. So as long as we keep a fixed false positive rate of 10% and we apply all markers, the detection rates for neural tube defects can be increased up to 70%. Now, increasing abnormal biochemistry may also be helpful in informing the prenatal diagnosis of other conditions. For example, if there's low beta HCG and PAP-A seen in asymmetrically grown fetus with a small placenta, this could be indicative of a triploidy, which might not be detected by NIPT. Finding of a low PAP-A with a congenital diaphragmatic hernia could be symptomatic of a Cornelia de Lange syndrome. I admit that these conditions are rare, but this is the beauty of serum analyte testing. It gives us the opportunity to make a diagnosis at 11 to 13 weeks itself, which may be lost if biochemical testing is discontinued. Now coming to the most important facet of the debate, using serum biochemistry to define risk of adverse pregnancy outcome. Now, as we have said earlier, that the hypertension complications is a major cause for not only mortality, but also iatrogenic preterm delivery. And as an obstetrician, it is a very important thing. The serum analysis gives an invaluable window into the future of pregnancy and helps us prevent complication. So, as you can see, Yaron et al. Defined odds ratio for prediction of hypertension, IUGR, placental abruption, intrauterine death, and preterm birth by using AFP, raised beta HCG, and reduced estrol back in 1999. And combination of these markers were most predictive with odds ratio ranging from 3.2 to 11.1 for IUGR, abruptio, and IUD. So first trimester screening is an important bulwark in the detection of preeclampsia, with up to 90% detection rates for early preeclampsia less than 32 weeks and up to 70% detection in preeclampsia less than 37 weeks and up to 40% detection rates in eclampsia after 37 weeks. So this is a significant uptake. This is a significant uptake compared to using maternal characteristics alone or with blood pressure and uterine artery parameters. So this signifies the importance of serum analytes in the first trimester itself. Also, adding of low dose aspirin is an effective intervention in the high-risk cohort by reducing 90% reduction in the prevalence of this early onset type of disease. Now coming to the fetal growth restriction and serum analytes. The low PAP-A less than 0.41 mom has an odds ratio of 2.6 for the developing small for gestation age fetus and a 3.6 odds ratio for severe small for gestation age fetus. So, and also low PAP-A and low beta HCG has been associated with increased frequency of adverse obstetric outcome, including small for gestational age fetus. Assessing the impact of serum analytes with stillbirth, the low PAP-A is associated with stillbirth, which is due to impaired placentation. And if we add all the ultrasound parameters, the detection rate only increases. So if we add serum biochemistry, the prediction rate increases from 36% to 55% for stillbirth due to impaired placentation. And the detection rate increases from 31% to 40% in all stillbirths. Lastly, coming to the cost factor, the elephant in the room. Now, all the studies that have been done regarding NIPT as the universal screening method were funded as a part of the universal healthcare or as a research grant. And even then, the cost has been prohibited even in developed countries. The most important thing is that this huge investment for NIPT will only benefit in detection of aneuploidies, mostly trisomy 21, with limited or no benefit in detection of other adverse pregnancy outcomes. So this is impractical for developing countries such as us due to the financial constraint of our patients. So these studies, they have they have
last 1 minute left, sir.
Yes, ma'am. They have assessed the feasibility of universal NIPT, and they have said, however, at current prices, the implementation of NIPT as a second-tier screening test is much more cost-effective than deploying it as a universal test. So, as you can see here, an NT scan with a serum analyte costs around 3,000 to 4,000 in our country, and if we add PIGF, another 2,000. But baseline NIPT will cost around 15,000-20,000 itself. And we have to add an ultrasound with that NIPT. So this ballooning of cost, given the healthcare is solely dependent in the out-of-pocket expenses on the patient, is unjustified, I feel. So in conclusion, it is clear that biochemical evaluation of placental function will play an important role in determining risk of ongoing pregnancy complication. The question is how many markers should be included and how often should they be repeated, rather than whether they should be withdrawn. The future of the screening should be application of inexpensive tools that are available to whole population. Cell-free DNA screening is too specific and too expensive to provide a solution. So in my opinion, we should be aiming for more addition of serum markers like alpha-fetoprotein for neural tooth defects and PIJ for preeclampsia rather than less. Thank you, sir.
Thank you, Vinayak. I think wonderful points brought across by Dr. Vinayak Das and Dr. Prasanna Roy. The final word will not be said. I think we will be continuing this discussion in days to come and years to come. I'm sure that there will be more evidence emerging which will tilt us on either side. But till now, all the points, wonderful points which you have expressed were all well taken. And I think we will continue debating on this in the days and years to come. So thank you very much for presentations, and we will move on with our scientific program. Thank you very much.
Right. Thank you, sir, for summarizing the debate well. And I move on to the next session, which is capsules. And for that, I invite Dr. Aarti Yevlik. Can I please see her CV? Can please her CV be projected? Dr. Aarti is a gynecologist from Pune, and she's a current fellow in fetal medicine. Fellow also in obstetric ultrasound. I invite Dr. Aarti to continue with the proceedings for today's scientific program.
Thank you so much. Now we move on to the capsules session for today. For that, I would like to invite our moderators. Can I have the CV, please? I would like to invite Dr. Chinmay Rata. So Dr. Chinmay Rata needs absolutely no introduction. She is the director and the lead consultant at Resolution Fetal Medicine Center in Hyderabad. She is the Fetal Medicine Foundation UK approved examiner in India, and she also conducts ICOG FOGSI certification training courses in her center. I'm very, very privileged to be her student. Ma'am, thank you so much for being here with us today.
Thank you.
And, Dr. Preeti is our second moderator. Can I have her slide, please? Madam is the founder, secretary, and secretary of Fetal Medicine, the Orissa chapter. She has conducted many conferences, Fetal Medicon 2015, 16, 17, and I'm sorry.
And they took out the apple.
Sorry, there's some disturbance in the background. I apologize for that. And she is the coordinator of Color Doppler workshop at the 61st AICOG held in Bhubaneswar. Ma'am, thank you so much for being here with us today. And I would invite the moderators to introduce the speakers.
Thank you so much. Thank you, Aarti, and welcome Preeti on board. And as we move on to yet another exciting session, and this is exciting because it's full of energy coming from the young blood, the young Turks of fetal medicine who are going to take the science of fetal medicine forward in this country. It's called capsules because, you know, capsule is the smallest form of intervention that you can give for any medicine. And in a very, very short span of like 4 to 5 minutes, they will give you short impulses of the gist of certain very, very important topics which commonly lead to confusion in the practice of fetal medicine. This is a new concept we've brought in. The faculty in this particular section are relatively young, inexperienced in presenting. So bear with us what they do, but I'm sure you will come up with something fresh in this section. So can I request my co-moderator, Dr. Preeti, to introduce the first speaker. Dr. Preeti? Dr. Preeti, can you unmute yourself? Okay, we'll move on. This is the first speaker in this session is Dr. Sahiti Reddy. She's a junior consultant in fetal medicine at the Resolution Fetal Medicine Center and Research Institute in Secunderabad. And she's done her DGO from the Navodaya Medical College, Karnataka, a fellowship in fetal medicine. And she did the ICOG certification course in 2019, which she topped and got the gold medal. She's presented her research papers in many conferences, and one of her articles on the fetal supernumerary limb is currently under review for the WISWOG publication. So welcome, Dr. Sahiti. She is going to give us a short capsule about a common condition called single umbilical artery.
Good afternoon, everyone. And at the outset, I would thank Dr. Chinmayratha ma'am for giving me this opportunity to speak over here. So I would be talking about the single umbilical artery. So as you all know, the normal umbilical cord has 2 arteries and 1 vein, and SUA is a malformation of the fetal cord where there will be a single umbilical artery instead of 2. This is the most common pathology in humans. Duckworth, way back in 1908, reported the first case in American literature, whereby Morin and Winsberg in 1978 made the use of ultrasound to detect the single umbilical artery. As you know, at first, there are 4 vessels in the connecting stalk, but later the right vein disappears, leaving behind 2 umbilical arteries and 1 umbilical vein. These are the pictures showing the umbilical cord vessels in first and second trimester, and very well known Mickey Mouse sign, which depicts the 3 vessel cord. So knowledge of normal development of umbilical cord is necessary to understand the malformations. The umbilical cord and elements are formed between
Sahiti?
Ma'am, we're having a little technical issue. I think Dr. Sahiti has lost her connection.
And around trilaminar disc, which forms the future yolk sac, connecting stalk. At day 17, if you can see, the allantois goes as a stalk into the growing yolk sac, and later by the involution of the primary yolk sac, a secondary yolk sac is formed, and we can see a vitelline duct which connects at the caudal end of the embryo. By 4 weeks, the vitelline duct and the allantoic duct become caudal and to each other. By day 38, angiogenesis takes place in the mesenchyme, and the vitelline duct and the allantoic duct, there are vessels around it. So if you see, initially, the vitelline arteries provide the dominant source of circulation in early gestation, and thereby they concede the primary circulation to developing allantoic vessels. Initially, there is a single umbilical artery in the body stalk, but later, due to differentiation and bifurcation towards the caudal end, they form a pair of umbilical arteries. Now, the amnion is attached to the margins of the umbilical opening and forms a wide tube connecting. It contains a vitellointestinal duct and remnant of yolk sac, the mesoderm which converts into the Wharton jellies, the blood vessels passing from the embryo to the placenta, and small part of extraembryonic coelom. The mechanism of the development of single umbilical artery remains unclear, but most likely accepted pathology is secondary atrophy of or atresia of previously normally developed umbilical artery. If you see, the umbilical artery can be either an isolated finding or an associated finding. In an isolated finding, there are no chromosomal or structural abnormalities and maternal risk factors. Coming to the classification, there are 4 types of SUAs depending upon the vessels within the cord. The type 1 is most common, where there are more than
Sahiti, your connection is gone again.
Some connection.
You can switch off your video and just talk. Okay, I think we'll move on.
Dr. Sahiti, can she
Sahiti,
hear us?
are you back?
Can you hear us? Please switch off your video so that we can hear you.
Yeah, we'll move to next session.
I think we'll move to the next speaker. And Saiti, are you back? Unmute yourself, switch off your video, and just start from where you left and complete it. Yeah.
So type 4, you see two patent vessels, that is one umbilical artery, either of allantoic or vital line derivative, and the right umbilical vein. So coming to the epidemiology, you see about 0.
Okay, move your slide ahead.
Again, she lost.
We cannot hear your voice, Saiti.
And she has a very poor connection. It's not.
Yeah, I think Saiti will stop this and move on to the next thing.
Ultrasound in a transverse section held previa or velamentous. The cord can be abnormally long or abnormally short. So what all to look for to rule out on TIFA? The renal pathologies being the most common, you have to look for renal agenesis, hydrouretronephrosis, cloacal extrophy, and renal dysgenesis. In heart, you should look for an appropriate four-chamber to rule out hypoplastic left heart. On color Doppler, the tricuspid atresia and tetralogy of Fallot. In GIT, you can have an either CDH or a duodenal atresia. If you see in the brain, acrania can be ruled out as early as in first trimester. In the second trimester, you look for any cerebellar abnormalities, holoprosencephaly, microphthalmia, or meningomyelocele. Coming to the musculoskeletal system, gastrochisis and amphalocele can be there. You have to look for any rocker bottom feet or CTV along with the sacrococcygeal teratoma to look in the spine. IUGR still remains the main concern in structurally normal and isolated fetuses, and 15 to 20% cases can be affected. IUGR occurs when the harmful influence occurs which inhibits the mitotic division at vital time in embryogenesis. Other form of IUGR is the harmful influence permits the cell division but reduces the cytoplasmic mass. The first type is seen in associated fetuses and the second type is seen in isolated fetuses. So how do you manage the cases with single umbilical artery? Prenatal detection of SUA with no other anomalies should not alter the obstetric management. A proper structural evaluation of a fetus with a clear checklist will help in optimizing the outcome by following individualized antenatal care. So the flow chart which we should follow at every center is when you detect an SUA, you have to do a detailed TIFA and you have to see whether it is isolated or associated. In isolated cases, you call back the patient for a fetal echo. In associated cases, you offer karyotyping based on the minor markers, and if there are major abnormalities, you counsel based on the prognosis. At the fetal echo, if it is normal, you follow up the baby with the growth scans. If the fetal echo shows a complex anomaly, then you counsel based on the prognosis of the abnormality, and if it is a correctable anomaly, then you rule out the karyotype of the baby. At growth scans, if everything falls in place and grows along, you have to deliver the baby at term. In growth scan, if you detect either SGA or IUGR, the follow-up will be based on the Doppler evaluation and delivery should take place. A detailed neonatal evaluation with renal pathology ruling out should be the most important one after delivery. Thank you.
So thank you, Dr. Saiti. You can stop sharing your screen. There's one quick question for you from Dr. Kushagrati Ghosh. Should we be doing CMA or KT in every case of single umbilical artery?
No, ma'am. In isolated cases, if they have a first trimester screening and there are no other maternal complications, we need not offer them CMA or KT, ma'am.
So doing the first trimester screening is important. And if that is normal, then you may leave it as an isolated one. Thank you very much for your thing. I request everyone else to have their internet connections sturdy. And with that,
thank you, ma'am. I'm sorry for the disconnection.
No problem. Good luck to you in future. And let's move on to the next presenter. Dr. Megha Sharma is our next presenter in this capsule session, and she is a very enthusiastic youngster in fetal medicine, a gold medalist from SMS Medical College, Jaipur, has done a fellowship in minimally invasive surgery and a PDCC in high-risk pregnancy and fetal medicine at SGPGI, Lucknow.
So currently she is a consultant high-risk pregnancy and fetal medicine in Kota, winner of the Indumati Javeri Award in the AICOG 2016, Young Talent Award 2013, and another Indumati Javeri Award in 2013. So welcome, Dr. Megha, and we look forward to your presentation.
Thank you, ma'am.
Please share your screen.
Yes, ma'am. Can you see my screen now?
Yeah. So she's addressing fetal renal pelvic dilatation. Again, another common condition, leads to a lot of confusion.
Yes, ma'am. Pilactasis, or the renal pelvic dilatation as we call it, is one of the most common findings that we encounter during a routine PIFA or a second trimester scan. Pilactasis is defined as isolated renal pelvis dilatation without dilatation of any renal calyces, and it may complicate around 4.5% of all pregnancies. But mild pilactasis can be transient physiological also, and it has been shown to be associated with aneuploidy, especially trisomy 21. While hydronephrosis is a broader term, it is renal pelvic dilatation with variable degrees of calyceal dilatation, and it is significantly associated with congenital anomalies of the kidneys and the urinary tract. So why is detection of pilactasis important? It is important for two major reasons: the detection of aneuploidies and for prognostication of the fetus. That is, for detection of postnatal uropathy if present in the fetus. Older classification was dependent only upon the renal pelvic diameter, dividing it into mild, moderate, and severe types. But a recent newer classification called the urinary tract dilatation classification has been given, which gives A1, A2, and A3 in the antenatal criteria or antenatal categories. Any renal pelvic dilatation less than 7 mm in the second trimester and less than 10 mm in the third trimester is considered as category A1, while any renal pelvic dilatation more than 7 mm in the second trimester and more than 10 mm in the third trimester, with or without any other features of peripheral calyceal dilatation, any abnormal renal parenchyma, any abnormal renal appearance, ureteronephrosis, bladder wall thickening, or a finding of unexplained oligohydramnios along with pilactasis is classified into A2 and A3 categories. So we all know the etiology. The obstruction in such cases can be at any. It can be uretropelvic junction obstruction, it can be vesico-ureteric junction obstruction, it can be any obstruction at the urethral level, the posterior urethral wall, the urethral atresia, or it can be only a transient ureteric reflux as well. But in all the cases, the renal pelvic dilatation is the first manifestation in such abnormalities. Measurement of renal pelvis is also very important. It is to be measured only in the anterior posterior diameter and preferably in 12 o'clock position. And it is highly variable over 2 hours of USG examination also. It is also dependent upon the maternal hydration status. The same renal pelvis that we measure 7 mm at one point can change to maybe 6 mm or 4 mm when we see the fetus in a day or two. So prediction of outcome after a single scan is extremely difficult in pilactasis. We need to follow up the fetus 6 to 8 weekly or even frequently than that, and then prognosticate according to what progression we get in the pilactasis. Mostly mild pilactasis, less than 7 mm diameter, 80% of them resolve antenatally. While moderate to severe pilactasis that corresponds to A2 and A3 categories require, 1/3 of them require post-sickle surgery, and they need detailed evaluation post-sickle. So if we encounter pilactasis in a mid-trimester scan, we should do a thorough evaluation of the renal system of the fetus. We should look for bilaterality, any abnormality of the contralateral kidney present, any renal parenchymal thickness or any abnormal appearance. We should look for calyceal dilatation, the ureteric dilatation, any abnormalities of the urinary bladder, urethra. Of course, the level of fluid, whether oligohydramnios is present in the mid-trimester or is it progressing or not. The presence of any associated malformation or any of the soft marker that we can see, that will warrant an invasive testing in such case, and the presence of NLP as well. So because A1 categories have a very low risk of postnatal uropathy, while in A2 and A3 categories, there is a high risk of postnatal uropathy. And hence, there is a need of postnatal evaluation and intervention in such cases. Mild pilactasis is a high risk of trisomy 21 with a positive likelihood ratio of 7.63 and an isolated likelihood ratio of 1.08. So such cases should be advised for a serum screening or even better an NIPT. If the serum screening or NIPT comes out to be low risk, then we don't need an invasive testing in such cases. We just need to monitor the fetus by USG to see for progression. However, if we get any high risk category in the serum screening or NIPT, an invasive testing should be advised in such cases. So this is a flowchart mentioning how to manage if we get a renal pelvic dilatation of more than 4 mm in the second trimester. We should look for bilaterality. If it is not bilateral, we can do a repeat ultrasound examination the third trimester. However, it is bilateral, and if oligohydramnios is present, oligohydramnios is a single most important prognosticating factor in these cases. If oligohydramnios is present in the second trimester itself, during the TIFA time, it is definitely a poor prognostic factor. However, if oligohydramnios is not present, we can follow up the case every 2 to 3 weeks, look for the level of fluid, and then monitor accordingly. And we can plan the delivery of the baby as well, according to the gestation and according to the level of oligohydramnios. Postnatal follow-up of such cases is required. Usually a sonography is done after 48 hours because in the first 48 hours of life, the baby is in a relative state of oliguria. So ideally after 48 to 72 hours, a sonography was done. Although in severe cases, we need to do it immediately as well. So current recommendation is evaluation of the fetal kidney should be a part of a routine mid-trimester scan at 16 to 20 weeks. And if pilactus is visualized, it should be done in a proper method. A detailed USG should be done to rule out other soft markers or other major malformations. Serum screening or NIPT should be offered. And if it comes out to be high risk, then the patient should be offered for invasive prenatal testing. Otherwise, if it is mild pilactasis and with no high risk in serum screening or NIPT, the patient can be assured of a good prognosis. But the babies should still be followed up in the subsequent USG scans, and the progression of pilactasis should be noted. Thank you.
Thank you, Dr. Megha. You can stop sharing now, and that was wonderful, very nicely put. So all of you had got only 4 to 5 minutes and you've all stuck to your time, which shows that if you want, you can put in as much information as you want in the designated time. So wonderfully done, and that shows the importance of, again, doing the first trimester screening, because minor renal pelvic dilatation is a common finding, as you said, and it can be seen in the second trimester scan. If the first trimester screening has been normal, then the anxiety is less. So that inversion of the pyramid of antenatal care, we are going back to that again and again. So that is how it works. Do your first things first, and then things will be good. Excellent, Dr. Megha. Thank you so much. Dr. Preeti, will you like to introduce the next speaker, please?
Yeah. Please, yes, ma'am. Thank you for this opportunity. I wish everyone a happy Fetus Day. We can do justice for the fetus. Thank you, Chinmay ma'am, for this opportunity. So our next speaker is Dr. Soumya Srivastava, who has done DNB and MS in ONG. She has done PDCC from SGPGI Lucknow. She is a consultant fetal medicine at Santevita Hospital, Ranchi, and Sansrishti Fetal Medicine Clinic at Hazaribagh. She is affiliated to ISUOG, SFM, and FOGSI, and she is a certified operator at FMF. She has been awarded as the CS Dawn Based Paper Prize at the 11th NARCHI World Congress, and her special interest is fetal diagnostic and therapeutic procedure. So she is going to talk about echogenic bowel. So I welcome you, Soumya, to the dais. You can share your screen.
Yes, ma'am. Thank you, Dr. Preeti ma'am, for the kind introduction, and good afternoon to all. So I'll be speaking on echogenic bowel. Echogenic bowel is a frequent sonographic.
Soumya, you need to share your screen.
Okay, just one, sorry. Is my screen visible?
Yes, please make it full screen. Yeah.
Sorry for that. Echogenic bowel is a frequent sonographic finding in the second trimester scans with an incidence of 0.4 to 1.8%. Normally, the bowel is as echogenic as the liver, and when this echogenicity is equal to or greater than the surrounding bone, most commonly the iliac wings are used for comparison, then it is reported as echogenic bowel. It is important that the transducer frequency is less than 5 megahertz, as higher frequency transducers tend to give a false impression of echogenic bowel, and the gain settings should be reduced so that only the bone appears white while making this diagnosis. A grading system has been used for reporting echogenic bowel, where grade 2 and grade 3, that is echogenicity equal to bone or greater than that of bone, is clinically significant. Now coming to the causes, it may be a transient idiopathic finding in about 0.5% of fetuses, where due to an intraamniotic bleed and fetal swallowing of the blood, an echogenic appearance of bowel may be present. It is a soft marker of aneuploidy, mostly trisomy 21, where due to bowel hypotonia and desiccation of the meconium, the echogenic appearance of bowel is seen. In intrauterine infections, particularly the cytomegalovirus infection, an echogenic bowel appearance is present. And in cases of primary gastrointestinal pathology, where there may be bowel obstruction, bowel atresia, perforation, or even Hirschsprung's disease may cause an echogenic bowel appearance in second trimester. Cystic fibrosis is a genetic condition with autosomal recessive inheritance. And in this case, there is mutation in the cystic fibrosis CFTR gene, which causes a viscid and thick meconium. So further evaluation is very important whenever a finding of echogenic bowel is made for further counseling and prognosticating our babies. A detailed anomaly scan is must, and we should look for bowel dilatation, meconium pseudocyst, ascites, peritoneal calcifications, which are suggestive of meconium peritonitis subsequent to bowel obstruction and perforation. And these findings are suggestive of primary GI pathology. Other soft markers of aneuploidy should be looked for from head to toe of the fetus, and the risk of trisomy 20 based upon the a priori risk and the likelihood ratio of the soft markers present. An isolated echogenic bowel has a likelihood ratio of 1.65, and this should be used for modification of the risk when it is present in isolation. So as in this case of trisomy 21 fetus, echogenic bowel was seen associated with an unossified nasal bone and a brachycephaly. Other features of intrauterine infection should be searched for, which may be microcephaly, ventriculomegaly, periventricular calcifications or cataracts, which are suggestive of intrauterine infections, and other organ systems should be evaluated as there may be an increased incidence of renal or cardiac anomalies. So after your detailed anomaly scan, a further testing is offered in the form of parental cystic fibrosis carrier testing, which can be done so as to know which further tests have to be performed on our fetus for confirmed diagnosis. A maternal torch IgG, IgM can be offered, however, are often inconclusive. An amniocentesis should be offered even with isolated echogenic bowel, as 4 to 20% of aneuploid fetuses may have it as an isolated finding. And amniotic fluid should be sent for fetal chromosomal analysis in the form of either karyotype or more commonly chromosomal microarray these days. A polymerase chain reaction test for intrauterine infections are ordered, particularly for CMV, toxoplasma, and rubella, and after 20 weeks of gestational age, when these pathogens are excreted in fetal urine, because before this time, we may miss out on these infections. And when these above tests are all normal, even with isolated echogenic bowel, a follow-up scan in the third trimester should be offered to look for fetal growth and any evolving gastrointestinal pathology, which may not be evident in the second trimester. So coming to the prognosis, if isolated, echogenic bowel has excellent prognosis. We need follow-up to look for any growth restriction. There is slightly increased risk of sudden IUD, for which close follow-up is required. If there is fetal chromosomal abnormality diagnosed on amniocentesis, a termination of pregnancy can be offered in mid-trimester. If there is a confirmed intrauterine infection on testing, prognostication is important based upon the findings of cranial, any cranial abnormality and any other GI pathology. If cranial abnormalities are absent, then a 4-weekly follow-up scan should be advised. Treatment can be offered in the form of antiviral drugs in CMV, however, still under research. With toxoplasmosis, we give pyrimethamine and sulfadiazine. And a referral should be done to pediatric surgeon if a gastrointestinal pathology is suspected for timing and place of delivery. And the pediatrician should always be informed at birth so that the neonate can be further evaluated. Thank you.
Thank you, Dr. Soumya. That was excellent. And I think you brought out an important point that it has a good correlation with a lot of other pathologies. Can you stop sharing your screen? And
Yes,
the important thing is why you said that aneuploidy testing should be offered. Well, offered is okay, but the incidence may be 4 to 20%, but the isolated likelihood ratio of isolated echogenic bowel is not that much. So if you've again done your first trimester screening well, and you've looked for all other markers in the second trimester scan, and isolated echogenic bowel is your only finding, then probably you can reassure them with regard to the aneuploidies. And again, persistent echogenic bowel and resolving echogenic bowel, they are two different things. So if it is persistent, then your referral to the pediatrician and everything is very important. But very many times, once the fetus swallows clear amniotic fluid, there may be resolution in the third trimester, and that's good. Please stop sharing your screen so that the next. And thank you very much. Dr. Preeti, any comments?
Yes, madam, it was nice, but we need to screen for the couple to rule out cystic fibrosis, because sometimes we may miss.
She said that point she made, that
yeah,
we'll do a parental carrier testing.
Because
That
I
is
had
also
a patient, who was in intermediate risk for Down syndrome, and we tested for Down syndrome, but we didn't screen for cystic fibrosis. So we missed that, and that baby was born with cystic fibrosis. I lost the follow-up after TIFA scans. He didn't return
carrier
back.
screening
So
of one of the parents also will be enough. So if one of the parents is a carrier, then you need to test the other one.
Mother.
Excellent.
Mother can be screened for the.
Yeah. So with that, we come to the next capsule. And our next speaker is, I think, Dr. Shruti Jain. So Dr. Shruti Jain is another young Turk from Noida, and she's currently consultant fetal medicine and genetics in the Kailash Hospital and Neuro Institute of Noida, member of the Fetal Medicine and Genetics Committee of FOGSI, certified by the FMF UK for fetal scans. Her graduation is from Delhi, and she's trained in medical genetics in Vellore. Done a maternal fetal medicine fellowship in Lucknow SGPGIMS, and received several awards, notable of which are an honorable mention in the John J. Sciarra Award, International Journal of Obstetrics and Gynecology by FIGO, the Dr. R.D. Pandit Research Prize, AICOG for the best thesis in 2012, the Dr. Kusum Pandit Memorial Award for the best thesis of all specialties 2013, and many publications in national and international journals. So Dr. Shruti has the indomitable task of concising everything in fetal therapy to 4 to 5 minutes. So Dr. Shruti Jain, the stage is all yours. Are you unmuted? We can't hear you, Dr. Shruti.
Good afternoon, everyone. Is my screen visible, ma'am?
Yes, everything is okay. Now go on.
Thank you so much, ma'am. So we'll be discussing fetal therapy in this session. Fetal therapy is a heterogeneous cluster of interventions which are given to fetus before it is born, with the intention to either save life of fetus or to prevent permanent disabilities. These can be either medical therapy or surgical therapy or gene therapy. Medical therapies can be given by various routes. It can be transplacental, wherein drug is given to the mother. It crosses placenta to reach the fetus. It could be transamniotic with direct instillation under ultrasound guidance into the amniotic fluid or into the muscle of the baby, intramuscular, or intravenous into the umbilical cord. Medical therapy can also be classified as prophylactic or therapeutic. Prophylactic, we've been using day in, day out, like folic acid for prevention of neural tube defects, injection anti-D for prevention of RH isoimmunization, low-dose aspirin, very important for prevention of preeclampsia, and there are many more other uses as well. Then there are lots of therapeutic indications. In cases of fetal supraventricular tachycardia, digoxin given to the mother has been shown to reverse fetal arrhythmia in a good number of cases. And in certain severe cases like fetal hydrops, when it is associated, then intravenous administration can also be done. Then in cases of congenital hypothyroidism, intraamniotic thyroxine injection has been shown to be beneficial. And there are a lot of other uses, like in cases of autoimmune thrombocytopenia, congenital heart block, and certain fetal infections, as we already discussed. Coming on to surgical therapy, we already had a mesmerizing session by Dr. Prashant sir. Surgical therapy can be divided into ultrasound image-guided procedures, or they can be done fetoscopic under fetoscope guidance, or they can be open surgeries and exit procedures. In ultrasound image-guided procedures, under ultrasound guidance, a needle, a shunt, or a trocar is introduced, and the procedure is performed. These can be used for diagnostic purpose. We all know chorionic villus sampling, amniocentesis, amnioinfusion, and cordocentesis. Then there are lots of therapeutic uses as well. Intrauterine transfusion for treatment of fetal anemia, amnioreduction for polyhydramnios, shunts like pleuroamniotic shunt for pleural effusion, balloon valvuloplasty, radiofrequency ablation, and interstitial laser coagulation for selective fetal reduction, and certain placental tumors can also be treated by these procedures. Coming on to fetoscope guided procedures, where fetoscope is introduced into the uterus and under direct visualization procedure is performed. These can be, lots of centers are doing placental laser ablation of anastomosis for treatment of twin-twin transfusion syndrome. Then umbilical cord occlusion is being done for selective fetal reduction. Fetal endoscopic tracheal occlusion is also being used for treatment of, enhancing lung growth in cases of CDH, and fetoscopic amniotic band release has also been attempted. Coming on to exit procedures, in these procedures during delivery, the baby's head and shoulders are delivered, and before delivering full baby and cutting the umbilical cord, fetus is intubated. So these procedures are basically done for management of anomalies where newborns' airway is getting compromised, like certain tumors, congenital high airway obstruction, and after fetal for removal of tracheal balloon. Open fetal surgeries, in these surgeries, a hysterotomy incision is given. The fetal part to be operated is exposed, fetal surgery is done, and then the uterus is closed. Myelomeningocele repair is being done in certain centers in West for this neural tube defects, and we are all aware of the famous MOMS trial. Although open fetal surgeries have shown fetal benefits, but they also have significant maternal risk. There's a risk of uterine rupture of this hysterotomy incision, and these surgeries are still in inception stage in our country. Gene therapy and stem cell therapy, they have a theoretical role. They're still under experimental stage. Fetus, we know, is immune tolerant, so they are being considered, but it will take time for them to come into clinical practice. Although we have come a long way in fetal therapy, there is a longer way to go because there are lots of challenges. There's wide range of outcome. We know intrauterine transfusion is the standard of care for fetal treatment of fetal anemia, but then there are certain treatments like vesicoamniotic shunt, which were previously used for prevention of renal damage and bladder outlet obstruction. It has gone into controversy after Pluto trial. So research as such is difficult in case of fetal therapy because conditions amenable to treatment are very rare, and most of the times collaboration is needed. And there's a long learning curve. If a center somewhere has produced good results, it takes time for other centers to gain that level of expertise and produce similar results. In fetal medicine, we consider fetus as our patient, but we must not forget for every therapy, every fetal therapy, we have to go through mother. So the risk-benefit ratio should always be weighed. And last but not the least, a good counseling and a good consent is must for all fetal therapies. Thank you so much.
Thank you, Suti, for that wonderful presentation. I think you need to give more emphasis to intrauterine transfusion and drug infusion, how we are doing practically in day-to-day practice.
Yes,
and these things that open surgeries and all we are not doing in India. Till now, no one has done.
Yes.
So you could have emphasized what we are getting on day-to-day practice, what are the cases we are getting. So anyway, you have done it very well.
I think summarizing the entire fetal therapy into 5 minutes is a big, big daunting task. And this particular session was for these youngsters to kind of, bring out the basic minimum, say what you're going to write in an exam or what you're going to answer in a viva, something of that sort where you have a bird's eye view of everything and in a very, very short time. So what Dr. Preeti is saying is about practical application, the therapeutic interventions which we use on a daily basis. And I think Prashant sir gave us a very, very extensive look into all that. So overall, today's audience would have benefited by that detailed analysis of Dr. Prashant and this quick summary by Dr. Shruti. So thank you very much, Dr. Shruti. And Dr. Preeti, can you take on to the next speaker now?
Can I have the CV, please?
Dr. Namrata.
Our next speaker is Dr. Namrata Kumar from King George Medical University, Lucknow. She is an associate professor in the Department of O&G. She is FMF accredited for anomaly scan. She has received many awards for her credit. She is the best student for best postgraduate student, and she received the Dr. N.B. Gold Medal Prize from KGMU. Dr. Krishna Mukherjee Medal for the best paper in recent advances by UPOG Society in 2013. Dr. Jagdishwari Misra Award for the oral presentation in ISOPERB, and in INSOC 2015, she has received the third poster prize in the poster presentation. Over to Dr. Namrata Kumar. She is going to give emphasis on amniocentesis. Thank you. You can share your screen now, Dr. Namrata.
Thank you, ma'am. Good morning, everybody. Is my screen visible?
Yes, yes.
So at the outset, I would like to thank Dr. Chinmay ma'am and Dr. Mandakini ma'am for giving me this opportunity to present in this amazing platform. So I'm here to speak about amniocentesis. So we know that amniocentesis is a diagnostic technique for withdrawing amniotic fluid from the uterine cavity using a needle wire transabdominal approach. And the indications, we know that it is done for studying the prenatal genetic studies, be it raised risk for trisomy, or so many other things when we find a major soft marker or a fetal anomaly, to evaluate for the fetus for infection and to test for genetic disorders like thalassemia and sickle cell disease, and sometimes for biochemical tests for kidney functions also. So the timing, it is done after 15 weeks. We have recently got an updated guideline from the RCOG in October 2021, which has again confirmed that it is best to perform amniocentesis after 15 weeks, because before that, there is high risk of developing equinovarus in early pregnancy amniocentesis. If we do amniocentesis later in pregnancy, there is slight risk of having preterm birth, but there is a 10% chance of having less adequate sampling and more chances of culture failure. Sometimes we do in third trimester just for the counseling sake. We know that termination is not possible in third trimester in our country. Now, if we talk about the test which we do karyotype, which is available in 14 to 21 days, interphase FISH, which is available earlier, and chromosomal microarray, which is the test of choice these days, which is available earlier than karyotype. But before we go ahead for any invasive procedure, we need to do a lot of counseling so as to tell the woman what is the purpose of the procedure, the complications, the implications of the results, and also any available alternatives which we can offer. So the procedure requires guidance from the ultrasound. We should avoid the placenta, or if placenta is there, we need to choose the thinnest portion. We can use Doppler to avoid any vasculature. Antibiotic, local anesthesia, or uterine relaxants are not routinely recommended. If the bladder is overfilled, we need to ask the woman to empty the bladder. Preparation is done with the antiseptic solutions, and we can delay the amniochorionic separation. If we can delay the amniocentesis, if we find to have amniochorionic separation, because it leads to more chances of dry tap. Like for example, if you're doing at 15 weeks and we see amniochorionic separation till then, we can delay it for 1 week. Now it requires a probe to be placed in a sterile pouch. We can use sterile gel outside, or inside we can use unsterile gel also. The needle size which we use is 20 to 22 gauge. The length is usually 8.9 centimeters. It can be up to 15 centimeters if at all woman is obese, if there is thick metal paniculus. We set it to the location of the target, and if we also require a long needle if we have certain like uterine contractions. For the procedure, we use freehand technique. We identify the clear path of the needle. The needle is inserted while holding the transducer. Once the needle tip is placed inside the amniotic cavity, one can ask the assistant to hold the transducer and can draw the sample. We use the parallel approach or the perpendicular approach. If we use the parallel approach, the entire needle length is seen. If we use the perpendicular approach, we can visualize the tip. Anyways, we have to keep the tip in vision all the time. The movement should be such that we use the movement at the level of the wrist, so that it can easily cross the amniotic. We feel the cross over the uterine muscle and the entering into the amniotic cavity. Sometimes in less than 1% of the cases, we might encounter dry tap, especially if there is amniochorionic separation. The initial sample of the fluid is discarded to avoid metal contamination. And the usual principle is to remove the amount which is equivalent to the gestational age. For example, 16 weeks, we need to have 16 ml. We ensure early transfer from the syringe to the culture tubes. We do not leave the sample in the syringe for long. Now we need to, after the procedure, we need to check the fetal heart rate again and ensure the woman that things are fine. We also have to keep an eye on the immediate complications like uterine cramping, sometimes mild spotting, leakage of the fluid. Usually limitation of the activities or sexual intercourse is usually not necessary. Now, if we talk about the type of fluid which we might encounter, it can include the bloody tap, which is seen in less than 1%, but the maternal blood is usually maternal, and it does not adversely affect the amniocyte growth. And the studies have also found not much association between the bloody fluid and the fetal loss. Sometimes we encounter green and brown colored fluid, which is seen in around 2%. It indicates intraamniotic hemorrhage, which was before the amniocentesis, and this has high chances of fetal miscarriage. Sometimes this colored amniotic fluid actually has a more likely chances of chromosomal abnormality. But to say that we send the fluid for culture and start antibiotics, this has got less evidence. Post-procedure, we can use antibiotics. Now, if we talk in terms of problems, the problem pertaining to fetus could be a direct fetal injury by the needle, which is practically not seen with the trained hands. Sometimes because of the fluid loss, there can be indirect fetal injury in form of pulmonary hyperplasia or kind of a Potter sequence if we have less like a fetal infection, fetal loss for which we are much bothered, but it is less, 0.1 to 0.3%. Leakage of amniotic fluid, which is seen in very few cases, and also it heals in 1 to 7 weeks. And the good thing is whenever we have leak because of amniocentesis, it has got good outcome as compared to spontaneous PPRN. If we talk about presence of viral infections and doing the procedure, yes, there is high chances of transmission. And so individual case has to be individualized depending upon the extent of the viral load and also the window period. And in cases like HIV, we can use a combined card and ensure that the woman is taking card, and we can use a nevirapine tablet 2 to 4 hours before the procedure as well. We can sometimes encounter cell culture failure, which is seen in 0.1%, and sometimes we can encounter 0.1 to 0.2% cases mosaicism, which is further less. It is seen more commonly in CVS. If we talk in terms of maternal problems, there could be chances of rare chances of rupture of membrane, infections, chorioamniotic separation, and very rarely, practically not seen in clinical practice, sepsis. So what affects basically the fetal loss for which we are concerned? There are 4-5 things like operator experience. Yes, in good hands, the loss is very less. The number of times we prick the woman. If we have the indications of amniocentesis, they guide. If already a woman is having high risk, like for example, if the maternal serum alpha fetoprotein is raised or if fetal anomalies are there, they are itself pose the pregnancy to have abortion. And that could be the reason. And we should not blame the amniocentesis because of that. If a woman has history of vaginal bleeding or has had previous abortion, be it spontaneous, induced, they always increase the risk of having any pregnancy loss after amniocentesis as well. Now, previously we used to study that it is 1% when we have a fetal loss after amniocentesis, but the recent guidelines have again proved, and we also see that the loss is actually not much. So now the guideline says it is less than 0.5% if the amniocentesis is done by a skilled operator. Now, if you talk about doing amniocentesis in multi-fetal gestation, we have 2 techniques, a single needle technique or a multi-needle technique. Single needle technique means we insert the needle in one sac, and then after withdrawing the fluid, we pierce the membrane and go to the other sac and take the fluid. But obviously, it has a complication of breaking, intermixing of the fluid and creating a monoamniotic pregnancy. So what the preferred one is multi-needle technique. That is, we take the fluid from one sac and then we take the fluid from the separate sac by a separate needle. So this separate procedure has got a better say, so it is more preferred. Sometimes we can inject a dye just to avoid the confusion, or if the membrane is very clear, we can not avoid the use of dye also. In case of a monochronic pregnancy, if the fetuses are of concurrent growth and there is no evidence of difference in the abnormality, only one sac can also be tested. This is the basic things which I wanted to share for amniocentesis. Thank you.
Fantastic. I think, again, this session has made it possible for us to believe that 5 minutes is enough time for people to squeeze in as much information as you want. And I think what's more important is if you understand the topic very well, if you practice, the number of times these people have actually practiced this presentation and cut short slides. We felt a little ruthless when we were editing the presentations, but I think a wonderful job done. And I'm sure all the seniors here will agree that the short capsules were really a good way to look forward to our academic session. So a big round of applause for all our presenters in this capsule session. Dr. Sahiti, single umbilical artery, Dr. Megha, renal pelvic dilatation, Dr. Namrata, amniocentesis, Dr. Shruti, fetal therapy, and Dr. Soumya, echogenic bowel. Thank you very much. Any last words, Dr. Preeti? Unmute yourself.
Yes, ma'am. Excellent presentation by all the speakers. They really did very well in that short span of time. So thank you, everyone.
So thank you. With 5 capsules, I'm sure your dose of fetal medicine is now updated. I said with 5 capsules, I'm sure our dose is updated for fetal medicine. And now I hand over to Dr. Aarti to take it forward. Thank you so much.
Thank you so much, ma'am. And indeed, it was a wonderful session, very short, but yet very informative. Now we come to finally
the much awaited panel discussion
session for today, which is for the
Dr. Aarti,
yes,
your
can I have the slide of the
you can switch off your video, your connection.
Am I audible, ma'am?
Better, yeah.
So moving on to the last session for today, which is the panel discussion, I invite Dr. Mandakini Pradhan, ma'am. Ma'am is the chairperson in Genetics and Fetal Medicine Committee of FOGSI, professor and of SGIMS Lucknow. She's authored many books. And next is Dr. Vandana Chadda. Ma'am is certified medical geneticist. Ma'am, thank you so much for being with us today, and over to you all to conduct the panel discussion.
Good afternoon, everyone. After that, excellent capsules. All our brains are full of capsules. So let me share my screen. And thank you all, my co-chair. Someone's this thing is switched on. The voice is background voice is coming. If everyone can mute themselves. Yeah. So thank you, Dr. Shanta Kumari ma'am, President, Dr. Madhuri Patel, Secretary General, and all our Vice President, Dr. Bipin, Dr. FOGSI Louis, for guiding us and combining all 3 of us, and definitely proving that 3 brains are better than 1 brain. So we move on to our last session. That's me and Dr. Vandana. Both of us will be doing this healthy fetus panel. So I request my co-chair, Dr. Vandana, to move on to start the session. Dr. Vandana.
Thank you, Dr. Mandakini, and it's a great honor to be co-hosting this panel with you. And moving forward, let's introduce our first panelist, Dr. Raju R. Sahatia. He's been the president of ISPAD, president-elect AFG, executive member MOGS, and so many awards to his credit. And I welcome Dr. Raju. Good afternoon, sir. Our next panelist is the very dynamic Dr. Sita Ramamurthy Pal, and she's currently the consultant fetal medicine at Apollo Hospital in Kolkata. She's also the member of the National Board Specialist Committee, Examiner MRCOG, E-Zone Coordinator, Imaging Science Committee, and so many more accolades. Welcome, Sita. I hope you enjoy the panel with us. Our next panelist is Dr. Manisha Madai Beck, and she's professor and unit head at CMC Vellore. Madam is very dynamic and is currently the head of department for the fetal medicine at that unit. She's trained at Wellington Regional Center for Maternal Fetal Medicine. She's also been the secretary of Vellore Obs-Gynae Society and the president of the Vellore Obs-Gynae Society as of now. And our next panelist is Dr. Smita Dingle. Welcome, Dr. Smita, young dynamic fetal medicine practitioner here, and she's done a fellowship in fetal medicine at the BFMC, and currently she's practicing in Bhopal, where she's at the Bansal Hospital as a consultant. So let's move on to our panel now. the healthy mother and healthy fetus. And what is the aim of this panel? We as obstetricians want to plan a pregnancy. We need to have access to our patients where we have pre-pregnancy clinics where we can give them the correct advice so they have healthy fetuses. We need to screen for possible fetal chromosomal disorders. So we need to touch upon that in this panel. We look for malformations, structural malformations, and we'll also be diagnosing genetic disorders, Mendelian, non-Mendelian genetic disorders. And we should be able to medically and surgically treat our fetuses. So that's the goal of the panel. Next slide, please. So this is our first case. This is a case we saw maybe 10 years back. 36-year-old gravida 3, no live births, 2 abortions, not investigated, referred for an anomaly scan. Incidental anomaly scan. Next slide, please. Dr. Sita, you've seen this patient now, and she's here. What would you like to do? Is Dr. Sita there?
Yeah, very much. Yeah, thank you.
So you've just seen this patient. She's not done her first trimester screen with you. And what would you like to do for her? A quadruple test or something else? NIPT or anomaly scan?
So first of all, congratulations and thank you to all the 3 committee chairpersons, Dr. Mandakini Pradhan, Chinmay and Bela, for this wonderful program, and thank you for giving me this opportunity to share the panel with such esteemed experts here. So this patient has come with previous 2 abortions, not investigated, and even now she's not been investigated so far. So I think initially we will take a brief history as to what her previous 2 abortions were, when it was, how many weeks. But definitely before we send her anywhere for any test, I think now she's come for the scan, take this opportunity and do a detailed scan at 18 weeks. I think we've seen earlier also in all the talks, we can do a detailed anomaly scan and pick up. So look for the viability, of course, if it's still there, because she's had no scans earlier, and then what are the whether it's a singleton, multiples, and then do a detailed scan as to any gross abnormalities, because accordingly we can decide what further action needs to be taken. And if everything is fine, then we can discuss with her. I really wouldn't go into NIPT at all at this stage, whatever it is. But yes, if she still
we agree that we go forward into an anomaly scan, which we did right there.
Yeah.
So in the next slide, we hit upon a couple of things. This is I think the first ARSA that I've seen in my career in around 2013, and thanks to my colleague who had picked it up then. And not just the hypoplastic nasal bone, the ARSA, but we had bilateral pelvic ectasis and certain echogenic foci and some other markers in this case. So Dr. Raju here, would you suggest, would you advise, what is your immediate reaction on getting these findings?
So I would say ultrasound, at the onset, I would like to ditto thank, like how Sita thanked to all the chairpersons, FOGSI chairpersons, Dr. Mandakini and you for making my appearance here today. And like I was saying, that ultrasound has come a long way, and now screening by ultrasound is also one of the most important way, and most patients who have come at this stage of pregnancy, and you see that there is an absent or aplastic nasal bone, and you see an ARSA, I think more than one soft marker like this ultrasound detected invites her to be counseled for invasive prenatal diagnosis, because this is what the guidelines are referring to, and indication for invasive prenatal diagnosis is very clear. And if it is a single marker, you could have taken the likelihood ratio like it is shown here for ARSA 3.94 and for absent or hypoplastic nasal bone 6.58. But more than one, and also a patient who has had a previous pregnancy losses, and she's come late without doing any tests, without any reports. I think invasive prenatal diagnostic technique rather than screening one after the other test, it will be better.
Okay, so Dr. Smita, would you want to follow some mathematical model if you have multiple markers with using your priori risks, or you just would blindly do invasive for everybody?
No, it's not like invasive for everybody. If I come across some soft markers in second trimester, yes, I would like to know the likelihood ratio for that particular marker. because we have second trimester markers like absent nasal bone or hypoplastic nasal bone, ARSA, then pelvic tests, echogenic bowel, ventriculomegaly, and we have put positive and negative likelihood ratios for these markers. So especially if we are coming across two markers, then definitely the risk for aneuploidy, it goes high. And with these markers, we need to see whatever marker is there, what is the positive likelihood ratio for that, and it is those markers positive likelihood ratio is multiplied, and the consideration of negative likelihood ratio is also to be taken. So this is how the mathematical calculation goes. But if somebody is using a software like Astria or the other one standard softwares, then we can just put in these markers, and then that software will calculate us the risk and give us what is the background risk and what is the risk coming for that particular fetus.
Fine.
Based on that, then we can plan our invasive testing. But yes, absent nasal bone or a hypoplastic and ARSA, they are very strong markers, strong soft markers, I would say. So yes, amniocentesis is justified in this case.
So they really jump up your risk, right?
Yes.
So we did amniocentesis, we did find trisomy 21 here, and the couple opted for termination. So with the previous two losses and this one being a trisomy 21, now she's come back to you 6 months after, as they want to plan a pregnancy. As a what investigations would you like to do now, preconception?
I would consider 2 points over here. It's a couple who has had recurrent miscarriages and then one pregnancy with trisomy 21, since it's proven now. I would see what kind of trisomy 21 is that. Is it a free trisomy or any translocation kind of a thing? So my investigation line would go for genetic as well as non-genetic causes. I would plan investigation to look up to their APLA, ANA, and beta-2 glycoprotein, considering the recurrent miscarriages risk. Then I would go for their CBC and HB electrophoresis also, considering the recurrent miscarriage risk. Then the kind of T21, trisomy 21, this result is there. I would investigate the couple also for their karyotype, so that I get to know whether it was a free trisomy or the parents are carrier for some kind of chromosomal issues.
Right. So with a lot of societies advising us to go for a full workup even after 2 abortions now, I agree with you that we'd like to do a good workup for this couple and also do the karyotyping. So the karyotyping has shown us a surprising result here. Dr. Manisha can jump in now and let me know if you're getting this result of a Robertsonian translocation 21-21, how would you prognosticate for the couple and what would be your plan here?
A warm good afternoon to all here. Thank you so much for allowing me to be a part of this panel discussion. So as we have come to know now, this couple who have had previous 2 miscarriages and now one termination of pregnancy because of trisomy 21, because of Down syndrome, we find out that one of the parents is a carrier of Robertsonian translocation 21 and 21. Now we know that Robertsonian translocations are a special type of translocations that happen in a certain group of chromosomes, the acrocentric chromosomes, and most common being chromosome 14 and 21. So if it is between 21 and 21, there is a risk that all subsequent pregnancies are likely to be affected with Down syndrome. So in this case, we would like to actually sit with the couple and talk to them about this finding and tell them that probably they need to undergo an ART. If it is a translocation involving any other acrocentric chromosome, for example, 14, 21, 13, 14, or any other thing, then the risk in the subsequent pregnancy depends upon who is the carrier of translocation. If the mother is the carrier of translocation, then the risk of recurrence is somewhere between 10 to 15%. If the father is a carrier of translocation, then the risk is somewhere between 2 to 5%. So overall, a 5 to 10% risk is what we tell them. But in her case, unfortunately, because it is 21 and 21, it's a 100% risk in each pregnancy.
Right. So she probably can go for a give me change. Correct. So moving on to our next case, which is also another important topic of hemoglobinopathies, and we have a huge burden of that in our country. So this particular case, you can see this lady has had a previous child who died at 3 years of age, and we don't know the possible diagnosis. And she is currently 10 weeks pregnant. That child had a history of anemia since 6 months of age and also had repeated blood transfusion. There's a vague history, but there's no final diagnosis here. And what do you do as a Dr. Smita? Please, can you tell me, as an obstetrician, does it strike any bells for you if you see this kind of history, or you feel that this is not your sort of field or liability, that you should be looking at a pediatric history in so much detail?
No, our role is a very paramount role over here with such kind of a history. That if they are saying that the child had anemia right from age of 6 months, and then the baby required repeated transfusion, it does strike a bell for hemoglobinopathy screening. Now the child is not there, but then I suspect that the child was having maybe thalassemia or thalassemia with some other combination of sickle cell or something. So but unfortunately, I don't have the sample for this child. So I need to work up the parents, or at least start with the mother's investigations first of all, and a strong family history, like mother's side as well as the father's side, if some other children had been suffering or their siblings have been suffering such kind of a issue of anemia.
Right. So you checked the mother, and we found that the mother is anemic. Her
Yes.
MCV and MCH are low. The MCV here is 62.
62.
And also done in HPLC, and your HbA2 is above 3.5. Yeah, it's 4.6 there. So what is your next step? Would you like to check the husband for something, or?
Yes, I mean this report is speaking itself now. The hemoglobin is less. If I had only just the hemoglobin less with MCV 62, then also I would have thought that why this MCV is low, and HbA2 now 4.6 is speaking that yes, she is a thalassemic.
What cutoffs for MCV and MCH you?
Yes, I follow a golden rule. Whenever I see a CBC report, I would always say that read in between the lines for that CBC report, because everybody sees the hemoglobin and skips down to the lower part of the report. We should always go for MCV and MCH. So 75-25 is the golden rule that I always follow, and I tell everybody that you see the hemoglobin and just keep reminding in your mind 75-25. Is the MCV more than 75 or not, and MCH 25 or less, then it should strike a bell. It's a differential diagnosis for iron deficiency anemia, but yes, if you see such kind of a report, please get HbA2 also done.
Okay,
if
so
A2 is 3.5 cutoff that we are keeping, definitely we are going to pick up more of thalassemics, which is very much prevalent in our country.
So we've tested the husband here. We have tested the husband here. I think Dr. Mandakini can show us the report of the husband, maybe. That's the report of the husband. It's 6.1.
So husband is also a thalassemia trait now. Yeah. So, I mean, now retrospectively, we can say that the child who is no more was thalassemia major, because both the parents are carriers over here.
Right. So we've got both parents who are thalassemia carrier by the hemoglobin RBC indices here. Now, what is the risk to the fetus now that you are looking at? What kind of risk do you see in the fetus, Dr. Sita?
Yeah, before we go to this, another very simple thing of, when Dr. Smita was talking about the red cell indices, what we commonly say is before getting even the HPLC, we can look at the Menzel's index and, divide the MCV and RBC. And if that's more than less than 13, then that would be thalassemia. And now in this particular case, clearly the mother and father are a thalassemia trait, which is an autosomal recessive condition. So there is a 25% chance that, the fetus would be affected with a thalassemia major. So that is why they would need prenatal counseling and intervention to find out if the pregnancy is affected or not, if the fetus is affected or not. So in this particular case where the HbA2 is more than 3-4% in both the husband and wife, they're clearly carriers, and one baby has been affected, as we would assume, though we don't have the reports. And this pregnancy is also a chance of infection. So we need to investigate and see.
So moving on forward. We've counseled this couple. We have told them that this is an autosomal recessive condition, as Dr. Sita has just mentioned. We know that there's a 25% chance that there'll be a fetus affected with thalassemia major who will need a transfusion. So what sort of prenatal diagnoses, testing, Dr. Sita, would you be offering this couple? What would you do at the moment?
We'll do, if we are at 12 weeks, that would be the best time. We can do a chorionic villus sampling to get to look for any problem in the fetus. But at the same time, we also need to check the parents for to find out the exact mutation in the couple, to know exactly what mutation is affecting the fetus. So when we collect the CVS sample, very clearly we also would check for the couple sample, and also look for any maternal cell contamination also.
You've taken out the CVS sample, you've taken out the 2 ml blood in the EDTA vial of the couple for the mutations. Dr. Raju, can you enumerate for us all of the tests that you've sent, and what is the test that you are expecting to, what is the test you've ordered to the lab?
Before I answer this, I would like to make a point. Because of the resources in our country, keeping them in mind, even when you do a good CBC, if you have MCV and MCH cutoff, which you mentioned, and they are very low, the bell should ring when the MCHC is normal and all these are low. When MCHC remain normal, it is a big indicator that there is a good likelihood that the hemoglobin electrophoresis is going to come abnormal. So should not ignore when you get a hypochromic and a hypocytic hypochromic anemia picture. In such a situation, if MCHC is also abnormal, then it is iron deficiency, B12 folic acid deficiency. But if MCHC is normal, then it is in great favor of this thalassemia trait. And then if you are going to do hemoglobin electrophoresis, most of the cases you will find them above 3.5 and a diagnosis will be made. Talking about along with CVS, what else is to be done? It is very important. We easily think about invasive technique. We take chorionic villi and we want to send the lab and we want them to give the results. No, it's not so. We should understand that there are more than 545 beta globulin mutations there. So we have to find what is going to match with this couple. And there are only 5 common Indian mutations which we have to look for. If we know this, then it is very, very important to test the couple. We have to take an EDTA bulb, send and identify the mutation in both the father and the mother of the fetus. That means the couple. And you have to hunt for the common mutation. Once you identify the mutation, only and only then you are justified to do a chorionic villus sampling, amniocentesis, send the material and see whether both mutations are present in this product of conception of the unborn or it is just one. If both are present, then there is a problem and it could be thalassemia major. But if one mutation is present and the other is not present, then it is possible that this fetus is going to be normal, or secondly, it could be only thalassemia minor but not major. So it is so very important to do the mutation, then do the invasive technique, then have the tissue, and then expect a good report.
Right. So we've burnt our fingers where we have gone in and done prenatal diagnosis and then realized that the HPLC report was wrong and one of the parents was not even carrier. So ideally, the point is very well taken. Dr. Raju has made the point very clear that you should have the mutation testing of the parents in hand. Only then you should subject the fetus to a potentially procedure where there is a mortality involved. And that's very important. For that, you have to have the correct timeline and the testing has to be done at the appropriate time. So you are correctly taking all the decisions. Dr. Manisha, can you tell me now you have sent the CVS sample along with the blood of the parents. We have to move in this practical situation. We didn't have time for some reason. We did all the 3 together. Now they have identified the mutation in the mother, I think. This is the tricky part here, but they have not identified the mutation in the husband, the father of the fetus. So
vice versa. They have identified in the husband and not in the mother.
Okay, so one of the parents, they have identified the mutation and the other one they have not, which can happen. So what is your next step?
Yeah. So in this case, as Dr. Raju just pointed out, there are so many mutations that can lead to this kind of a scenario. So what the next step would be to look for to do the sequencing of the entire beta globin gene and then to look for the mutations. And then once we identify the mutation, then the specific thing can be looked for in the fetal sample.
Yeah, so the first part of the question was the mutation is not identified in one of the parents, you have to sequence it. The next question is the mother's mutation is not found in the fetus. Father's mutation is found in the fetus. So do you think, Dr. Manisha, that the fetus is minor or it is major? Only one parent's mutation is found in the fetus. The other parent's mutation is not found.
Yeah. So in this situation, when this mother's mutation is not found in the fetal sample, then most likely either the fetus is a thalassemia trait or it might be normal also. So they can continue the pregnancy. The chance of being major is not here because one of the mutations is not found.
Right. So even if you don't find mutation of one of the parents, but the fetus is not carrying the mutation of the parent whose mutation you found, then the fetus is either trait or not affected. So you can still continue the pregnancy. Mostly we will find the mutations if after sequencing, but very rarely if the mutation is not on the beta globin gene and it's somewhere in the promoter region or elsewhere, then you may not find it. That's very rare to happen. Mostly we do find it after the sequencing. So we have to manage, if the baby is born thalassemia major baby, it's a lot of headache in terms of, to the family, it's a big burden. There is lifelong blood transfusions. Every 3 weeks, chelation therapy has to be given. There is all the complications associated with iron overload and transfusions. So we as obstetricians, as antenatal care providers, it's our ethical, moral responsibility that we have to make our country a thalassemia-free India, just as so many Mediterranean countries have done. It's quite possible, it's quite doable, and we should be making this pledge on this day to day as the Fetus Healthy Fetus Day panel, that we'll be striving to do that. So we move on to the next case. Dr. Mandakini, would you want to start?
Yeah, nice going on. So moving on to the next case, this is a 32-year-old, second gravida, previous one normal delivery, normal baby. She's GDM, controlled on diet. She had an TIFA scan at 20 weeks, which is found to be normal. Presented at 29 weeks. The resident present in the antenatal clinic felt that the fetal heart rate is very high. So she thought that let's do an ultrasound. She couldn't count it. So hence she has gone for an ultrasound. So now the ultrasound shows this. So Dr. Manisha, can you take it up? What are we seeing in this ultrasound?
Okay.
Yes.
So in this ultrasound, we can see the transverse axial view of the fetal thorax with the 4-chamber view and the things of the heart. And what we find out here is the fetal heart rate is very high. So the fetal heart rate, and on the other side, you have the pulse Doppler of the M wave, and that shows the conduction pattern between the atrial contraction and the ventricle contraction. And as you can see that this is the fetal heart rate calculation, and that tells you that it's around 270 beats per minute.
Yeah.
So so the fetal heart rate is around 270 beats per minute. Then when you put on the pulsed wave Doppler on the M mode, you can see there is a one-on-one conduction. So this is basically showing that there is a tachyarrhythmia, most likely to be a supraventricular tachycardia because of the one-in-one conduction, and the heart rate in the region of 270 beats per minute, 200 to 260 to 80 beats per minute. So
yeah.
Yes, ma'am.
What else you would like to see? You are doing.
Okay. Yes. Okay. So while we are still doing the ultrasound, we would also like to make sure that the heart is structurally normal. There are no structural abnormalities in the heart, that there is no hydrops in the baby. And we would like to rule out the hydrops in the baby. Of course, we have calculated the fetal heart rate. On the M mode, we found out the conduction pattern to make sure there is no block, which would go more in favor of an atrial flutter. So these are the things that we would like to look at. You also look at the growth of the baby, make sure there are no other additional abnormalities of the baby.
Okay. So how do you manage this case? This is your case. Now you have found out 273 fetal heart, structurally normal, no other malformation.
Okay. So in this case, we have found out now so gestational age is important here. So we see that the fetus is only 29 weeks. And we also find out that the fetal heart rate is very high. There is no evidence of hydrops. The heart looks structurally all right. So one thing here would be to see how most of the times it is transient, but sometimes it may be sustained. So if this is sustained SVT, then we need to give the therapy. And this transplacental therapy, the main aim of this is to slow the fetal heart rate, to improve the conduction, and to prevent the onset of hydrops. So the transplacental therapy, there are many agents that have been used. The standard teaching is digoxin is the first line agent that is used. And if it doesn't settle with digoxin, then you use second line agents like flecainide, sotalol, and those other ones. Digoxin is used as a first line agent primarily because it is found to be safe for the mother, because all these drugs that we are going to give is going to have an impact on the mother as well. So with the digoxin, the maternal side effect profile is relatively lower. So that is used as the first line agent. But with digoxin, what happens is sometimes it is not controlled, and you might need to add on another agents, antiarrhythmic agents like flecainide or sotalol. So those are the things that we need to add.
Oh, yes. So does your management differs if it is fetal hydrops, non-hydropic baby with a supraventricular tachycardia? This fetus was non-hydropic.
Yeah, so in this case, our fetus was not hydrops. We started digoxin. If the fetus is hydropic, then I would actually like to use flecainide or sotalol as the drugs, because, or if you are using digoxin, most of the times you would have to add on the second line drug. There has been a meta-analysis of 21 studies that looked at all the transplacental therapy for fetal tachyarrhythmias, and they found out that the effect of sotalol and flecainide was much better than digoxin, especially when the fetus was hydropic. So I would say if the fetus is hydropic, then the first line agent should be actually flecainide or sotalol rather than this thing. And the success rate, as you is more than 90%.
Yes.
If it is still not settling, then for refractory thing, we have amiodarone as an alternative, madam, which can be used for refractory SVTs.
So for everyone to see this, the same patient who had a heart rate, what you saw previously, the same heart rate after treatment became like this only with digoxin. This was a non-hydropic baby. And would you like to deliver this baby at your center, at a special center, at a peripheral hospital?
No, definitely this baby should be delivering at a higher center where they have a proper NICU setup and a pediatric unit. And if a pediatric cardiologist is there, you cannot ask for anything more than that. And one more thing, before we start for all these drugs, we need to have a cardiology opinion for the mother as well and a baseline ECG, and then we start with all these drugs.
That's an ideal situation. Many of us, when we are practicing, we do not have access to all these things, and then sometimes the guidelines or the follow, we deviate as per the practical case-to-case basis and the place-to-place basis. So sometimes we need to know what is a disadvantage of giving digoxin to a mother. Say, for example, hypokalemia, or you need to have a baseline ECG of the mother. So every time we can't do a digoxin level, serum digoxin level, that is an ideal situation. But sometimes, like the serum digoxin level is not always available. So, but still, this is a condition which is treatable, and everybody should be aware about that. This is the outcome of such babies are very, very good in such cases. So Dr. Sita, can you enumerate other causes other conditions where we do transplacental therapy as we did in this patient, giving a digoxin to the mother, reaching onto the fetus and correcting the fetal heart rate?
Yeah, so as we've just heard in the previous talks, in terms of fetal goiters, when there is a suspect fetal hypo or hyperthyroidism, we can give transamniotic therapy. If it's hypothyroidism, then the goiter, because of hypothyroidism, we can give thyroxine, and that will it will reduce the goiter. And other ones are indomethacin, but not routinely practiced. And of course, that won't be transplacental. Steroids would be and Naxal for neuroprotection for the mother, prophylactically for preventing complications in the fetus.
Yeah, we do practice steroid, every one of us.
Yeah, that is one of the best recommended.
Yeah. That's we need to start practicing magnesium sulfate. If we are not doing for preterm babies, very right that idiopathic polyhydramnios, very rarely we may need to go on to indomethacin. But then fetal hyperthyroidism is another condition where we may practice transabdominal therapy. So moving on to the next case, where we see an anomaly at 18 weeks. This is a third gravida previous to abortion, presents to refer to you, Dr. Smita, at 30 weeks. And she never had any serum screening, presents at 30 weeks. And what you saw is this amount of polyhydramnios. We were talking about giving indomethacin to an idiopathic polyhydramnios. But here it is this ultrasound which shows a double bubble. And we saw very beautiful picture in this double bubble with this thing in earlier talks. So in addition to this double bubble, she has got an absent nasal bone. Since morning, we are listening to this. So how will you approach this case? Dr. Smita?
Yes, please. See, I see a double bubble and a strong marker of absent nasal bone in a lady who has not done any kind of screening before. My suspicion for aneuploidy is very high for this one, because double bubble is also seen in trisomy 21. Absent nasal bone is a strong marker for that. And I don't have any evidence to say that her chromosomes are, the baby's chromosomes are all normal. So my suspicion is highly for aneuploidy in this fetus.
Okay, so
I need to see more structural abnormalities, because once abnormality I see, I need to have other structures also evaluated very thoroughly.
So Dr. Smita, will you be doing an amniocentesis at 30 weeks or a chordocentesis at 30 weeks to evaluate fetal chromosomal abnormality?
Yes, it is a very tricky gestation age now, that 30 weeks, we are exactly, I mean, very much nearing towards our expected date of delivery. But yes, definitely, I would like to know the chromosomes of this baby before the baby is born. So I will discuss with the parents that the aneuploidy is one of the reasons which I need to know, and other structural abnormalities with a good scan that I would like to rule out. So,
Dr. Raju, in your book, you mentioned so many causes. So you are the best person to tell us what are the differential diagnosis of this double bubble.
See, when you see this double bubble, you should always keep in mind the duplication of the foregut, because that mimics and you may diagnose as double bubble. But otherwise, diagnosis like duodenal atresia, duodenal stenosis, and many times there is an annular pancreas which may constrict and make it appear like an hourglass or double bubble. So this is very, very important, and associated cardiac, vertebral, so many other anomalies have to be kept in mind. It is just incidental. Yesterday we had one patient, a patient who was conceived with IUI, and she came with her 26-week report, which we had given for a second relook anomaly scan. And the abdominal circumference for 26, 27 weeks showed 31 weeks. Okay. So abdomen was, diameter had increased. And what we saw there in the small gut, we saw a lot of fluid there distending the jejunum part. And we got little panic, like, you know, when it comes to own patient and things happen like this. So we started calling up so many pediatric surgeons. What is to be done? What is to be done? Have we to remove this baby? Is this volulus? Is it intussusception? So, you know, the good tips which we received from this pediatric surgeons, they said, just wait and watch. Don't panic. You must see signs of mesenteric ischemia. If there is ascites or the jejunum loop, which was 28 mm diameter, whether it is growing. Many times these things resolve, in my case, like what they said, and you should keep a watch, should not hurry up, start steroids on her. You don't know when it will become critical and you'll have to remove this baby. And this has happened just yesterday. So these problems which come up, the GI anomaly, we have to look at it seriously, but also we shouldn't overreact to them.
Yeah, very right, Dr. Raju. We should not overreact and straight away terminate such pregnancy. No, our message is we should not straight away terminate this pregnancy. No, what is the risk of genetic abnormality in such fetus? Dr. Smita says she would like to do a amnio or a chordocentesis. So definitely the risk of having chromosomal abnormality is high, and hence she wants to do this thing. And if you see a double bubble, say the risk of having trisomy 21 is as high as 20 to 30%.
Yes.
So, yeah, Dr. Manisha, what are the role of prenatal diagnosis at this gestation? Dr. Smita says she will do. Why should we do at all? That can be done at delivery also. The patient can argue for that. Yeah. Dr. Manisha?
You need to unmute.
So the role of prenatal diagnosis in such a situation, even if the gestational age is 30 weeks, is to first of all know what is the cause for this. And whether it is an aneuploidy or a trisomy 21 that the baby is having, because of which this is associated finding, because that changes the prognosis the whole lot. Then second thing is whether because of the polyhydramnios, there is a risk of PPH in this baby, there's a risk of preterm labor, there's a risk of PPROM and all those things. Then the parents need to be aware of the fact that there is an underlying chromosomal abnormality, or whether there is no underlying chromosomal abnormality, which will change which will in a way help them to prepare better for the delivery of the baby and for the surgical inputs that will be required later on. And at the same time, if once we have made a diagnosis, then it also helps the neonates, the neonatal team to be aware of such a baby and the immediate neonatal management that is required. And of course, in the next pregnancy, if this baby is having trisomy 21, then it will have a bearing in the next pregnancy in terms of recurrence risk. So if it is usually trisomy 21, then the recurrence risk is less than 1%.
Yeah, now you have done it. And this fetus, this particular fetus showed chromosome trisomy 21. Now the gestational age is 32 weeks. There is maternal distress due to polyhydramnios. So Dr. Sita, how do you take it up now?
Yeah, so as Dr. Manisha rightly said, the invasive testing is being done to find out the cause and to prepare the couple and the family as to what they're expecting, and even before the baby is born, or whatever they decide to do. A lot of these women, polyhydramnios, they end up in preterm labor in the middle of the night, and so the whole team is prepared to handle such cases. Well, here, especially because she's already 32 weeks, we don't need to do the entire, we're suspecting a high risk of trisomy 21 here. So just FISH to target the 21 chromosomes, and you've said that it is trisomy 21, right? At 32 weeks, it's a very difficult, situation to actually whether to terminate or not, because they're already nearly there, and it is just going to, it's very traumatic for the entire couple to terminate. And then
we also maternal distress.
And the other bit of looking at it is, yes, Down's baby is there, but it's the whole perspective is how the parents look at it. So it has to be an informed counseling and decision making. And of course, if the patient is distressed with the polyhydramnios, there is a role of amnioreduction here. But again, explaining the risks of amnioreduction at this stage, that it can cause preterm labor, PPROM, abruption, as well as a small chance of infection. But yes, important to tell them that there is a problem here and then go by what they decide. But I really wouldn't be pushing towards terminating here. But of course, it's the patient's choice here. And yes, as you've asked, delivery, so obstetric indications to basically, I would like to continue and monitor this pregnancy, and be, as I said, have a pediatric surgical team also be aware that there is a patient on board here like this who can come, and they'll definitely deliver in a center where there is enough neonatal backup and pediatric surgeon available. And if, as you've said, most of we've had cases where there is isolated defects and the prognosis is really good. So that is important, in positive counseling them and deliver at a center where the whole team is prepared and handle these cases. Because if it is isolated and it's repaired, then the outcome is really very good, more than 90% in most of these cases.
So seeing malformation doesn't mean termination. Seeing malformation means further evaluation. And if isolated, there are malformations which are surgically correctable. As high as 95% of duodenal atresia will be correctable. So rule out chromosomal abnormality.
With your permission, can I make a point? See, termination question doesn't arise because you're not even allowed to terminate a pregnancy on these grounds. If at all, there should be an obstetric indication. Then only you have to decide. Otherwise, whatever is the situation, you have to deliver such baby. You're not allowed by the law to terminate on these grounds.
Yeah, that's true. But then what I was telling was, if it is before 24 weeks, even then, it needs a lot of counseling and then explaining that such isolated cases can be correctable in more than 95% of cases. So you need to have that knowledge and then explaining the couple. So moving on to the last case and the most distressing case for me, because we get to see such patients arriving, at least 6 of them admitted in my ward, and some 18 of them are on follow more than 30 weeks gestation. That is, say for example, third gravida, previous to LSCS, 26 weeks with fetal high drops. Dr. Manisha, can you take it up? Previous to LSCS, fetal death, previous fetal death at 32 weeks. She is of course RH negative, and she had received anti-D in both her pregnancy. So straight away going on to, let us not deviate into it and save some time. So what investigation will cleanse the possible diagnosis in this case?
So in this case, doing an indirect Coombs test will be helpful, madam. Most likely this is a case of RH isoimmunization. Indirect Coombs test will be positive most of the times. What we need to know is the exact titer of the antibody, how much it is. If the baby is hydropic, most likely with the titers will be more than 1 in 256, here 1 or 1 in 512. Yeah.
Yeah. So, so this patient had titer of 1 in 512. How do you manage this case?
The baby already has high drops, right?
Yeah, baby already have high drops. So on the day of, you are doing ultrasound. So now you are, Dr. Sita, you are going to do an ultrasound. This patient has presented to you in your OPD. So with this history, with this report from outside, so what do you do? Unmute yourself. Yeah.
Sorry about that. Yeah. So if the baby has high drops, and we know that in terms of RH incompatibility, this baby is hemolyzing, and we're expecting the hemoglobin to be really low. So of course we need to see what is the state of the baby now, and the MCA PSP Dopplers would be definitely high. The baby has got high drops now, and we are planning treatment here, because though there is high drops, there is a possibility of bad outcome. There is still chances of a good outcome if we intervene now rather than wait, because if we wait, then it's going to be a stillbirth really. So we have to counsel them and say that the only chance for the baby is to have an intrauterine transfusion, and there are very good results with it. Of course, with high drops, the success rate slightly reduces, but even then there is a chance. In fact, recently we've had a case with fetal high drops where the baby just delivered a couple of weeks ago, where it was gross high drops, despite a similar case where the mother had a previous section, had anti-D, and just came and had no screening in the previous trimester, in the previous part of the pregnancy, just came in when the baby had high drops. So there is hope for these women when we transfer with O-negative blood. Of course, it has to be done in a center where you can get fresh O-negative cross-match irradiated, screened and depleted, where the hematocrit will be 85. And then depending on what you get, the hematocrit of the baby, we decide on how much volume needs to be transfused and how regular.
So all your system gets geared up for this.
Yes, absolutely.
But Dr. Smita, if you get otherwise isoimmunized pregnancy, how do you monitor? She is yet to develop high drops. Do you wait till high drops develops, or you start monitoring?
No, we start monitoring them right from beginning. Suppose if such kind of incidences happened, then after 18 weeks, we start monitoring them in a very good non-invasive method by ultrasound only. We monitor their middle cerebral artery peak systolic velocity. We call it as MCA PSV. And we really need to have a good training to record this middle cerebral artery PSV. If I tell you the way to do it, it's like in the BPD section, biparietal diameter section that we take. In that image only, we have to magnify it enough. And then we need to identify the lesser wing of the sphenoid bone. The thalami, which we see, just lateral to it, you can nicely see the lesser wing of sphenoid. Just put the color box onto it, and then you will see the circle of Willis. Here, very near to its origin only, you have to put the Doppler gate completely covering the middle cerebral artery. The Doppler gate should completely cover it, and the angle measurement also we should do. And then we put the measurement. So this is how we get the waveforms. It has to be minimum of 3 waveforms, but less than 10. That is very important. And one more important thing, not to put a lot of pressure on the probe, because see, the fetus is already moving, the mother's breathing movements are also there. So we need to have less of these artifacts into it. The probe pressure should also be as minimum as possible. And then we do the measurement of the middle cerebral artery and the peak systolic velocity. If we do an auto trace, we get all the values. And then we need to see the PSV has to be less than 1.5 multiples of median. So a good way to see is either we go by the charts for the gestation age specific thing, or just it has to be less than double that of the gestation age. So suppose if she is 20 weeks, the PSV has to be less than 40, 22 is a 40. So it has to be less than 40. So a rough idea on the screen, only seeing the PSV value, we can make it up. So every 2 weeks, we are going to see this lady for a middle cerebral artery PSV, and this is the way we will be monitoring a isoimmunized pregnancy.
Yeah, great. So you are looking into this MCA PSB. Probably everyone who does an ultrasound should know how to measure it, and Dr. Smitha nicely told this. And how to go about, either you use perinatal.com software, or otherwise you can refer to this chart which says 1 MOM, 1.29 MOM or 1.5 MOM. And it roughly is twice the gestational age, say 20 weeks 40, 26 weeks 52, so more than 52, then that is an indication for going ahead and doing a fetal transfusion. Or else you see the features of hydrops, and they almost everybody knows skin edema, pericardial effusion, pleural effusion, ascites, or if it is more. So let's not go on to this media which says that how to do an intrauterine transfusion, but everybody should know that if it is high or more than 1.5 ml, it needs transfusion, and the patient should be shifted to a center where it is done. So what are the chances of success? Dr. Raju, can you enumerate us?
Yeah, that like
hydropic baby, non-hydropic baby.
Yes, the way you mentioned, if there are hydropic changes, then the success rate is like shown just 60 to 70%. But if it is non-hydropic, very good prognosis, and they do very well with transfusion, and outcome is very good.
Oh yes, great. So we always, any person who is doing intrauterine transfusion would love to have a non-hydropic baby rather than having a hydropic baby. So what do you learn? We learn that if obstetric history is suggestive, then start monitoring your MCA PSV. And when to start is around, say, 10 weeks before the previous affection, you start doing your MCA PSV. And if it is fetal hydrops, then you must treat it. It is not an indication for, again, I'm emphasizing that it is not an indication for termination, because 60 to 70% of such babies also can be saved. Dr. Sita already told you this. So, Dr. Manisha, can you highlight if this woman had received anti-D in both her previous pregnancy? So still woman, she is isoimmunized and has presented with us with hydrops. Can a woman get isoimmunized even after receiving anti-D in all her previous pregnancies?
Yes, madam. So that is So this is a possibility that even if she has received anti-D, this is a possibility. Sometimes if it is the site of injection, if it is given in the gluteus maximus, then absorption might be erratic. Or if the cold chain is not properly maintained, then probably it loses its efficacy. Then of course we have that thing about monoclonal and polyclonal. Polyclonal is supposed to be the better of the two. Now, with respect to the history, if you look back at the history, there was one baby, the second baby had actually died. So probably the dose of anti-D that was given was not adequate to cover the entire feto-maternal hemorrhage that could have happened at that time. So we know that 300 micrograms of anti-D is going to neutralize 30 ml of fetal whole blood or 15 ml of fetal RBCs. But if we are suspecting in certain cases like IUD or abruption or all these cases, or if we have done a manual removal of placenta, then this 300 microgram is not going to be enough to neutralize the feto-maternal hemorrhage. So in that case, we need to calculate the dose of the amount of feto-maternal hemorrhage, and we have to give the anti-D accordingly. So we do the Clay-Hauer-Betke test, find out the percentage of fetal cells in the maternal circulation, multiply it by 50, that will give you the amount of feto-maternal hemorrhage in ml. And then you divide it by 30, that will give you the number of vials of anti-D you require. You round it up to the nearest whole figure and you give off that. In a 24-hour thing, you cannot give more than 1500 micrograms. So that is 5 doses of 300 microgram. More than that, you cannot give IM.
Yeah. So, but then simultaneously everywhere this clear bed case is not available, practically not doable. So, if there is abruptio with fetal death, then that itself shows that the feto-maternal hemorrhage is more. And in that case, the suggestion is that you give 2 doses of 300 microgram anti-D to such women. So we see that prevention is better than cure. All of us know that. We started screening for Down syndrome chromosomal abnormality. We then went on to screen for thalassemia. We must not forget. Our aim is thalassemia-free India. Then we went on to detecting malformation that can be surgically correctable. That is, our example was double bubble. Then there are certain conditions where fetus can be treated through transplacental route, and the best example is supraventricular tachycardia. Then we went on to treat the fetus invasively, like intrauterine transfusion is the best example of invasive fetal therapy. So I thank all this baby coming up crying. So every day should be a fetus day, and we should not discuss. We should go and start practicing, and to have this practice. And I thank you all my panelists, my co-moderator Dr. Vandana, and all the attendees, my co-presenter that is Dr. Chinmay and Dr. Bela, and FOGSI itself for making this. As this is the first time that FOGSI is celebrating Fetus Day. Anecdotal celebration was there every year. Like last to last year, we used to celebrate in Lucknow. There are Raipur Society used to celebrate. There are Hyderabad Society used to celebrate. But then this is for the first time FOGSI is celebrating Fetus Day. So let's hope that in future we will have more of it, and then more of occasions to do this. So I stop sharing my screen. Thank all of you for this nice webinar. Yeah, Dr. Raju wants to.
I must thank the President, Dr. Shanta Kumari, and I sincerely thank the conveners, and plus above all the moderators for putting up such a beautiful panel and covering up in the specified time of 1 hour all important practical cases. Thank you, Dr. Mandakini, Dr. Vandana, and all the panelists who are there with me. And on behalf of all of them, thank you once again.
Yes, on a wonderful spectrum, across the spectrum, you've covered all the cases. So thank you, Madam, and Dr. Vandana.
Thank you, each and everyone, both the moderators as well as Dr. Mandakini, Dr. Vandana, all the panelists, esteemed panelists, for staying for so long. Even post-lunch session, you are there. We are supposed to be starting.
There was no lunch.
Yeah. Extremely thankful to all of you all. Of course, thanks to both the co-conveners, Dr. Mandakini and Dr. Chinmay, for having this session possible, entire webinar possible. Thanks to Shanta Kumari ma'am, President FOGSI, who gave us opportunity. And thanks to
Dr. Bella, this is the first time that we are celebrating, and hope that it continues. Every year we celebrate, and then world will know that this is FOGSI Fetal Day. Exactly. So this will go across.
This is a nice start that all three committees are together and we are doing FOGSI Fetus Day. So yes, indeed, it's a nice thing. So thanks to all office bearers and the VP in charge, Dr. Bipin Pandit and Dr. Cassie Lewis, and all the eminent faculties right from beginning in the morning, 9:30 till 3 o'clock, 3:15 now, for giving valuable time and valuable inputs for all of us and for all the delegates who joined. Thanks to all the delegates for being with us for so many hours. And of course,
the academic partner.
Yes, academic partner, Mayor, as well as the conference manager, Niti. So thank you so much, each and everyone. Without you all.
Venkatesh and Tirupati.
Yes. Yes, Tirupati and Venkatesh. Yes, Dr. Chinmay and Dr. Mandakini, you want to say something?
Oh, I think you've said it all, and it was a really satisfying experience. I think the coming together of the three committees has been a very, very positive move, because instead of duplicating the same academics here and there, we got together. And like Mandakini madam said very clearly, 3 brains are better than 1. And so despite all the
Congrats to all of us all.
Absolutely. I mean,
of course.
it was a lot of fun, and I think that's the way forward when we work in associations. I think working together is what makes it all very
teamwork is always good. Yes.
It's a lot of fun, very satisfying, and I was very, very personally happy about that young brigade which did that capsules, because that was something we look forward to. Otherwise, it's either free papers.
I'm very, very happy with my panel, what it went. Even all the lectures and everything.
Lectures were very nice. So we had a balance of, youngsters, seniors, stalwarts, everything put together. And really, thank you very much, everybody, for coming through. The fetus has had its due today. So thank you very much to the President FOGSI for allocating a whole day to the fetus. And that's a very, very important statement to make. And all our experts, Dr. Neelam has been there from the beginning. And that's how fetal medicine people are. So Dr. Neelam, do you want to? You were the first person to start, and I think I saw Dr. Mumtaz also. So both of you were the first people to start the sessions. Is there anything you want to say by the time it's finished?
Also, thanks to all MOCs for being there from beginning till end. Thank you so much, each and everyone.
Dr. Neelam was saying something. Dr. Neelam?
I said the pleasure was all ours, ma'am.
Thank you, Dr. Neelam.
Thank you.
Thank
so
you,
cheers to the fetus and happy Diwali to all of you.
Yes, happy Diwali to all.
Happy Diwali in advance.
Happy Diwali and a prosperous New Year.
Thank you so much, sir.
Happy Diwali, Raju sir.
Okay. Thank you.
Thank you. And be happy, be safe.
Thank you. Happy Diwali, everyone.
Bye-bye, everyone.
God bless.
Chalo, are we offline now?
1 second.